check one. हेलो हेलो, नहीं आ रहा? ऑडियो नहीं जा रही भाई। जूम पा रही ना उसमें, उनके उसमें यूट्यूब पर तो जा रही है। हेलो, करण का। हेलो, तू बोलिए अपने माइक पे। हेलो, नहीं तो यार। हाँ वो आज सब आ रही है। हाँ हाँ, दिल तेरे पीछे लाइट करण का ही है ना। हाँ जल तो रही पीछे लाइट, दोनों की लाइट जल रही। हेलो करण, करण क्या हुआ? तो दे तो रखी यहाँ से दे तो रखी है। तू बोलिए वहां से माइक में। नहीं तेरी भी नहीं आ रही, तेरी भी नहीं आ रही। वीडियो तो आ रहा है। हाँ बोल, आवाज तेरी तो आ गई। हेलो, इसको हटा भाई यहाँ से, मैं लिख। आवाज भी दबगी फटी फटी आ रही है। उस टाइम क्लियर आ रही थी। कैमरा कैमरा तो आ रहा तेरा, नहीं आ रही है, नहीं आ रही, फटी फटी आवाज आ रही थी अभी आ भी रही थी। म्यूजिक बंद कर दो। नहीं आ रही, अब चलेगी। अभी आ रही थी, चलेगी। नहीं 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 आ रही, अभी आ रही थी वो भी चलेगी। कोई बात नहीं ना, नहीं आ रही, नहीं आ रही, नहीं आ रही यार। हाँ आया, हाँ आया, बोलो फिर चलेगी। आ रही चलेगी, पता नहीं। नहीं दब रही है आवाज, बहुत आ रही है, नहीं आ रही है।
जूम में आ रहा है भाई, जूम होना क्यों चेक कर रहे हो? जूम में आ रहा है।
जूम, जूम में क्यों आ रहा है? जूम में नहीं आना चाहिए ना, जूम में आ रहा है।
अभी नहीं आ रहा है, अब नहीं आ रहा।
अरे नहीं आ रहा ना तेरी
पहले आ
आवाज।
रहा था जूम में।
है नहीं आ रहा ना तेरा, उसमें नहीं आ रहा, बाहर हमारे उसमें नहीं आ रहा, नहीं आ रहा। फटी फटी आ रही है, अब आई फिर चलेगी। पता नहीं, छोड़ रहा हूँ। फट रही है, बिल्कुल फट रही है, फट गई है, एकदम फट रही है। बंद होगी अब तो, बंद हो गई, नहीं बंद हो गई, बहुत बंद होगी, फट रही है। फट रही है आवाज एकदम। दिन में तो सुबह तो क्लियर थी। नहीं नहीं नहीं, बहुत फट रही है।
जूम का कैमरा ऑन कर दो अपना।
आवाज फट रही है, भारी फट रही है, बंदी होगी अब आ गई, फट रही है, फट रही ना, फिर चलेगी, बंद हो गई। आ रही जा रही है, बंद हो गई।
तार हिलाने के लिए बोलो, तार हिला के देखेंगे।
नहीं नहीं नहीं, बिल्कुल फट रही है और दब रही है। हमारा चैनल क्या चेंज करो, चैनल चेंज करके देखेंगे।
चैनल नया मिक्स है।
अपना चेंज करो ना, नहीं आ रहा है अब तो सही है। नहीं आ रहा। चले गया, आ ही नहीं रहा, आवाज ही नहीं आ रही। कभी आ रही तो बंद हो जा रही है, आ रही बंद हो जा रही, फट रही है। नहीं 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 आ रही। बिल्कुल फट रही, जैसे वो होता है ना, एकदम फट रही है, बिल्कुल दब जा रही है आवाज जैसे। नहीं ठीक, हेलो
चेक हेलो।
ठीक है आपकी, ठीक है ठीक है ठीक है आपकी, ठीक है। करण की आई नहीं रही।
करण की नहीं आ रही।
पता नहीं क्या लास्ट मिनट में पता नहीं क्या इंटरव्यू करता है, अब शुरू होने वाला है। पता नहीं, हम चेक कर रहे हैं। आपका तो ठीक है कीजिए, जूम का तो अभी जूम का भी नहीं खोला था ना। तुम्हारा जूम चल रहा है वहाँ से, तुम्हारे हॉल से चल रहा है जूम, तुम्हारे तुम्हारे नहीं जूम, पता नहीं करता है क्या होता है। जूम तो है, बैक बैक करना तो है। यार मेरा यार भी करता ना, उसमें पता नहीं क्या करता है। हाँ हाँ है? नहीं आ रही तुम्हारी, यहाँ से आ रही है, हमारे पास आ रही है ना, ना पता नहीं, वहाँ से मुझे नहीं चला रहा। हम क्या करें बता, वहाँ मनी मंडी में सब जा रहा है, यहाँ सब कुछ आ रहा है, वीडियो आ रहा है, वो तार भी सही है, बिल्कुल लाइट जल रही है ना, ना आ रही। उसको ओ, हाँ हाँ भाई, यहाँ देख रहे हैं, दिख जाएगा बताना। वोटिंग वाला चेक किया था तुमने? फाइबर वाले बुलाऊं? दो नंबर को हाँ एक नंबर को लगा रहा हूँ ना, ठीक है चलेगा। हाँ, उसको पकड़ना है यहाँ से, आगे आगे आशीष जी आगे, आपकी ऑडियो नहीं आ रही है, जाली ना आ रही है, मैं चेक कर रहा हूँ। बोलना जरा।
हेलो, बोलना। वही सेम सेम प्रॉब्लम है, सेम वैसे ऐसे ही यार, वैसे ही फट रही है
हमारी आ रही है?
मेरी। हेलो चेक 1 2। हमारी भी नहीं आ रही।
हमारे उधर से। अरे यार, एक नंबर की तार लगा दी मैंने। एक नंबर तार लगा तो दिया। और रोड कौन सा ऑक्स है कि नहीं? आए नहीं सर। ऑक्स है किससे?
ऑक्स से दे रखा है।
ऑक्स से दे रहा है। आजा। एक नंबर पे है। दो नंबर एक दो नंबर पे। फर्स्ट क्लास आ रहा है। एक बंद करना।
इसकी करंट क्या है सर? एक मिनट, करंट की साइड, करंट की दिक्कत पता नहीं क्या होगा, अभी तो चेक किया।
बोल को लगाना। बोल।
चेक आप देखना।
आ रही है?
आ रही आ रही है, लेकिन वही फट रही है।
दब रही है आवाज तेरी।
बोलते बोलते बैठ जा रही होगी।
नहीं आ रही तेरी आवाज।
हेलो चेक, मेरी पहुंच रही है।
शुरू होने वाला है यार यहाँ पे। नहीं आ रही तेरी आवाज। आ रही फट रही हो। आ तो रही, कभी आ रही ऑटोमेटिक बंद हो जा रही है।
यार चैनल चैनल अपना चैनल एक बार आप ही चेंज करो ना।
दो नंबर में फर्स्ट क्लास सिग्नल आ रहा है।
तो अभी तो टेस्ट किया था,
कितना माइनस कितना माइनस? हाँ कुछ क्या माइनस 4 आ रहा है। वीडियो के चक्कर में कुछ किया उसने। माइनस 4 ही आ रहा है। वीडियो भी दो नंबर तक चलता है। फाइबर भी चेंज कर लिया अब तो। आपके वहाँ कोई
चेक
वहाँ
1 2।
पे कोई कोड का इशू है। फाइबर पर दिमाग मत लड़ाओ। हाँ वीडियो आ गया। वीडियो आ गया ना? हाँ ऑडियो में कोई कोड इधर से यहाँ से भी तो ऑडियो नहीं जा रहा है। नहीं देखने जा रहा हूँ क्या वहाँ का उसका मिक्सर तो क्या प्रॉब्लम है। इसमें वीडियो दोनों तरफ से लेके देख लिया। फाइबर ओके है मतलब। और -4 मैंने मीटर पे नाप लिया। अब आप और पूरन जी अपने अपने टेबल पे संभालो क्या फोन। हेलो ये तो नहीं आ रहा ना भाई। नहीं आ रहा भाई। नहीं आ रहा। वो खुला है इनका वहाँ से?
हाँ भाई चेक करा रहा हूँ वही।
अरे यहाँ वहाँ से खुला है उसका ऑडियो?
हाँ खुला है।
नहीं आ रहा
नहीं यार,
है। हाँ ऑन वन एक नंबर लगा दिया। आर एक्स में मैंने एक नंबर। दो नंबर वीडियो में लगा। हाँ एक ही, हाँ एक एक पर दो। नहीं आ रहा। दो नंबर पे करूँ पहले जैसा? दो नंबर पे करूँ? ऑडियो 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 एक्सएलआर एक्सएलआर एक्सएलआर। इनको म्यूट करना।
म्यूट है,
म्यूट करो।
म्यूट है।
कुछ छेड़खानी करी थी क्या वहाँ जाके? शुरू से सही चल रहा था।
अभी आधा घंटा पहले भी तो चेक किए थे।
किसने किसने छेड़खानी करी? चल बोलना।
हेलो
मैंने चेंज किया वो
हेलो,
जगह चेंज करी। दो नंबर में लगा दिया दोनों। इनकी
आ रही है। हेलो चेक 1 2। हेलो हेलो
नहीं
हेलो
आ रहा।
हेलो।
नहीं आ रहा।
तेरे पास भी नहीं आ रहा, कुछ भी नहीं, आना जाना बंद हो गया।
नहीं आ रहा। आ ही नहीं रहा भाई। नहीं आ रहा।
देखो आ रहा है।
हाँ अब आया, बोल बोल।
हेलो।
आया।
फट रही है लेकिन
आवाज़ वही सेम है, फट रही है।
आवाज फट रही है। किसी और चैनल पे लगा के देखो। चल अभी कर लेते हैं। कौन सा है?
ये लास्ट में 24 नंबर है, 24 नंबर निकालो।
24 नंबर ही है।
हाँ, ये लास्ट में 24 नंबर है।
21 नंबर।
21 नंबर।
रुको रुको कर रहा हूँ, 21 नंबर खोलना। नहीं, चैनल भी चेंज कर लो। हाँ बोल।
फट रही है।
फट रही है आवाज, आ तो रही है आवाज फट। हाँ सेम प्रॉब्लम है यार, सेम प्रॉब्लम है, दब रही एकदम फटते फटते चली जा रही है।
हेलो 1 2 चेक चेक चेक। हेलो हेलो।
लाल साहब की सही आ रही है, लाल साहब के पास किस कॉल आ रही है, चाहे मेरी या मेरी।
चेक 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 अभी। हेलो 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 हेलो।
फट रही है, फटते
हेलो
फटते चली
चेक
जा रही है,
1 2 हेलो।
फटते फटते हल्लो हल्लो करके दबते दबते चली जा रही है। उसकी कोई कोड खराब है, कोई चीज मिक्सर खराब है, मिक्सर दूसरा है, मिक्सर नहीं डायरेक्ट तो आनी चाहिए मिक्सर। दब रही है, बिल्कुल दब रही है।
चेक 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 चेक
नहीं
चेक।
दब रही है, दब रही है,
हेलो 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 हेलो।
दब रही है, फील कर रही है।
चेक ऑल है, चेक आ रही है, चेक क्लियर है ना?
हाँ क्लियर है।
ठीक,
वन
अब
ठीक
क्लियर।
ठीक।
हेलो चेक चेक हेलो 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 चेक 1 2
ये हेलो,
बोलो जूम पे।
फट रही है आवाज, फट रही है। हेलो, आराम
चेक
से,
चेक।
आराम से बोल, आराम से। हाँ
हेलो
बोल,
हेलो हेलो
हाँ बोल।
हेलो
जूम का ठीक है, बोल बोल, बोलते रहो।
हेलो।
मेरी आ रही है? मेरी नहीं आ रही है? मेरी आवाज नहीं आ रही भाई, वहाँ जूम की भी। हेलो, आ गई? चल ठीक है, मेरी आ रही है ना, जूम की आ रही है ना। और ये तुम्हारी बोलना, बोलो बोलो, माइक पे बोलो।
चेक 1 2। हेलो
हाँ
हेलो
ठीक है,
हेलो।
ठीक है ठीक है, इसका बेसिस थोड़ा कम करो, कम करो थोड़ा हल्का। ये क्यों खोल रखे इसमें?
कुछ चला के छोड़ दो।
चला रखा है, लो। ये म्यूजिक आ रहा है?
नहीं
नहीं आ रहा म्यूजिक?
नहीं।
किस में दिया तुमने? ऑक्स किस में दे रखा? 5 नंबर ऑक्स खोलना, ऑक्स खोलना और खोल देना यार, तू शर्मा क्यों रहा है? हेलो, अब आया म्यूजिक? आ रहा है? हेलो,
नहीं आ रहा नहीं आ रहा।
माइक आ रहा है?
माइक तो आ रहा है, तभी तो मैं जवाब दे रहा हूँ।
म्यूजिक नहीं आ रहा?
नहीं।
5 नंबर है ना? तूने क्या दे रखा है इसमें? क्या दे रखा है इसमें? क्या दे रखा है? कुछ नहीं होता ब्लास्ट। क्या दे रखा है इसमें? क्या दे रखा है? अच्छा मॉनिटर दे रहा हूँ, मॉनिटर। हेलो,
हेलो।
हाँ आया?
नहीं।
5 नंबर, 5 नंबर, 5 नंबर, 5 नंबर, 5 नंबर, म्यूजिक का 5 नंबर। हाँ पोडियम का 5 नंबर, पोडियम पोडियम। अरे म्यूजिक चल भाई, यहाँ पे स्टार्ट हो रहा है, मैं जा रहा हूँ अपने साइड पे।
ठीक है।
पूरन जी
अरे मेरे को पूरन जी जरा उसमें
नहीं फोन है क्या
इस लैपटॉप को उसमें देना, इस लैपटॉप को उसमें देना, मेरे को देखना है वहाँ पे देना, ये वाला लैपटॉप देना, ये वाला देना, मेरा वाला। हाँ एक मिनट देना देना, मैं उस यहाँ से वहाँ देख रहा हूँ ना।
all, I ask everyone to be please seated. Shamika ma'am, please be seated. It is an immense pleasure to welcome all of you for this exclusive scientific meeting, which is film-based, followed by live surgery, and to share their experiences and all. All of the stalwarts of India are there to share their experiences and showcase their skills and fill us with their knowledge and interaction. So I'll hand over the mic to Rajneesh to give a brief about this conference and the model. Rajneesh, over to you.
I'm Dr. Rajneesh Sharma. I'll give you a brief introduction of the scientific program. This, I'll ask Dr. Mang to take over and start the session.
Yeah. For as per the Hindu tradition, अपने संस्कारों में है कि कोई भी काम अपन शुरू करते हैं तो गणेश जी महाराज को याद करके करें। तो मैं चाहूँगा कि गणेश वंदना प्ले की जाए।
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। गणपतये नमः। ॐ गणपतये नमः। ॐ गणपतये नमः। ॐ गणपतये।
So I would like to start the first session by inviting the panelists and the chairperson of the first session. I would like to invite Dr. D. Ramamurthy to chair this session. I think his flight was little delayed, so he will come in a while. I'll ask Professor Nepalia sir to please come on the dais. Welcome Nepalia sir. Dr. Pankaj Sharma sir. Dr. Rahul Sharda sir. Please be on stage. And Dr. Sandeep Vijay. Is he here? I'll be moderating the session. The first talk, for the first talk, I would like to invite Dr. Viren Agarwal for IOL exchange tips and tricks. So welcome, Virendra sir.
Thank you, ma'am. And I must congratulate Dr. Sonu Goyal and the Jaipur Film Society.
As of the companion of the service, we are now here. I will request Anand to come on the stage. And I request Nalini madam, Nalini Sen ma'am to come on the stage, please.
Thank you, ma'am. And I must congratulate Dr. Sonu Goyal and the Jaipur Film Society for organizing a very good scientific piece covering almost all for the ophthalmology in a very short and crisp manner. But the talks are very elaborated for the learning of the daily practice. So, may I start now? The IOL exchange is required for many of the regions, and you all must be facing there are times when you need to change the IOL, maybe a wrong power, not very common nowadays. Damage implant during the implantation, sometimes it gets stuck into the cartridge or in the injector. There are many other reasons also. But the thing is that we need to learn how to do the exchange of IOLs and when to do. There are different varieties. I am going to show you different techniques. There are some controversial, some are in common use. The most important thing is that you should always take care to protect the endothelium and the posterior capsule, because that is anterior and posterior of the lens. These two are very sensitive tissues, and if get damaged, then your IOL exchange may not get the desired result just by exchanging the IOL. The cornea needs to remain clear, and the posterior capsule should be protected if it is already damaged. There are different ways. In this case, the wrong IOL power was the main reason, and because of this, the IOL need to be exchanged immediately. This was a high power IOL, and IC was very shallow, but we wanted to protect the posterior capsule by implanting the IOL as a scaffold we do in cases where there is a posterior capsule rent. There are controversies, but there are times when I prefer doing this, that the IOL is implanted in the posterior capsule is now safe. And now use the converting sulfate and other viscoelastics, whatever is your choice, but preferably to cover the endothelium in a protective manner and create a gap between the IOL and the cornea, and then you hold and you can cut. The scissor need to be sharp. I am not very happy with the present scissor I am using, but I am looking for something which is better, because it should get cut in one go, then it is good and safe. You have to take out the haptic first, hold, and then you can roll out like a tire mechanism in which you keep rolling. And the hold should be firm. You can use tooth forceps sometime to hold the IOL, because it gets slipped with the McPherson kind of forceps. And 2/3 of the cut in the optics is enough to take it out from the almost 3 mm incision. And at the end you need to take care of the sections or openings you made. Now there is another technique in which you can remove. This case actually patient required a toric lens, but somehow he went away. The primary surgery, I advised him for toric lens, he went away and got a surgery done somewhere else. Unfortunately, the one haptic was in the back, another haptic was outside the back. Patient came to me almost 6 months later. Because of this tilt in the IOL, he was not getting the crisp vision, even with the cylindrical glasses. So, though it was 6 months plus, we decided that we will try to open the bag. And luckily, we could open the bag in majority of the places. At some place, it was very difficult. At some place, it was an ease. So, after dissecting it out the whole bag, we thought that we can implant the toric lens, and that is how we thought, and we succeeded in this case. Again, the same technique. You protect the anterior and posterior of the lens, that is the endothelium and the posterior capsule. And after cutting the IOL to 2/3 or 2/3 plus in the optics, by holding the haptic here, I am tiring it out hand in hand, and then after removing this IOL, in this case we wanted to give him good vision, and there was a plaque you can see in the posterior capsule. So we tried to peel it off, and we were lucky that we could peel off that plaque in toto. And you can see the difference in the glow happening from the area where it is peeled off and from where it is remaining. Here it was a fibrous kind of thing, so we just used the scissor to cut it off. We did the posterior capsule polishing also, because some of the fibers were there. And this is the special trick I do where there is a more of fibrous kind of tissue that I hold with the vacuum in a just pinch like manner, and these fibers gets released. And at the end, we implanted the toric lens in this case, and patient achieved good vision. The bag was not, the rexis was slightly bigger, but still we achieved the centered IOL placement for the toric lens. In this case, already the posterior capsular rent was there. And this is a risky and tricky situation because vitreous keep coming, and here if you cut the lens or pieces in between, it can have a fall also. Or the whole IOL can also fall in the posterior chamber, and then you require to have the help of vitreoretinal surgeon. So again, hold it firmly, cut it, and then you remove. The trick remains the same. You have to hold, you have to cut, and then you have to remove. So IOL exchange is the need of the hour, and it will be required more and more often because now patients want emetropia. Preferably, whenever there is a refractive error less than 1 diopter, you should never ever even just give the idea to the patient because otherwise it will start demanding. But whenever there is a good refractive surprise and you need to do, you should know how to do exchange. At the end, you need to take care that the vitreous should not be in the anterior chamber. And here, the back, I am seeing that how much is the sulcus. If sulcus looks good, the rexis is intact, then we can implant a 3-piece IOL after removing the 1-piece IOL. And 3-piece IOL is a very big savior in these kind of patients. So by holding the haptic with the forceps like we do in Yamane, we can put it placed in a right place. Otherwise, when you just want to slide it out from the anterior to posterior chamber, it sometimes goes behind the capsule and then IOL will start getting dipping into the vitreous cavity. Thank you very much. If there are any questions, I will be happy to answer.
Dr. Virendra, what is your experience with tricot assisted anterior vitrectomy, pros and cons?
Sir, if you don't use tricot, then it will be very difficult to find out where all the vitreous is there. You may remove almost 80-90% vitreous without use of tricot, but some part of vitreous will remain in the chamber. So tricot is very useful. Very rarely tricot can give steroid response kind of glaucoma. But if you use diluted tricot and at the end you do complete vitrectomy, usually most of the tricot is removed with the cutter and vitreous.
That what are coming to? A few reports about secondary glaucoma using tricot for anterior vitrectomy. So
no,
what?
I've never seen ever.
You are not encountered. Sir, anything would you like to add?
I completely agree with what Dr. Virendra is saying. I think in today's world, we have to use tricot if you have a vitreous loss, and it's important that we use a diluted tricot. The problems of IOP rays and all comes in when enough tricot goes into the vitreous cavity, that too undiluted. But if you are using in 1 in 10 dilution, usually only strands are there. 1:10. Oh, yeah. Huh? Yeah, rest would be 1:5 to 1:10 is what is recommended.
And sometimes
there is a little echo. Can the echo be reduced? The mic is having a lot of echo. At least on the stage we are getting an echo.
And second thing, sir, if this tricot goes in the posterior chamber, then you can use a Pascal approach and remove most of the vitreous. Then the tricot will also come along with the vitreous. So it will not remain significantly, but sometimes those who are having high response to the steroids, they can develop it. But I think it will also be a short-lived.
Leaving behind a little bit of tricot is also fine. It's a complicated surgery and it will help in arresting the inflammation.
Actually, it will help in reducing the post-op inflammation also.
Only for the glaucoma part.
Yeah.
But inflammation it is very.
So, is there any standard for dilution? Is it 1:1, 1:5? Yeah.
Sir, in all these patients, definitely we may be using dispersive viscoelastic to protect the endothelium. Would you recommend doing a specular biomicroscopy in these patients before you take up for IOL exchange?
Yeah. All the patients, whenever you go for second surgery, specular count should be taken.
Yeah, and the gut
you don't know what was the issue in the primary surgery.
Exactly.
It may be already low count before the primary surgery, or during some complication. It can again go for a very low count. So it is reduced. Right now we are having one patient in which IOL have one haptic is coming in anterior chamber again and again. It is a single piece IOL. And haptic comes into the anterior chamber. For 2 times we have done reposition. Patient is asking for exchange, but we are not attempting because the count is just 1100. So such situations are there.
How long would you wait if everything is okay between an IOL exchange and the primary implantation? What time gap would you like to give?
No, if it is because of wrong power, it should be done kind of immediately. Suppose you come to know that you wanted to implant an 18, now it is 8 or 28 by any mistake. Then you need to exchange because there is no other option to treat it. But otherwise, why you want to exchange? That is the main reason of delay or doing the early surgery. If it is causing some...
to wait.
How long? General criteria.
Sir, any experience of explanting or replacing the IOL, those multifocal and trifocal IOLs for the patient dissatisfaction like glare, halos, or the patient is unhappy? Do you have any experience of that?
Luckily, till now, I have not explanted any multifocal lens since last 26 years. For the reason, because beforehand, patient should know that he or she will have glare, one, and try to convince him that the glare, what you are right now saying as a complaint, the moment I remove it, when you will lose near vision, you will say that I wanted that. And then I will not do it, repeat. So by this, usually they settle down. And even I implanted the patients who are having, now we have refractive lenses. The refractive lenses also the patient donated after some time.
I would like Dr. Ramamurthy to present the certificate to Viren Agrawal sir. Now, moving on, I would like Dr. Saurav Luthra for the second talk, phaco in phacomorphic glaucoma. Oh, his flight is delayed, so he'll be presenting this talk later. I'll ask Dr. Anaga Harur to speak on challenging the challenge.
A very good afternoon to all of you. Thank you so much, Anand Hospital and Jaipur Ophthalmological Society for having me here. And we have had a very nice discussion in the morning also. Why is it switching off? Just a minute. Switch off क्यों? अच्छा, So this is a very challenging case. Face to face with certain challenges. 65-year-old gentleman who came to us with history of blurred vision in one eye, and you can see it's not just an inflammation. pressure. So we went ahead and decided to do an AGV implant. So this was the AGV implant that we planned because we thought that this would give us a more controlled reduction in IOP. So meters away from the limbus and the stay suture with 8 cm. Partial thickness clear and flap was done. It was made by 23 gauge needle, and the tip of the AGV after it was put in was a stay suture and the partial thickness flap was then sutured and the conjunctiva also was closed. So we thought that hopefully now that the pressure would reduce and we would give the patient a second chance to see. We knew that the eye was not very clear and as the cataract was out, and if we are able to control the pressures, we would give him the best chance. Pressures remain 10 to 14, the vision improved to 6/60 and problem started. So when obstacles arise, you change your direction to reach the goal. Do not change.
Madam, what was the preoperative status of intraocular pressure, and could you go for angle evaluation, or it was not possible because of hazy cornea and all that?
There was no angle at all. You saw the ASOCT, sir. So it was totally, the iris was totally plastered to the cornea everywhere and the pupil was fixed. So there was no question of angle. That's why we did an ASOCT. USGB scan was normal. PLPR was good. That is why we went ahead. We thought we would probably just leave the patient alone because we didn't know what would happen on table with the pressures of 40 not coming down at all. We gave the patient a very severe guarded prognosis, but at the end, as the vision improved to 6/60, he said that I can actually see this side, even if he is not able to read, but at least that side field of vision was improved. So he was very happy at the end of
Do you think occlusal pupilli was also responsible for preoperative rise in intraocular pressure, along with the obliterated angle?
It was. That is why we did an iridectomy, but we thought doing a YAG PI before, we thought of that also. But because the media was so hazy, lot of iris pigment, we thought we would probably initiate more inflammation, what was already there. So there was no other way, we thought, which would give us the best result.
And why are you apprehensive about post-operative subluxation of the IOL?
No, sir, that we had not expected. This was incidental finding. So when we were doing the the capsular axis also, I saw that there was a little donesis. So I knew that maybe the zonules were weak. Then phaco, we thought at any point of time it might just, drop. But fortunately the phaco, we were very careful at each step. Phaco went off fine, irrigation aspiration, fortunately cortex was not much because it was a mature cataract. But when we were doing the IOL implantation, then I could see that there were little folds on the capsular edge also. And we knew that it could, we didn't want to take a chance. Since everything had went off so well, that's why we put in a CTR.
Any extra post-operative reaction in this case?
No,
or
fortunately
it went
was very
flawless?
good, except for the pressures. So we put him on steroids. So first we put him on prednisolone because we knew that so much of pigment dispersion and inflammation would be there. Even pre-op we had put him on low-dose steroids. But post-operatively, when the pressure started shooting up after the 7th day, we thought maybe he's a steroid responder, so we reduced the dose of steroids, shifted him on loteprednol. But the pressure and maximum medical therapy, but the pressures didn't reduce at all. So we had to, now that the vision had improved a little bit, we had more chances that if we keep the pressure under control, at least his optic nerve would be saved. So we had to do something to keep the pressure low, and trap would probably be a bigger risk because there's a sudden decompression, when you open the eye, and that could cause a suprachoroidal hemorrhage. So we decided to do an AGV.
So compliments for meeting such a challenge in a very, meticulous way. It was just like doing NATO. Thank you.
Thank you, sir.
Dr. Anaga, any possibility of neovascularization in this case because the pressures were not coming even with the maximum tolerable therapy?
It was not there. We were ready for, we told him everything, right from there could be a bleed, we would have to leave it alone. But fortunately there was no bleeding. And we told the patient, why did you wait so long? So actually he could not come to the hospital. He was stuck somewhere and there were some problems and he could not reach the hospital and he was having some other personal issues. So he's an educated patient. He said, I know I have come very late. And post-operatively when vision improved, he said, I had no hopes at all. I knew I had lost the eye, but at least now 660 vision for him was a very big thing.
Thank you.
I think very nicely managed, Anaga, a very difficult situation. Just to give a difference of opinion, a few points. One is that when the chamber was almost absolutely flat and the iris was stuck to the back of the cornea, do you think not just momentarily at that point of time, doing a limited anterior vitrectomy as a primary procedure would have created a little more space for you to...
So that's why we put in the port, and what happened was we wanted to do a vitrectomy. Actually that was a little edited also. We did a little bit, but even when that blob of vitreous came up, the pressure reduced. But what happened was, initially what my VR did, he removed it. So you saw that we reinserted. The moment he removed it, then as I was trying to do put in the iris hooks, the pressure again started building up. So then I told him, don't remove it at all, put it. But then if it was kept inside, then that could have caused more problems because of the vitreous. That's why we put in the plug. So we did a little bit of anterior vitrectomy.
Usually we do anterior vitrectomy to reduce the pressure during the time of surgery. I am talking about removing a significant amount of vitreous by doing a proper vitrectomy, more to create a little more space in a case where the angle chamber is almost totally flat. The other thing is that, you managed very well, very difficult capsular access, everything was done. In case it's more for the sake of the audience, in case you have to put an endocapsular ring, it's always a good idea to put it before you place the intraocular lens, especially with a large hydrophobic single piece lens. Sometimes the lens itself tends to tilt and unzip whatever zonular support is there. And so that's the reason that when you're suspecting that there is a little zonular weakness, maybe it's a good idea to put the endocapsular ring and then place the intraocular lens. But of course, she managed very well. The other thing is when you're having problems like this and preoperatively it was already zipped up, why not do a phacotrabeculectomy in the first place itself?
I agree, sir, but with the pressure so high, we didn't want to do multiple procedures at one time. Already the prognosis was very poor, the pressures were very high. So we thought maybe there would be a very high chance that the trap would fail if we do everything at one time. We were not sure about how this would go at all. So we thought we would go one step at a time, and I had not touched the conjunctiva anyways. So it was a pristine conjunctiva. We could have done a trap at any point of time, which we had given the idea to the patient that the pressures we will have to monitor. There is a very high chance that it will rise, and it did within a week after the surgery.
Very well managed.
One more query. Do you think reduction of intralentricular pressure preoperatively, either with a YAG capsulotomy or in peroperative small punches in the anterior capsule, might have helped
so
a bit more?
The pressures were very high, sir. So I didn't want to do anything which would further increase, and I didn't know whether, it was plastered and this condition was there for 1 month. By doing that, we would not be able to make the anterior chamber anyways. But we would preclude the next step of actually doing capsulotomy on table, because visibility would have become impaired when I actually went on table. If I did a YAG, then if there was a fluid, then it was not actually fluid. If you saw, there were more of hydrated cortical fibers. But suppose there was fluid, that would have come, and whatever little visibility I had, it would have obliterated that. So I thought it's best to do it on table.
Thank you, Dr. Anuga, for a wonderful presentation. I would like to ask Dr. L.K. Nepalia, sir, to present the set. Now I'd like to ask Namrata ma'am to come on the dais and deliver his talk on biosynthetic cornea. Welcome, ma'am.
Thank you so much, ma'am. I would like to thank Dr. Sonu Goel for this wonderful conference today, and I would be talking to you about biosynthetic cornea. Now, as we all know, in India, if you look at the corneal opacity, it is only second to the cataract as far as the blindness is concerned, and in less than 50 years, it is the commonest cause of blindness in our country. So we do require a lot of corneas, and there's a huge disparity between what we need and what we actually have. And if you have episodes like COVID, then the transplants and the collection drops down to the tune of 80%. And even in the post-COVID era, we have not come up to where we had started in the pre-COVID era. So there is a need for biosynthetic cornea, because you cannot depend only on human donor corneas, because they are not there available in sufficient numbers. Now, this is something that we've been working on. It is a clinical grade collagen type 1 biosynthetic cornea. We call it bioengineered porcine construct double crosslink. And this is using double cross-linking agents, so you don't actually have to cross-link it. It is available in 12 millimeters diameter in thickness, 100 to 500 microns it is there, and the shelf life in the bottle is 2 years, and the studies that we've now done are close to 6+ years. It has gone through all the quality check, the various procedures that are required in vivo, ex vivo, in the laboratory as well as in the animal models. The light transmission is similar to that of the normal cornea. The collagen fibrils are also quite tightly packed, and the fibrils are slightly thicker than that of the normal human cornea. Now, the epithelial adhesion is better than the normal human cornea when we compare it with the control, and these are the animal trials which have already been done with this, which shows the pachymetry, ASOCT, as well as the ConfoScan pictures. And these are the animal studies which again have been done with this. Essentially, this is the biosynthetic cornea, which is acellular structure, as opposed to a corneal transplant that you do in the animal eyes, which would have some amount of cells. So this is how it is done. A pocket is created with the help of the femtosecond laser, and so much so that the residual bed thickness is 120 microns or more. This pocket is then opened up. The biosynthetic cornea is then taken, which looks pretty much like a contact lens, a soft contact lens. It is trephonated depending upon what the pocket is, and this is folded and is then placed intrastomally inside. And subsequently, the bandage contact lens is placed over it. So you don't have to put any sutures. So this is in the post-op period. There's some amount of corneal edema which does subside. Now this is a case of keratoconus with pellucid marginal degeneration where thinning is present in the periphery. And this is a case in which cataract is also there. So first the cornea is addressed and a pocket is created which goes right up to the periphery, because the thinning is there right up to the periphery, again keeping that buffer of 120 microns as the residual bed. And subsequently the biosynthetic cornea is taken and then is implanted intrastromally in the pocket that was previously created. And in this case there was also cataract, so 3 months down the line the cataract surgery was also done, and notice that it is quite clear, and it is possible to do cataract surgery through it. This is again the post-op picture. This is a third case of keratoconus again which was very steep, and again for which biosynthetic cornea was done, and Kmax decreased from 85 to 57.1 diopter in this case. This is how it looks like. This is our oldest case, so all that you can see is the rim of the biosynthetic cornea that is present. Now this is a case of post-LASIK ectasia in which again the flap was elevated just like you would for any LASIK flap when you do correct the residual error. The pocket peripherally was reinforced, and notice that the residual bed is so thin, that is why possibly the ectasia occurred. And then subsequently this biosynthetic cornea is placed, and again notice the thinned out bed that is there. And then in this case we put the sutures also because the flap was edematous, and if you put the sutures then the biosynthetic cornea gets sandwiched intrastomally. So this is the post-op picture. Kmax decreased from 89 to 50 and pachymetry increased from 240 to 581. Again, in cases like this where you have opacities, you cannot do femtosecond laser. So you have to use a microkeratome or manually dissect, followed by again placement of the biosynthetic cornea. Now here it is placed only anteriorly and then subsequently it is glued all around, followed by a bandage contact lens application. This is the post-op picture that is there. We've done it now in 50 plus eyes and there have been no rejection, inflammation, vascularization or scarring. And decrease in Kmax was sufficiently seen to more than tune of 11 diopters with the best corrected visual acuity of 6.9, 95% of the cases at 48 months. Confocal scan, you can see the nerves as well as the endothelial cells, and possibly you may not need the media, the laminar flow hood as well as the eye bank in future. So this is feasible, it is safe, it is not dependent on human donation, no graft rejection, no suture related problems, no eye bank facilities required. It does not preclude a human transplant if required, and now we are even growing endothelial cells on this to get a complete corneal construct, and this is our project which has been sanctioned by ICMR. This is the publication that we came out with. It was published in Nature Biotechnology with an impact factor of 68.1. And to conclude, we do require longer follow-up in larger number of cases, but this is feasible, safe and simple technique. So possibly just like for IOLs, you would just have to open the bottle, take the biosynthetic cornea and use it, and I hope that does become a reality in the near future. I would like to acknowledge Dr. Mehrdad Rafat and Dr. Mahmoud Jabarwand. Dr. Mehrdad Rafat from Sweden is our Swedish collaborator, and the second site where these trials were done was Iran under Dr. Mahmoud Jabarwand. Thank you very much for your kind attention.
Congratulations, ma'am, for such an excellent pilot study. We are also proud of you. One question about the thing. Before doing this, were we doing C3R linkage on the keratoconus patients, or it was done without a C3R?
So some of the initial cases that were done were not cross-linked. No cross-linking was done because at that time we were taking native corneas. But now we are also using it in cross-linked corneas. It is a little difficult to get the pocket, but it is not, I mean, slightly more difficult than in virgin corneas.
Do you think every case of keratoconus should be considered for this, or those who are not responding to corneal cross-linking, and where you think about other options like piggyback contact lenses or deep anterior lamellar keratoplasty likewise?
So sir, I wouldn't think, I always feel corneal transplantation is the last resort for all keratoconus patients because that is where the story starts. But having said this, this form of corneal transplantation is less invasive. But then again, those cases which you are thinking you are going to take up for DAL, those cases this can be tried because this tectonically also stabilizes the cornea. And contact lens fitting, although not written here, becomes a lot more, it becomes better. Those patients who are contact lens intolerant became contact lens tolerant following the surgery also. So that is also one advantage of this. But yes, wherever rehabilitation is required or it happens with contact lenses, that should be our first move rather than doing a corneal transplant. But these were the cases whom I would have done DALC, but then we did this intrastomal keratoplasty. And of course, there should be no scarring, otherwise.
And ma'am, the power of the, were they specifically powered for individual? Plano. So did you find a change in refraction post-op, and was it going hyperopic? Or
it was
myopic?
going on the hyperopic side, but then hyperopic as compared to the previously myopic, but they are so myopic that they get better as you add tissue.
So it acted like a benefit to them.
You have very rightly highlighted that compared to demand, collection of corneas number is very poor. But I'm happy to share with you that Eye Bank Association of Rajasthan is doing wonderful work, and even our Ajmer chapter in terms of collection of corneas.
I know, I think I should congratulate you. EBSR has done enormous amount of work, and the best thing is that they are giving corneas to other surgeons who don't have access to corneas.
Any primary complications that you've noticed that you would like to highlight, like epithelial breakdown and all, like which was seen in 1990s when we started with the lenticules, human lenticules in the eyes?
So, like I said, you do have some amount of corneal edema in the initial post-op period. It takes about 7 days to subside. And in those cases where the corneas are very steep, there were some folds also which were present, because when that thing flattens the cornea, some folds tend to be there in the initial post-op period, again will disappear over a period of time.
And your post-op regimen of steroids would be
Post-op
for 2 weeks or something, or longer? 8 weeks. 8
weeks only, and then we stop steroids, which is again an advantage because you're not using steroids for a prolonged period of time.
Yeah. I'd request Dr. Rahul Sharda sir to present the certificate to Namrata ma'am. Now I'd like to invite our own Dr. Saurabh Bhargav for the next talk, whitewashing the white cataract.
Thank you, Dr. Sonu Goyal and Jaipur Ophthalmic Society for inviting me on this podium. I'm going to talk about whitewashing the white cataracts. We all know that white cataracts are a greater challenge to cataract surgeons. There is a greater risk of PC rupture, endothelial cell loss, incision-related complications like wound burn, rhexis extension, and zonular diastema. And all this occurs so fast that you're literally helpless. Now I've divided white cataracts into three types: white intumescent, white, and the white not so white. That is the harder cataracts. Now basically, white intumescent cataracts have two variants. The one on your left, that is the brownish one, is where you have areas of liquid cortex with islands of swollen cortex. So this is the benign version, and it rarely progresses to a rhexis extension. But on the other hand, the one on the right side is the one where the entire cortex is swollen. It's a tense cataract. You can feel it. It's tense and bouncy. And this is the one which is likely to progress and give you an Argentinian flag sign on the table. So here, in a white cataract, I need to highlight that the first and most important thing is the use of a trypan blue dye. Trypan blue not only stains the anterior capsule, but it also stiffens its character and makes it more compliant to your surgery, to your rhexis. So I follow the APDV rule. There are several methods of staining the capsule, but here first is the air, then is the Phenokin Plus, which is a cocktail of phenylephrine, xylocaine and tropicamide. Then comes your dye, and you not only instill the dye, you paint it over the surface, and then comes your heavy viscoelastic like sodium hyaluronate. Now, as far as the rhexis is concerned, I prefer the use of a micro trata. Here I am using the Haldi Purkar version, and you balance the centripetal and centrifugal forces. And also I've imprinted my rhexis onto the cornea with a rhexis marker, so I exactly know how to size my rhexis exactly, a 5 or 5 millimeter rhexis. Everybody admires Lionel Messi, but we cataract surgeons don't like the pattern of his t-shirt, especially when we are viewing it through the binoculars of our operating microscope. Now, this sign, can we actually prevent it? Is it preventable? Because it occurs in such a split second that the use of a heavy viscoelastic like sodium hyaluronate 1.4% or visco, the use of a 26 gauge needle to decompress the liquid cortex so that your anterior capsule becomes flattened, and also a perivulvar block. I know most of us are topical cataract surgeons and we do not use a block, but my message to you is that don't let ego come into this, because a block helps relax the intraocular muscles, the extraocular muscles, and also since the patient can't see, the patient will be, the eye will be stable and the chances of an eccentric rhexis are greatly reduced. So here I am demonstrating the use of a 26 gauge needle, and you can actually see the fluid cortex flowing from the periphery towards the center, and the end point is when your capsule is flattened or even concave. From here on, you can commence with your Aegis and grasp and re-grasp, and now it's basically like a routine Rexis because your capsule, your anterior capsule is flat, so there's no pressure, and the Rexis can be completed in a routine fashion. Now coming to the phaco part. So phaco in soft white cataracts is not an issue. Here I am delving with the harder cataracts, and here first I would like to highlight the parameters that I use. An IOP of 60, AFR of about 38, and a vacuum of up to 575. So these are relatively high parameters, and I do not step down the parameters till the end of surgery, contrary to what has been traditionally taught to us, that at the end, when you have a solitary piece, step down your parameters to protect the posterior capsule. Here, the intelligent phaco, the IP is used, which is nothing but a burst of 10 to 20 milliseconds of longitudinal power when 95% of the preset vacuum is achieved. Here again, I would like to highlight a technique which I use called the phaco tap technique, where I oscillate between foot switch position 3 and 2. To demonstrate that, I'll just show you another case which was slightly harder than this one. So one more thing, I'm a great fan of torsional phaco, but here you see torsional phaco is not helping me. The vacuum seal is not good, the tip is not embedding well, and the nucleus is rotating despite a vacuum of up to 600. So what I do is I switch off the torsional and go on to pure longitudinal. Here I switch to pure longitudinal. Now you see that the tip is bearing well, the hold is much better, and I am achieving an almost 95% chop. I don't expect to chop greater than this because of the already fragile capsule and zonules in such cases. So to initiate the first cut, that is the heminucleus, and the remaining chops, you can shut off your torsional and use pure longitudinal. Once you've created the pieces, then you can go back to your original parameters. Now coming to the phaco tap technique. Basically, phaco tap technique is nothing. Yes, here I would like to emphasize that use as much amount of viscoelastic as you can to protect your endothelium. The phaco tap technique, as you can see, my foot switch is oscillating between 3 and 2. So what happens is an adjunct to your IP. What happens is the moment you switch from 3 to 2, there's a micro reflux. This micro reflux does two things. One, it stabilizes your chamber further, and secondly, it declogs your tip. So the phaco fragments which are hard, which are just inside the tip, just move out and they are ready to be re-emulsified again. So this phaco tap technique enhances the efficiency of your surgery, it hastens your surgery, and despite all that, it helps you achieve pristine corneas on post-operative day 1. The evidence to this is in this graphic. You see, I had consumed almost 60% of the case in the nucleus, and my CDE was 13.1. But I've completed the case at 15.9. So just 2.9 units have been used, and the last pieces, which are the most critical, have been consumed effortlessly. Thank you so much for your kind attention.
Dr. Saurabh, did you encounter any problem during the whole procedure which might have compelled you to customize any particular step during the surgery?
Sir, routinely with every case,
I mean, how it different? What you have presented that we want to know.
With every case, you have to customize your parameters. So you have a set of panels, grade 1, grade 2, grade 3, and grade 4, and mainly the modulation has to be on the power side, because you can't use high power on a soft cataract and vice versa. So that we've done pre-operatively by seeing the basically sheet that we have, and intraoperatively also we can customize the parameters as to decrease the power or increase the power. as and when required.
Would you again highlight what was the logic of keeping all the parameters on the higher side throughout the surgery?
Yeah. So that's an excellent question. So that's something that I've gotten used to. When I started phaco, I used to use lower parameters like an AFR of maybe 20-24, vacuum of 300-350. But with my machine and in my hands, I feel that the efficiency, the speed, and your post-operative results, you have to think for yourself what you get best. So in my hands, I feel that a higher AFR does all the things faster. A power, obviously, you have to modulate. And IOP is not much. IOP in this machine, because it's through a compressed bag, so an IOP is very reasonable.
But any extra risk to the endothelium?
No, sir. That's what I'm trying to say. Though I don't have access to a specular microscope, but immediately after my surgery, I make my patients read, and on post-op day 1 also they have pristine corneas. So I believe what I'm doing is right.
Dr. Ramamurthy? Ma'am?
Sir, excellent presentation, sir. So for the capsulotomy, we also have other ways of doing it, like you can make a smaller excess initially, decompress the entire capsular bag, remove whatever possible superficial cortex, again flatten the anterior capsule, go in from the side port, then with a micro scissors you can just give a cut, tangential cut, and then you can take, or you can do it in a spiral pattern, yeah, if there is more controlled this thing.
Absolutely.
And another thing is a flax also in such cases, or as even a Zepto for all that matter.
But
Only for the
believe that it's the
capsulotomy.
surgeon above the machine.
Yes, absolutely.
And once you achieve the flat capsule, a baby rexis is generally not required, because that will you require another step.
But that gives you a very, very controlled
Yeah,
capsulotomy.
but you can observe the control while you're doing the surgery. Yeah. So if you feel that the centrifugal forces are more, you go for a baby rexis and later on extend it and do your.
Well, I think yes. Please. Excellent presentation. One thing I completely second is, the initial chopping being using just longitudinal phaco. So that's the way I've set my machine, and subsequently that's longitudinal phaco with the IP off. And when it comes to quadrant evacuation, it's torsional phaco with the IP on. Because when you do that, I think the kind of hole that you get on the nucleus is much better. Usually I make a small trench and then go into the center of the nucleus and get a good hold on it. It works very well. I think that's not something that I did till about 2 years back. But once I switched over to this, it works very well. Other parameters are fine. I'm sure you can also do it. I generally don't alter especially with this machine, don't alter my intraocular pressure beyond 30. That's just a port light of 41. And because of the various factors that are incorporated, I think you get a fairly stable anterior chamber even if you're using AFR of 550 or vacuum of 550 or even a 36.
But I believe you must be having the active sentry.
I do have the active sentry, but I switched over to this even before I incorporated that. And you mentioned it, and I've also highlighted the different ways of handling with the initial neck of the hypermature cataract. I think the very important factor is the initial opening that you do, whether it's a puncturexis or whether you go ahead and puncture with the needle, as Dr. Rajendra Prasad mentions, is that whatever the opening you make should be a little curvilinear. In the sense, if it's straight, the rexis is never going to run off in a curved fashion. It's only going to run off towards the poles of the nucleus. So if you make a straight cut, and because of the intralenticular pressure, there will always be a tendency for it to extend. But whatever you do, method you adapt, if the initial nick is a little curved, then the tendency for the rexis to run off to the periphery is very much under control. Other factors, I think, you have highlighted.
Yeah, boss, have you ever tried by an phaco probe to have the initial cut of these hard intumescent cataracts with the bevel down going and just give a snip so that it makes a baby rexis as well as it decompresses the entire nucleus also? Have you ever tried?
I have not tried this, but I have tried the yak shot previously, and it used to leak, So, but when I saw literature and I found that it's actually not helpful. and plus the time duration that will take. I mean, like, you might get delayed with your surgery, and that might create complications. So the thing that you are asking is, I have not tried that, and I tried the YAG thing, which I was very happy with, until I read some literature and I stopped it.
Okay, sir. Thank you, Saurabh sir. I would request Ramamurthy sir to present the, Dr. Anoga Harur to present the certificate, please. In the meantime, I would like to invite Dr. Anurag Mishra, our guest faculty from Cuttack, to present the next talk. Welcome, Dr. Anurag Mishra. He'll be speaking of white intumescent cataract management.
Right, thank you, Dr. Mayank. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Jagannath. Gratitude, Dr. Sonu, for inviting me to this wonderful meeting. I tried to pronounce this at home, hospital, do, di, festival, do, di, dance, something like that, for 25 times at home. And at the conclusion of the 25th occasion, my wife said, "You're good at nothing." And I don't understand the reason why people invite such stupid minds to their conferences. I hope by the end of this conference I would be able to pronounce it right. So just an extension of what Anaga and Dr. Saurabh have already spoken about, the whites and the categorizations of them. I would conglomerate 3 case scenarios and would like to speak on how it went in each one of these. Dr. Saurabh wonderfully categorized the 3 cataracts, the 3 types of white cataracts, the white in white, the white with a lot of pressure, and the white without white. That's exactly how these 3 case scenarios would be categorized as. The first case has a lot of intermittent and a lot of mid-peripheral fluid pockets. And as we proceed doing rhexis, even if you bend it just at the right time, it sometimes starts protruding, the liquid pocket starts protruding. I stopped there and tried to grab it with a pair of forceps to bring it back to the midline because I was apprehending the extension, but it extended the vein before it was any time. So I couldn't salvage it from there. I took the micro figures to produce a cut and rotate it from the opposite side while I was bending back, encapsulation, cutting, and getting the management back. Luckily, the section was so economically placed that the basic was not going to hit the area where it had extended. So it was slightly outlet. So I just extended the tip of the femur, which gave me some space to work with. And the other thing that happened was, which is to my last was the nucleus is not very large. And how you can take care that the business area is away from where the work extension is taking place. We saw cataract and then these fluid and taken out of the bag and continued this one. I do go ahead because of the over the side, so the internet multi-charge both the eye and consider the numbers like this. And now you can't leave the eye with such a small opening in the middle, so under cover of PSS, a small method to use the macro areas and then the macro surfaces. Rounded off to the perfectly round edge of the point where the transfer pad is maximally in its support, the active surface of the middle. It's not a toric eye, so you don't need to worry about where the active are. It is down place in the surface maximum support. The next is the intermittent cataract, which has a very shallow basin and a long, message of length. So able to figure out the justice properly. The cataract much harder to remove, much harder to remove. The parameters we have been independently. There has never been the ability to move towards contrary to the parameters of the book, which was studies back, I don't use the monitoring of at all. I think the height is so strong and the vacuum at which height is not taken is just at the bare minimum 90%. So the moment the taken is equal to the meter where the speed is into, the height is comes in and it gives to the lens to make it the running. So I believe the exploration and the building both to happen at the same time. This is good video. This is unlimited video. The speed at which it can move. The people is not also very large to start with, so we have to say that is the center of the eye, that is the grading for it. But all the doing is having a big observed wobbly captured by, which is very natural to get in such ability in cataract. So besides the grade into the PGR, which are the undercover created the banana, which show data when it comes to the later steps of the system, because there are a lot of things under the effect. CPR also goes in under the cover of beauty, which beautifully encloses the car, which means cover it all as regard is concerned. Manix goes into some chemically fired, chemical communication has steps to figure to much steps for relevant for us to chemically fired it. Had it been a pH work or a related out of, just out of implant and multiplication project and be able to develop the cataract, but since that is not there, it can be constantly going injecting under cover of the again. The third case is a typical people anaphylactic uveitis where the anaphylactic is more and that is found. You can see a murky viscous here because a lot of pockets have actually neatly to the viscous as it happens here. This particular question in these cases because we don't have any support of the cortex and it is very mobile and fine. But we have to go from multiple approaches. One possible work we necessary and margin ways. The sleep case is actually something that is funded and made vertical profit properly because how do you try? It's very difficult to support this so that you can stop and once you separate it completely, it's relatively easy. However, since the waves are always low, one has to keep in mind that the beauty suffers actually. It's stable into the anterior and in normal circumstances. And as I was eating away the nuclear pieces, towards the end of the first nucleus, I observed that I accidentally went in the first pieces was actually different. So this is very likely to happen, but because we in this particular case, any which way this pattern not happen as well, we just created a nucleus to clear out all the cortex that is running with this. So once that is done, and the two fragments which are uneven back to these surface, I did use the IOS to hold the people. When I use the IOS to hold, so first to start the whole IOS inside the back, because that makes the optic sit vestibular and gives you more space to hold it. No doubt you have to hold the individual all the time to refer to the scholastic, but I always ensure that the IOS goes right into the back, which gives you more space to work with and that much sharper of solid is coming in the middle. After I displaced the other two fragments I noticed that there is a small fragment that remains behind the cover of the iris. So I had to unearth it. So I put the iris with my second instrument and brought it out of the back and then continued it. So especially for next closing, clears out all the scholastic that has speak to the discussion on the cortex. Now this is much more clear. There is a possibility that these two things combined in post-operative period might again lead to a reaction in the scholastic. I could avoid doing a follow rejection and removing all the debris of the cortex and using scholastic around the head. So that's usually set of situations and we have to do that for the
Commissioner, two observations. One, I feel like that you are going for a larger size of CCC in this case or just conventional?
It's not seen properly in the oil field, but the second case is small. You have to come large, but if you do that in the very small way to be done. The third case, we couldn't see the vessel margin properly because the red globe is not very bright. This is murky because the cortex has been so you can see the margin is small. And if you do a larger restriction like this, the nucleus is something you don't have a particular facility, they are quite much difficult. This could be the smallest possible amount so that the nucleus can be very important part of the process. So case 1. No, it was not a magic except it is possibly bad for at least 15 minutes. There is time to make it this way. It was a false look. Yeah. Second case, maybe it was in a edited video, so we couldn't see proper unfolding of the IOL. As we had put it inside. Still, I mean, for that, second case. But it stays in the middle of the support form of the optic screen in between numbers. It's actually easier to put it to a smaller people because it stays there in just a little number. Quite true. Third case, for the benefit of the audience and those who might have joined us a little late, what made you to bring those two pieces on the iris surface? Just highlight it. I think that is a wonderful message. What should be done under such circumstances?
Because the visibility also was not very clear. People were slightly coming down, and just in case the PCR extended or for whatever reason we are not able to salvage it, then we could have easily put this to the
Because basically to all of us, I was operating under this risk gateway that my consciousness allowed me, that my consciousness allowed me to live in that way. Even when we all got but it was a peripheral PCR. And once I knew that the rest of the time was in class, it was then my possibility to use my practice. If I knew that I was going to face it in the lab, I would just get it.
Experience, because in the first case, when we went into the main incision, maybe the chamber shallowed a bit and that is why it went to the periphery. Maybe if you go into the side coat and start more in the center rather than more in the mid periphery, you could probably avoid going into the
Thank you, Dr. Anand Mishra, for this excellent presentation. I would like Dr. L.K. Nipalia sir to present the certificate. In the meantime, I would like to invite our national faculty, Dr. G. Haripriya. Thank you very much, ma'am, for traveling from such a distance. Welcome, ma'am, to Jaipur. She'll be speaking on iris fixated IOL. May I like to have the presentation on screen, please.
Thank you so much for having me here. I think it's always a pleasure to come to Jaipur, and thanks to Dr. Sonu Goel and all the organizers for this kind invitation. So I'll be talking on iris fixated IOL. I'll be sharing two techniques. The first of which is using a PMMA lens, and the second would be using a foldable lens or a PMMA lens. So iris fixation, we basically have two broad types. One would be either the iris suture or the iris claw IOL. This is a good option, according to me, for patients who have an intact iris. If the iris is compromised, if there's been any iris trauma, there's been a large SI during surgery, in those cases I would prefer to do a sterile fixated lens. So we published the first technique where we use the PMMA lens. The advantage of this technique is the earlier technique which was used for iris fixation, one would have to fold the lens butterfly style and then place the IOL and then do iris fixation. Here we didn't have to do that. So here what we would do is two iris bites are taken onto the iris, exactly opposite to each other using a 10-0 Prolene suture, and the suture from below the iris is brought out through the main tunnel. So we have two loops at the main tunnel, and each of these suture loops are then twirled twice around the leading and the trailing haptic of the IOL, and then the IOL is placed in sulcus and the suture is tied so that the haptic is fixed to the iris. So this is the first technique. I'm using a 10-0 Prolene suture on a long curved needle. So this one is made by Orolab. I think a few other, Ethicon and a few other companies also make it. So this bite is taken in the mid-periphery, about a 2 to 3 millimeter bite, and the same needle is then reversed and another bite is taken exactly opposite. So here I'm going to place a PMMA lens, so the main tunnel is extended, anti-vitrectomy is done, and the suture from below the iris is then retracted using a Cook lens hook and brought out through the main tunnel. So I'm just going to show the same thing through a mock surgery because this gives better contrast and one may understand it better. So the suture from below the iris is brought out through the main tunnel. The second loop is also brought out. So basically you have two bites on the iris, and the suture from below, it actually comes out quite easily using a Cook lens hook. It's retracted, and this is then twirled twice. I twirl it twice because this way it will stay on the haptic. Even if one slip, the second one is still there. And I don't prefer to tie it as well, because if you tie it onto the haptic, the IOL may be decentered. It may not be at the spot where you want the knot to be. So I just twirl it twice and then I place the lens in the sulcus. So just to ensure that the suture loop has included the haptic and it hasn't slipped while it's being implanted. Once this is done, we just lift the two ends to see if the IOL optic is tilting. So this way, you know that the suture is still under the haptic, so it is still going to hold the haptic. And the suture is then brought out through a side port. So you can do a modified mechanical suture, so whatever technique to then retract the suture through the side port and then tie it together. So through the side port, the knot will then sit on the iris. So when the knot is being tied, you'll see that the optic and the iris would lift, but otherwise it would settle back once it is, once you push it back. So to retract these sutures, the side port here will be about 1.3 to 1.4 millimeter side port, something like a size which you'll use for a Simcoe cannula. That's so a little larger. That way you'll have enough space for the Cook lens to go in and retract the suture from the anterior chamber. And I would place about 6 to 7 knots, and this will hold well. So we find that with technique, we don't see the suture degradation. So it can happen that the haptic actually slips, which you can see in the early post-op period. But otherwise, even after, we have been doing this for more than 15, 17 years, but we don't see that happening. Of course, in children, I find this is an issue. In children, the suture does degrade, but in adults, we don't have this problem. So the modification now is to use either a foldable or a rigid lens. Again, a 3-piece IOL only. I never use a single piece, and place the IOL in the anterior chamber, and then place only the leading haptic below the iris, and then before placing the trailing haptic below the iris, that is before you do a pupillary capture, the optic is supported through a side port, a spatula is passed, and the spatula supports the optic from below. So any secondary IOL, I think one has to ensure that we do a good anterior vitrectomy, be it primary or secondary. Make sure there is no vitreous. Again, in iris fixation, because we're going to do an optic capture, I also constrict the pupil. a 3-piece acrylic IOL. Here it's a sensor. I like the sensor because it is an anterior rounded edge. So when I'm doing iris fixation, I prefer to use that model. So the IOL is placed, and even at this point, I sometimes, like to support the optic, because when you're dialing the leading haptic, the optic also may tend to go below the iris. So I like to support the optic from below using a spatula, which is passed through a side port with a non-dominant hand. And after this is done, the trailing haptic now has to be tucked to enable that the haptic is dialed so that it is closed to the tunnel. So you can grasp it easily with your McPherson's forceps. And then you continue to hold the optic in the anterior chamber, and then the haptic is tucked under the iris. So this technique basically using the same, no special instruments, no special IOL, it's all the same lenses, the same instruments, and it's also an anterior segment technique. So this is my go-to technique today for a patient who does not have adequate capsular support. Once it is captured, then both the haptics are suture fixated. So this can also be done in patients as well as a primary surgery. This patient had a pseudophakic lens. The whole nucleus was in the anterior chamber. So the lens had to be removed in toto. There's no point trying to save this bag here. So antivitrectomy is done. And after that, the pupil is constricted. The pupil doesn't, in some patients where you have traumatic mydriasis, there I wouldn't do this technique because obviously you can't do an optic capture there. So the IOL is then placed in the sulcus. And once the leading haptic is placed below the iris, the optic is supported from below to the spatula. If someone has a micro forceps, one can also use that to hold the optic. Otherwise, I think the spatula also works well. And then the trailing haptic is then inserted below the iris. Then you now have a good pupillary capture. And then it is fixated. I use again the same 10O proline, again mid-periphery, because this way you also have good pupillary dilation post-op as well. Too much towards the pupil margin will cause pupillary constriction, will cause pupillary peaking. So we want to avoid that. And because of this optic capture, the haptic becomes prominent. So it becomes easy for us to take the bite. You don't have to guess, where the haptic is. You actually can see the rim of the haptic. And once it's fixed, the optic is pushed back. So these patients we find even post-operatively, in contrast to what many of us think, if we've done in patients who have not had too much of trauma, pre-op or whatever, they do quite well. So we don't have a higher incidence of CME or inflammation. This is how the post-op looks. You will see some of the suture here on the iris, which is then holding the haptic. So the advantage is it is more of an anterior segment approach, and you can also use the existing lens. If you have a decentered IOL, you can also lift it again to an optic capture and then suture the haptics as well, in case the IOL is the right power and there's no damage to the IOL. Thank you.
Ma'am, two queries. One, these procedures require a lot of intraoperative manipulation, isn't it? So any added risk of post-operative reaction in the follow-up period, number one, and number two, any risk of per-operative irododialysis? Because a lot of maneuvering is required while pushing and suturing these IOLs.
Yeah, the second question I think is easy to answer. No, there is no risk of iris dialysis. I haven't encountered that. The first question, yes, sometimes you may have more inflammation if you manipulate too long. So maybe if someone is just starting off the first few cases, they may see a lot more inflammation. But I think once you understand the technique, the technique which I showed with the suture loop being brought out through the main tunnel, and then that one is less traumatic because there you find you already have that support, so you don't have to worry. The second technique, one has to be careful to be able to support the optic well and then tuck the trailing haptic in. So that needs a little more, I think, learning in terms of one understanding how to get that control. So it is more of a bimanual technique, so one will have to also use the non-dominant hand. I think any technique will
requires
have a
more
longer
learning curve.
I personally don't think so, but I think it depends from surgeon to surgeon.
Not for a specialist like you, but for a general ophthalmologist or one who wants to go for it in few of such circumstances?
So I think it is for someone who is able to use both their hands well. I think this technique is good. If someone is not comfortable doing it, I think this may be more difficult.
I think excellent demonstration, I agree. I mean, it seems to work very well in your hands. These were the thoughts in my mind also. Whenever we have a situation like this, we use a retroiris clip fixation. That seems to be much more simpler. And most of your surgeries, I think, were planned surgeries, and maybe the patient was under peribulbar. Supposing you have an event on the table, majority of our surgeries are topical, and you lose the bag and you have to do a secondary IOL. Then in that case, doing it a topical itself, I find that fixing the iris clip where the lens lands up almost in the same position is much more easier than all this maneuvering. Do you think this technique has any advantage over the retroiris fixation, which more of us do?
I think all these techniques, I think, coexist, and they all have a place. And I mean, one can do sterile fixated, sterile sutured, one can do sterile tuck. So one, it depends upon the situation. Second, it depends upon what the surgeon's comfort is. Third, in that, in terms of the experience, what they would prefer to do. I personally am not very comfortable with the iris claw because I'm not always sure that it is enclaved it properly. Probably I had one case where it didn't sit properly. And so I always feel more secure when I have a suture fixated. But having said that, I think iris claw works very well. Many surgeons do it. Even in Aravind, many doctors do use. I don't say that you should not use it, but I think suture fixation gives me more comfort that the IOL is going to be centered and stable.
Can I have a question? I was just worried, how do you center the pupil? Because a lot of these times, whether you do an iris fixated or whether you do all these mechanisms, the pupil tends to get ovalized. So any quick pearl where you can just ensure that the pupil remains circular?
Yeah, so I think for suture fixation, one thing I would say is to not have the bite too close to the pupil. Again, it also again, the iris claw, the IOL diameter is much smaller. So we have to be conscious as to where it's being enclaved. That's exactly the reason why I don't suture fixate don't tie the knot on the haptic before I place. I want it to be well centered. But again, with an iris claw as well, one has to be careful regarding the size of the lens and the pupil. So one has to take into consideration this, and if that doesn't happen well, then this decentration. So actually, we do see a bit of decentration with some of these techniques. Yes.
Madam, one question. All this secondary IOL, the incidence of retinal detachment is quite high. See, being an anti-segment surgeon, we always depend upon the vitrectomy unit which has been given by the phaco machine, and we do anteriorly vitrectomy. My question to you, how much amount of vitrectomy exactly we have to do? Or if I talk to my retina surgeon, he said that your vitrectomy is more. That might have pulled the vitreous and patient has had a RD after 2.5 months. I had one or two cases. So they say that the vitrectomy with the posterior vitrectomy machine is much better, or you have to do a pars plana vitrectomy to reduce the incidence of retinal detachment. So I just wanted to know you. See, once upon a time, 25 years before, we used to do this open sky method, minimum of vitrectomy, and with the one or scissors, and we never used to get an incidence of retinal detachment. Now the incidence of retinal detachment has increased. So how much vitrectomy and which technique you prefer to do?
It's a good question. So anterior vitrectomy, I think we will do as long as the anterior chamber is free of vitreous. That is what is the goal. We obviously won't go beyond the anterior vitreous space and do a vitrectomy. And I always do anterior vitrectomy. I don't do I've done a few, of course, but I completely believe that even if done through the limbal route, it works well. There does not have to be traction, even if you go, because all of us have been doing so many surgeons, so many cases, so many years. Retinal detachment is a risk, but I think the risk is very, very low. I mean, honestly speaking, many of these cases could have had some other problem, like if it is a patient who's had a trauma, there could be other risk factors, could have been a myope, could be because of surgery, could be iatrogenic as well. I'm not saying no, but I think if you remove the traction component, if you haven't gone and dug into the vitreous to retract your nucleus fragment or the nucleus which is sinking, if we avoid all those maneuvers, I think we can be, you can get a good outcome. I think seeing the patients over many years, you don't see that much of retinal, even the late post-op period, even after a couple of years. Thank you.
Thank you, ma'am Haripriya. Now I'd like Dr. Ramamurthy to present the certificate to Haripriya, ma'am. In the meanwhile, I would like to invite Dr. Saurav Luthra to deliver his talk on phaco-in-phacomorphic glaucoma.
Good afternoon, everyone. At the outset, I would like to thank Dr. Goyal for having me here and giving me this opportunity to speak. No, sir, I think there's a problem. You can go ahead, sir. I think they haven't connected my laptop yet. went with a bigger cannula right now, 22 got, and you can see these products, these technique products coming in between cannula. So that, I have my space created and I was very careful about my optics. I took to a higher mark. I am somehow much comfortable in my practice using a system, so I wanted to go ahead with it. But right here, I felt, that it's going beyond my control. I again went in, took some more of simplified products, which is there, so I don't touch the capsule much. But now it was time to go off the center. And mind you, the capsule here is very, very fragile. It is just not the way a routine cataract capsule would have. So after, I went in with my apparatus, and I thought that now my life is safe. I will turn my capsule well. But I saw on again on the higher mind, I saw that, there is something stuck, I need to cut it. But I was ready to give up, so I thought, let's just try one more time. And luckily, to my surprise, the capsule was still very much there, and it was trying to come back in. And now I decided, no more of subsequent, I go back with my apparatus. Happy enough now that, slowly, with every breath counting, and the patient asking me, how much more time will it take. So, right here I feel that now everything is okay, but again you see that the capsule is again not ready to come down. Maybe my source was not at the right person, I keep going down. I think, now it's just finished. Okay, right here, now it's time to, follow my commands properly. Even after this, before doing any hydro, I went in with my eye at home just to take care of that simplified product because there is a lot of meaty and fluffy products behind the nuclear matter. So again there was still a scope that this capsule might be ready. So I am doing a little water before going with my simplified. So hardly any hydro needed because after doing that IA thing, the nuclear was very much mobile. So very soft nuclear and completely stop and stop that. So my energy is completely related. I'm using very low current. But yes, it came out properly. Again, yeah, so I was of the opinion that now the satellite should not be a problem, but slowly I had to really, put it out and I don't need to maybe if you want to eliminate after using the product. Normal single piece of eye oil, particularly eye oil, you need to put it and go with it.
Dr. Gupta for the talk. We had some detailed discussion about white papers today, so we are able to make tricky points and for that. Thank you once again. Please collect your certificate. It's a pleasure to invite Dr. Ramamurthy for his keynote address. Dr. Ramamurthy does not need any introduction to this house. He is a well-known figure, and he is going to deliver a keynote on cataract synapse.
Thank you so much. At the outset, I'd like to thank Sonu Goyal and the rest of the members of Rajasthan Ophthalmic Society. It's always a pleasure to be back here, meeting old friends and making new ones. I think there are numerous occasions when I come here and always gone back with pleasant memories. I'm just going to go away with from these videos, excellent videos that we saw in this session, and take you through some very practical tips which all of you are aware of but maybe worth reiterating. These are the two tips of which were used in my own OT with the Centurion machine. You can see there's a Prestige tip, there's a fairly old tip which has been in use. So obviously when you have a tip like this, all the parameters, all the things that we talk about goes out of the window. And whenever I have to deal with a hard nucleus especially, I make sure that I get a tip like this, because the cutting efficiency significantly goes down with this kind of a tip, because the kind of occlusion that you get, the holdability of the nucleus goes down, and this is often used and reused again and again as a matter of routine. So it's always a good idea to have a look at what you're doing. And why exactly these tips never get damaged? Because of the nucleus, whatever be the hardness of the nucleus is being managed. More often occurs when a second instrument like a chopper or a stethoscope comes in contact with your tip, especially if the tip is also activated. It can also happen if your sister is not so careful, and when a wrench she is using to fix the tip onto the phaco probe, if it's clashing onto the tip, then there could be a damage to the tip that occurs. So if you want long life for the tip, train the sisters, and you also be careful in the phaco probe. The other factor that I want to drive home is that I usually make my incision depending upon the size of the incision that's required for the implantation of the intraocular lens. I don't like an uncontrolled extension. So though I'm very comfortable with the 2.2, 2.4 millimeter, if I'm planning to use a 3-piece lens, or if I'm planning to use an Indian multifocal toric lens which requires a 2.8 millimeter incision, I always make the incision of 2.8 millimeters. And the point of we use both the Signature, Compact, Infinity, Centurion, etc. And there are several other excellent machines that are available to us. What we need to understand is that when you talk about the Signature Compact, when you shift from 2.2 to 2.8, the internal diameter of the phaco tip shifts from 0.54 to 0.9 millimeters, because of which the parameters that you need to fix, whether it's aspiration flow rate, whether it's the irrigation and the vacuum, the settings have to change for the optimal performance. But when we come on to the other set of instruments, like the equipment like the Infinity or the Centurion, it's essentially the sleeve size only that changes, and the internal diameter remains 0.9 millimeters. And so you go ahead and deal with the cataract exactly the way you did, using the same parameters, irrespective of whether you're doing a 2.2 or a 2.8 millimeter incisions. Of course, we can go on to discuss other machines, but once you understand this basic concept, that's something which will hold you in good stead. And as regards the sleeve itself is concerned, as you can see over here, once you are using and reusing a sleeve, again, there is a possibility that, I didn't know that the point is not coming here. As you can see over here, the irrigation flow is straightforward, and that tends to push the nucleus fragments away, and that's suboptimal. So that's because of repeated autoclaving of the sleeve. So on the other hand, if you use something like a new sleeve over here, you can see that goes on either side, tending to push the nucleus fragments more towards the center. So I always make it a habit before introducing the phaco tip into the anterior chamber to go ahead and activate and see whether the sleeve, the flow of the fluid is on either side. Once that occurs, then I find that this is just an additional point in addition to all other things that we talk about. As far as the tip sleeve orientation is concerned, it's a good idea to have it 90 degrees, and especially for hard cataracts, at least have about 0.8 to 1 millimeter of your tip exposed. But just in case for softer cataracts, it's not necessary. But then, when you are holding your phaco tip in the anterior chamber, sometimes when it's at 90 degrees to each other, the irrigation is directly impinging on the endothelium. In those cases, I find that keeping it about 45 to 50 degrees, now I find is a good via media, where there is the orientation, the tip is also right. At the same time, the damage to the endothelium is also minimized to a large extent, because the fluid is not flushing onto the onto the endothelium directly. As far as the cavitation bubbles is concerned, especially if you're training youngsters, I think it's a good idea, though it's not recommended, to go ahead and activate the phaco tip outside. As you can see here, I'm using just about 50% of torsion power, that also in linear, but the amount of cavitation bubbles that is created and the kind of buzz that's created obviously is extremely deleterious to endothelium, and that's the reason that your plane of phacoemulsification has to be as posteriorly as possible, fill and refill with dispersive viscoelastic to coat the endothelium quite adequately. Then, apart from the various other factors, as far as arresting surge is concerned, as we all know, surge essentially occurs when the nucleus tip is impinging on the phaco tip, and there is a sudden evacuation of the tip, and the vacuum that is generated and the collapsed tubing tends to come back to its normal form, because of which there is sudden evacuation of fluid from the anterior chamber. So most importantly, apart from various other features in Centurion, which has made it a slightly better machine than the Infinity, the fact that the bore of the wall, this aspiration tubing is much less. It has much thicker walls, which translates to lesser compliance. One of the major factors. So whenever you are looking at an aspiration tubing, the thicker the tubing is, the smaller the bore, the better is going to be the control as far as the surge control is concerned. So that in some cases, especially in Indian machines, you can even determine the kind of tubing, that aspiration tubing that you can have, and this is a point that you can keep in mind. I don't know how many have really looked at the span of the phaco foot pedal. As you can see over here, this was what I had in the past. Basically, the first 5%, whenever you put your foot on the foot pedal of a phaco foot switch, the first 5% is because there is always a certain amount of depression that occurs. So there is no activation, no irrigation that's taking place. But the next 10% I was keeping for irrigation, then the next 40% for irrigation aspiration, the last 45% for activation of the phaco power. Because of this, sometimes inadvertently, even when you want to be just in foot position 2, you might slip into foot position 3, because of which there can be unnecessary activation of the phaco power. The present day, these are my foot switch span settings. You can see 60% of it is devoted essentially for aspiration, and I have to go reasonably all the way down so as to activate phaco power. And apart from so many other parameters that I'm familiar with, I find that at least in my hands, this has also helped in reducing unnecessary usage of phaco power. This was a challenging case. I'm just coming to the last two of my snippets. And this is a challenging case where the patient had severe kyphoscoliosis, and this is what we saw in the OPD. When the patient was made to lie down, there was so much of gap between the table and his head. And he had been refused surgery in a couple of places because it was felt it's impossible to do in this position. And this was what the patient had initially when he was made to lie down on the operating table again. But he had a discussion with the anesthetist also, when we thought we'll just place some covers under the patient's feet. Yeah, as you can see over here, it hardly seems to make any difference, and there's still quite a bit of space, and there's no way that we can operate. Essentially, what we had to do is to support his lower back and his buttocks so as to lift up his head. Basically, his head was something like this. We had to tilt his entire body so that his lower portion lifts up and the head comes down at a more manageable level. As you can see here, even in this position, the head is quite high, and we had to keep multiple layers of drapes to essentially support it there. And when we did this, the feet were actually hanging in the air, and that's the reason that we placed the footstool beneath him. And essentially, in spite of all this, it was quite high, and I had to sit on a stool at its extreme end and use the objective, which was essentially brought down, tiltable objectives, crane my head and go ahead and finish the surgery. But obviously, it all paid off. It took almost 4 times the amount of time that we would do for a normal phacoemulsification. But obviously, we could help a patient who did have a reasonably ordinary cataract, but then he had a concomitant problem which required certain amount of thought process to go ahead and deal with. As far as the last of my points is that as far as my go-to formula for intraocular lens power calculation is concerned, for a long time it has been the Barrett group of formula, and initially it was Barrett Universal 2, but now we use essentially the Barrett toric calculator. That's simply because even though very often I am asked what is your criteria as far as when do you recommend a toric intraocular lens, whether it's 0.75, whether it's 1 diopter, etc. But what we essentially do is feed in the parameters into the Barrett toric calculator. Here is IOL Master 700, and here using the total keratometry values. As you can see, even with just a 0.6 degrees of against-neural astigmatism, it's a T3 which is indicated. So even though especially if the patient requires a multifocal intraocular lens, we would definitely recommend a T3 intraocular lens.
Even though if you can just see, go by the value of the astigmatism, the corneal astigmatism is just 0.6. On the other hand, if you have oblique astigmatism or with the rule astigmatism, mind you, it's a little more than what you have in the earlier case, 0.68 diopters, but still it's essentially a non-toric intraocular lens that's recommended, simply because there's posterior corneal astigmatism that's to some extent compensating for this. What in case you don't have the optical biometers, and especially something like a IOL Master 700, we use various other optical biometers, each of them perform quite well. But we do have centers where we use just the immersion A scan and the manual keratometer. Here you have direct access to the Barrett formulae in the APACRS as well as the ASCRS website. You can go ahead and use your manual keratometer or auto K and use your immersion A scan readings and then feed in this data over here. And again, it works equally well. As you can see over here, just a 0.75 diopters of 180 degrees, but it's against the rule astigmatism. So essentially what's recommended is a T3. But on the other hand, when it's a 0.75 at 90 degrees, then it's a non-toric intraocular lens that's being recommended. So we really don't go by the actual value, whether it's 0.5, 0.75 or 1 diopter, but just go ahead, because it's not just the dimension of the astigmatism, the axis of the astigmatism, as well as the age of the patient, does play a role, and this is sort of factored in. The reason we shifted this was once the patient is identified to have a cataract, significant amount of counseling takes place. The patient is motivated to go for a multifocal intraocular lens. And then you put him on a biometer, and then you find that what the patient needs is actually toric lens or a toric multifocal, obviously costing somewhat differently, and then becomes a different conversation altogether. So once we have this data with us, once the patient is identified to undergo the need for cataract surgery, we essentially do this and subsequently counsel the patient whether it's a toric monofocal, toric multifocal, or just a spherical lens that's needed for the patient. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy, for a wonderful presentation and A to Z coverage of various cataract snippets. I think for his wonderful presentation, he deserves a standing ovation. So I request all the participants to please rise from your seats and give a big hand to Dr. Ramamurthy for a wonderful keynote address. Thank you once again on behalf of everyone.
I would like to request you to present the certificate to Ramamurthy, sir.
Ladies and gentlemen, with this, we come to the end of this wonderful scientific session. I thank all the speakers and the wonderful gathering here for its patience hearing, and I request Professor Namrata Sharma to take over for the next session. Thank you all.
One question, sir. One question, sir. Sir, excellent pose for all cataract surgeons. Do you have any particular nomogram as to how many autoclaves or how many surgeries should we continue with the tip and the sleeve? Is there a particular number?
Actually, it all depends upon the way it has been handled.
That's true.
I find that, a lot matters also depending on the experience of the nursing sisters who are there. If they're using the bridge inappropriately, the damage to the phaco tip occurs much faster. So frankly, we have not really counted the number of procedures we use. It's just that we look at both the tip as well as the sleeve before putting it inside the eye, especially if it's a hard cataract case. In case I find that it's a slightly not a very nice tip, then go ahead and change.
Thank you so much.
Session, I would like to invite Dr. Namrata Sharma as the chair. Dr. Hari Priya, Dr. Anil Kothari,
Dr. Rohit Charan, Dr. Ashok Singh, and Dr. Nalini Sen on the chair and panel. So first talk is by Dr. G. Haripriya on management of epithelial ingrowth. Sorry, misalignment of toric ions.
So, through the course of this talk, am I audible? No. The mic, please. Okay, thanks. So, through this talk, we'll be discussing about toric IOL misalignment. I think this is a good follow-up talk for what we just heard from Dr. Ramamurthy, considering we had some discussion about toric lenses as well. So, I think toric lenses are broadly forgiving lenses. So, with some mild rotation, you find these patients do very well. But if it is more significant, for example, if it is, let's say, 30%, let's say a patient has 1.5 diopters astigmatism and rotation is about 30%, then you will find that the patient has about 33% of the astigmatism come back, which means they will have 0.5 residual. And with 0.5, it may not make a much difference if it is a small amount of pre-op astigmatism. But if it is a much bigger, higher amount of astigmatism, let's say the patient had 4 diopters of astigmatism and the IOL rotates 20 degrees, the patient will still have post-op about 2 diopters. So it depends upon how much astigmatism the patient had pre-op and the rotation, which decides whether you have to go ahead and realign these toric lenses. So I'll just be sharing some of the cases. So 2 cases I'll be sharing. So this is one patient who was advised a toric IOL. Patient had a regular astigmatism, regular bow tie with the rule, and this patient had a residual of 1.5 diopters. So this was because the IOL had some rotation, and this rotation was about 30 degrees. So image you see here is taken through the eye trace. So this eye trace uses ray tracing, and it tells us where one is we see the IOL position on the slit lamp and we say it was supposed to be at 90, it's now at 105. The second is we also have a more objective way of identifying where the IOL is now sitting. And this also tells us, how much the IOL has to be rotated, which is like 31 degrees, to have the least residual astigmatism, which is about 0.38. So the patient now has about 2.33 has about 2.33 corneal, and if you rotate it, the patient will only have about 0.3. So this is what the eye trace does tell us, and that is useful for us for understanding, whether intervention will actually help the patient or not. And this patient had, a refraction, and which would improve by at least 3 lines if the IOL were in the right position. So we decided to go and do a repositioning surgery. So here, this is the same patient. So this is the marker which is used. So I place the marker at the existing IOL position and then place the mark about 30 degrees away from it. So this way, you don't have to decide just by the axis, because you don't want to make another mistake in terms of identifying where the IOL has to lie. So I would use the existing IOL position and from there measure 30 degrees clockwise, and that new position is where the IOL has to lie. So this was what 1 month post-op. That's why there is some amount of addition here. So viscoelastic is used, a main tunnel is open, so we don't make a new incision here again, so that we can control the astigmatism. Otherwise, you may have a change in the corneal astigmatism. I've also used a Simcoe here because I wanted to be more gentle with the cortex wash, not disrupt the lens too much, kind of use whatever addition the optic has with the posterior capsule. So that is the idea why the Simcoe was used here. This patient did well. So post-op, the IOL was on position 2 degrees away from where it was intended, and the patient also had 6/6 nil glass. This is how the simulated E-vision chart looked before rotation, and this is how the patient could see after rotation. So in many of these patients, when we have this kind of significant astigmatism, and if we find that the astigmatism will improve at least 2 lines of vision. If the patient has 6.9 to 6.6, we wouldn't advocate, but if the patient has 6.18 to 6.6, improving with refraction, then we will consider repositioning surgery. This is the second case. This patient again had 1.5 diopters astigmatism. Here the toric IOL was planned for this patient as well. But this was a surprise because post-op this patient had 2 diopter cylinder. And the IOL was at the right position. Based on what the pre-op planning was, it was still at the right position. So we tried to understand what went wrong here. So again, we repeated the A scan. The A scan was the same. It was again only 1.5. But this was again a very, very weird, like a freak incident where the surgically induced astigmatism had been misentered as 5 instead of 0.5. And this is again, it doesn't happen very often to any of us, but this is the one case we have had. But I'm just saying that these kind of freak incidents can also happen. So one has to really focus when handling these lenses. So we've also had an incident where the K reading was interchanged. Instead of a steep axis in the horizontal meridian, it was on the vertical meridian. So from the A scan sheet, when you enter it onto the toric calculation sheet, there will be a change in the axis, there will be a change in the number, etc. So this patient we thought we'll have to set right. So now we had to place a T3, and so the patient had received a T8, so the IOL had to be exchanged. So that is what we went ahead and did. So this original incision was used. We didn't want to change the incision. Here we first marked the site where the new IOL has to lie. Again, this was 1 month post-op, a hydrophobic acrylic lens, the Aegis lens. So it adheres very well, very quickly to the capsular bag. So any such intervention is best done within 15 days. If it's done more than that, you will find that the chance of the capsular bag adhesion is much stronger. So 2 instruments are used. Visco is injected. The capsular bag is first dissected out. The IOL is brought out into the anterior chamber. To remove this lens, I'm going through a 2.8 incision. So the leading one haptic is brought out. IOL is stabilized with a micro lens holding forceps. And then you can either do this, or you could even hold the extruded haptic with your forceps outside also. This also can still work. One of this is done. And the IOL is first stabilized, and then it's cut into using a micro scissors. Again, a 1 hour also works very well. Just a regular long 1 hour also does the same thing very well. So you can still, manage to explant the lens through the same 2.8 incision. You don't have to enlarge the incision to explant this lens. But it's important to remember to always stabilize the IOL optic. Otherwise, when you're trying to cut it, the IOL will keep tilting. It won't stay in place. And the 2 parts of the IOL are then removed to the main incision. The next IOL is then placed in the bag at the site where it was planned. So when you have a small pupil, I like to use the Kuglin's hook. So you can just retract the iris and see if that is correlating. I do this. And again, I don't fill the anterior chamber too tight. I just make sure it's well formed and leave it at it. If your bag is over inflated, this can also cause the IOL to rotate. So you would just want the AC to be well formed, but not overfilled. So again, this patient also did well. The patient also had 6.6 post-op. So another option, so in terms of intervention for toric IOL rotation, so if you are planning rotation, which I said was in case the patient has significant astigmatism, there we have 2 options. So one which we use commonly is the eye trace because we have that equipment. The other one which is I think most widely used is the astigmatismfix.com, which 2 authors, Burdell and Harden, introduced, and one has to just key in the different data onto this website, astigmatismfix.com. So here you'll have to include everything from where your IOL is now sitting to the refraction now, what was planned. Once we give all this information onto the site, then this will give us a similar image and tell us the existing position and how much the IOL has to be rotated to have the least residual astigmatism after repositioning surgery. So this is a tool which can also be used. However, some of the Indian toric lenses, the models may not be available here. So one may not be able to get the model, but you can key in the amount of astigmatism that model corrects. and that will still give you the same result. So that is also possible. Like standard multinational company IOLs, it gives you straight away what model and things, but otherwise you'll have to key in the astigmatism that specific model corrected. So the risk factors for rotation is, of course, while the IOL is placed itself. So one, the reference marking or the axis marking could be an issue. If one is not careful, doesn't take effort to ensure we're having the 0, 180 correct and the axis marking correct, there could be a mistake to begin with itself, and we don't know if it was an issue with the reference marking or rotation, because most rotation happens in the early post-op, within the first 1 hour or within the first few hours. So we won't know the difference, so it's important to take care of that. Second, you ensure that you're placing the lens well, and you don't, when you've formed the anterior chamber and had a side port hydrated, at that point as well, you'll have to confirm that the IOL is still at the right position. And in patients with high axial length, large capsular bag, there's a higher risk, or if you have more, retained viscoelastic. The factors which influence, less rotation. So some of the IOLs, if you use them with a hydrophobic platform, especially the ones which are more adhesive, which are more tacky, are better for toric lenses, because this way the lens sticks to the capsule and there's less rotation, and these patients have a better outcome. So we published our results comparing the outcome amongst both hydrophilic and hydrophobic lenses, the number of patients who required repositioning surgery, and the outcome in these eyes. So this was at that point the largest series. We did it in more than 100 eyes. And our definition is, we did it when the patient had more than 15 degrees of rotation, or the patient had improvement of at least 2 lines with refraction. So we had about total of 5,500 eyes in this series, more hydrophilic than hydrophobic at that point. And 2.46% needed rotation and 1.76 underwent repositioning surgery in the hydrophilic platform. In our case, it was the Oralab's hydrophilic toric lens. And in the hydrophobic, about 1.85 required and 1.51 underwent repositioning surgery. And this difference was not statistically significant. And we also found there was a higher risks in high myopes, as we know, because larger bag, in high astigmatism, because in high astigmatism, even small rotation, the patient will have a higher residual power. And some lenses also have this power on the posterior side, and so once the power is more, the chance of rotation is also higher. And we also saw another important aspect, that this is more common in younger patients and patients with the rule astigmatism compared to against the rule astigmatism. So I think what is important to remember is, if you're planning repositioning surgery, try to do it within 10 to 15 days. So if that happens, then the IOL would not have adhered to the capsular bag. So this is one such patient. Here I'm just using the side port because I'm not opening the main wound, not using viscoelastic, so side port is fine. Using the right hand side side port for the hydrocannula, so the chamber is well formed, and the left hand are using the dialer to position it in the new position. So this could be not the very, very less maneuvering, and the patient also does well. So if you're going to wait for beyond like a month or so for a hydrophobic lens especially, then you'll find the adhesion is much stronger. So you find that toric lens, most of them do well. So I think we have many studies today, about 1% will need repositioning surgeries. That is a given. But if we take as much precautions and care as we can, especially in patients who have high risk, patients with the rule, high myopes, high astigmatism, there if you're going to give more care, we can reduce this number significantly. And those who do need it, I think we find that the resurgery actually works very well, and most patients actually are very happy after they've had the repositioning surgery. Thank you.
Thank you very much, ma'am, for the excellent talk. There are any questions?
Just a couple of queries and just maybe one comment, Haripriya. Any difference in the type of IOL? Because I remember the Oralab all are the Rayner type.
All are the?
Hydrophilic, Oralab, toric IOLs are all the Rayner type of with the double haptic, and the others from the Alcon or from J&J are usually the modified C-loop. So my query was there any difference in the type of model when you look at the type of rotation. Because in our experience, we find that the double haptic, the Rayner type, is actually a lot more stable, and chances of rotation is less. Because it's probably more compressible, that's what my impression is. The second is the plate haptics actually are the most stable, even though they may have a slightly higher PCO rates. The plate haptic toric lenses are actually the most stable of all the set.
Yeah, so we haven't actually used the plate haptic torics again because of the PCO rate. And I do agree that the Rayner model of the loop haptic actually are more stable. And I was more convinced after we began using the hydrophobic platform of Aurolab. So with the hydrophilic, the reason why they made the loop haptic was because that was the model with the initial hydroflex platform itself. When they moved to the hydrophobic, they made their hydrophobic in the regular C-loop model, and we found the rotation was more there in the initial lenses. So then we asked them to make it in this model, and once they changed it, we found that the rotation was lesser. So now they still make their hydrophobics as well in that model.
So one question, Haripriya, lovely presentation. If there's a posterior capsular tear, you would still implant a toric IOL, or you would choose not to, and in what situation?
If you can place the IOL in the bag, I think, if you identify the rent early, many of us, who are experienced can still place it in the bag. In that case, and if it is like an inferior rent, an IOL placed vertically, there obviously we wouldn't. If the haptic is going to be right over the rent, and if it's inferior, those are risk factors for decentration. Otherwise, we still would go ahead and place a toric lens. If the rent is small, if there's no vitreous, and you can still place a toric lens in the bag. In case I'm going to plan for a sulcus fixation, then I'll do a non-toric.
Okay. And have you had to do this adjustment for misalignment of the toricity more than once in any of your cases?
Actually, no. That is a nice thing. So I'm actually very happy with the outcomes with these patients. They do very well. We don't do them. That's the reason we don't do them very early in the post-op. I don't do it. Even if one day we see it, I like to wait for at least a week so that we actually get the final keratometry when the IOL settles down, and then we can. Any other question?
Dr. Haripriya, I had a quick question. Really enjoyed your presentation. With the eye trace, what I found is that many times it does not pick up the toricity of the IOL correctly, which means that you may have used a model which is having more or less astigmatism, but what it detects as the internal astigmatism is not exactly the same as what you thought, and that can kind of alter your. So do you make an adjustment, and how do you make it?
Actually, it's a good point, because you are right. The eye trace is not as objective as we would like to. But we did try alternate methods of looking at it, like going on to different websites and doing it. And there we thought there were a lot more subjective components. Like if we're going to say which axis, if I'm going to key in 15 degrees, it may be 15 for me, 20 for someone else. So, but I thought the aspect of the fact that this actually tells me where it is now, and 30 degrees from there, it could be 15, it could be 20, or it could be 5 degrees. Seemed to work, and basically I am convinced because our outcomes have been good and it has worked. So that's why I think this is.
When it picks it up correctly, then it's beautiful. But sometimes when it's not picking up your internal astigmatism correctly, then you're doubtful whether that much rotation will actually work.
Yeah. So I normally it does show much higher than what actually it is. So you are right on that. But on this front, for this aspect of thing, I think works well. And also in patients with small pupil, right, when they have high astigmatism and we can't identify, again in those eyes as well we use the eye trace.
I follow one tenet in the sense that look at the value, the spherical equivalent of the residual astigmatism, and only if it is zero, near zero, I think it helps. If it's just a -1 diopter of cylinder, or it's just a diopter of sphere, then because when you are rotating, you are just redistributing the power, not really changing the power. Do you also follow the tenet, or because whenever
we don't do it as much again because I feel the refraction is dependent. Of course, we don't consider the auto refractometer in this factor. So we look at the refractionists. Some of them don't give a mixed astigmatism. They just because the patient reads the same. Whether you give a +0.5 -1 cylinder or just give a -1 cylinder straight away, the patient still reads the same. So sometimes I find it's technician dependent, so I don't always go by that. But it's definitely a good factor. So what it means is that the IOL power calculation is a mistake. It's not just the toricity. but the overall axial length, keratometry, whatever is a mistake. So you may need an IOL exchange in those patients, not just a rotation. So that is what may be the solution there.
Thank you, ma'am. Our next speaker will be Dr. Gaurav. He'll speak on management of epithelial ingrowth.
Thank you so much, and very good afternoon to everyone, and it's a pleasure to be here in Jaipur once again, and congratulations to Anand Eye Hospital team for a wonderful program under the JAWS. So, Dr. Goyal had asked me to speak on epithelial ingrowth, and thankfully now that we do more of SMILE, this has become much of a rarity, but yes, there's a huge number of LASIK patients sitting out there who can still come to you at some point of their life with flap trauma and epithelial ingrowth. So the common causes of epithelial ingrowth can be early post-operative flap slippage, and they can be pannus at the flap edge, and here I would like to caution everyone that if there is pannus and your flap edge is going through the pannus, and if you have a small bleed, at the time of closing out the surgery, it's very important to ensure that you've been able to contain the bleed from the edge of the flap and not allowing any heme to kind of gather under the flap edge, because that will potentially leave a space there, and later on that is where the epithelial ingrowth will start from. I've had 2 instances like this over the last 20 years of my practice, and I now never leave this flap edge with a small active bleed. Flap trauma, it can happen near the hinge. It can happen following hyperopic treatments because you're guttering in the periphery, and it's more likely to happen with microkeratome flaps and with flap relifts. So these are the common reasons why you might have an epithelial ingrowth. And I'll share one of these cases which was operated recently. It was a post-op day 1 flap slippage, if I remember correctly. So again, now this is very important, what I was just doing, like removing that frill of epithelium from the edge. Once you do a relift, you will sometimes, of course, you will have some kind of epithelial ingrowth on the back of the flap, and you will have some on the bed, and it's very important to identify it. But beyond that, it will also be important to remove a frill of epithelium from the periphery. And as you can see here, because they were striated, so it is important to, if you are not able to get it right, you have to get the epithelium off. I almost always end up removing the epithelium, because there have been times when I've thought that I will get away without removing it because the stria may have been very minor, but then I end up almost always having to remove it. So nowadays I actually remove it before I lift the flap, because that makes it much easier. And you can see here that it's easily done with a hockey stick knife. And with the benefit of retroillumination, it becomes much easier to actually get these stria out, and to get a perfect outcome, I think it's almost mandatory to do the epithelium removal from the surface of the flap as well. And then you can use 2 sponges like this. I like to iron it and dry it thoroughly for about 5 minutes, and with a wet squeezed sponge, you can kind of traction and counter traction in opposite directions so that you're ironing the flap. Some people have used other devices like giving heat to the flap as well, to the stria as well, but most often I have managed to, even the most resistant ones, I've been able to do it. And then IOCT of course helps you to identify if you've got a great outcome, and that helps. So then you can obviously put a bandage contact lens, which is absolutely necessary. Going on to our next patient, this was one patient who presented with epithelial ingrowth after flap trauma, and we could see that this was involving from the superior to inferior scans almost through and through, but on the horizontal scans it was basically coming to the half of the cornea. So we decided to proceed with this patient's surgery, and these were fixed striae which had been there for almost a month or 2, and started by removing the epithelium in the area of the striae. Again, here I was not sure whether I would lift the whole flap, because the epithelium ingrowth was basically coming only till the central area. It was not crossing the center of the cornea, and I started by removing the epithelium meticulously, and then also the edge, from the edge of the flap, making sure that a small frill of epithelium is also removed. And once I was able to do that, I was going to lift the flap and look for the epithelium on the back side of the flap as well as on the bed. So it's important to get the epithelium off. and then you can use a hockey stick knife to clean it up. So once you've lifted up the flap, I lifted up as much as I needed to, and once I had done that, I'm basically now using the hockey stick knife. Also on the edge, you have to stabilize the flap with something if you have to. You can do it with a sponge, you can do it with a small instrument, and make sure that every small, you have to be patient. This can take 10, 15, 20 minutes, and you can then stain to check sometimes as well if you got everything out, and that can help. Some people would like to use alcohol or mitomycin C. I've most often got away without using any of these. If you're very meticulous with the removal and you put a contact lens in place and you've made sure that everything is done, but you can still sometimes get an issue. So here we managed to retain one side of the flap without lifting it, and then ironing it nicely, and then putting in a contact lens, and we got a good result post-operatively for this patient. And this was a third last case which I wanted to show. Very referred from outside with a bad epithelial ingrowth. There was a lot of scarring and a very bad topography. Patient had high induced astigmatism. In fact, it was so scarred that it was actually very difficult to lift up the flap edge as well. So I had to remove a lot of epithelium there first, and then it was almost stuck over there. This sometimes happens if it's been there for a very long time. These may not necessarily be progressive actually, but then if they're inducing high astigmatism, you have to get it out. So once you've made a pocket, and then you can just do a femto flap lift kind of a thing. And now I'm going to use the hockey stick knife to remove it. And I remember working on this for good 15 minutes or so on both the flap and all, but even after doing everything, there was still some remaining scars, remaining over there. And frankly, they would have left a small space over there and potential space for the epithelium to grow back. So I went in with a burr, and with a burr I was able to get some of that scarred tissue out. And this can be a useful way to clean up for any remaining epithelium scars which may be there. And then you can put it back in place. And you can sometimes have to suture it as well. So I'll just go to my last one small snip of 10 seconds. This was a patient where we use IOCT to get this right. And this can be a very useful way of checking. You can see on the IOCT the epithelium ingrowth over here. The technique used was almost the same. Remove the epithelium, go under the flap and remove from both the sides. And then once you've got it in place, you can actually put it back and then check it again on the intraoperative OCT. I think Dr. Namrata has a talk on this, and I'm sure she'll be able to share a lot of details on how it is useful. So with that, I would like to stop, and thank you so much. I'll be happy to answer any questions.
Thank you, Gaurav. I think we'll take the questions in the end because we are running a little short of time. So
the next speaker is Dr. Anand Parsarthi, and he'll speak on Femto Perfect, problem solving in femtosecond refractive surgery.
Dr. Kudlu, can you check if your presentation is here?
Good afternoon, and I'd like to thank Sonu and the Eye Hospital, Anand Eye Hospital team. And Sonu is a very, very good friend, and he's so good that he named his eye hospital after me. I must thank him for that. But he's got a lovely facility, and it is actually quite nice to see. I've been asked to speak about Femto Perfect, just a couple of talks, and I'll try and focus on something that's probably not being done in this live surgery because SMILE is already being covered. And we do know the femtosecond procedures is a very heavily utilized scheme because of the reproducibility, safety, versatility, and of course the precision. Now, when you look at commercially available lasers, and there's a very, now probably 4 which are active, and the one that are marked are what are more commonly used. And that's 2 important points which I'll probably want to stress is one is the suction, and the second is the applanation surface, because these are important because they change the dynamics of surgery itself. Now, of all the 3 machines which are commonly used, my experience, and I've used all 3 of them, I find that the Wavelight actually has the best suction, and I think it's because of a dual vacuum. The second important point is the applanation surface, because that directly correlates with the vacuum that is there. And the Zeiss has a curved, the Wavelight is a modified planar, and that is important because sometimes if you put too much pressure, the chance of break of suction tends to be there. Though with the curved interface, the sensitivity of the machine is a lot more. Now, of the scope of the use, the LASIK, keratoplasty, intracorneal rings, and SMILE are the most common ones. I won't touch about LASIK because that's beyond the scope, but I'll touch upon femtokeratoplasty and the intracorneal rings, which we have very, very good significant experience. Now, as a technology, I think it's been used to perform PK, and now a lot of use has been there for targeted lamellar surgery, and it is proven to have more rapid visual recovery and, of course, decrease the amount of astigmatism, especially in some of these patients. We described this way back in 2008, so it's almost been the 14, 15 years since the first publication of femtosecond laser keratoplasty. And this was the lab model which we did prove that you can actually get very, very good significant cuts. After this, we did publish the clinical results as well with femtosecond keratoplasty, and we had almost about 8 patients in the initial report, and all of them actually did quite well. It is now possible to do sutureless surgery, like in this patient who has granular corneal dystrophy. And of course, you need to understand it is an optical procedure. You need to get the depth of the precision right. So most of these, up to 200 microns, you can actually do a sutureless procedure. There have been some publications who go deeper, but I find 200 to 250 is probably the limit. Now, when you're talking, centration becomes important. You want to make sure that you do not go beyond 8 millimeters. We find 8 millimeters for LK works in most times very well. The second important point is when you got corneal dystrophy, the disruption of the laser tends to be a lot more. So you may not get as clean a cut as you would for LASIK flap, but with a bit of dissection, you can actually lift most of these. You need a free cap, unlike LASIK. So you basically go around, you lift up the edges, and then use a forceps. You can use iris spatula that works equally well. You can use a LASIK flap lifter as well, like that is used. Now you can make out the central part, which has got an opaque bubble layer, requires a bit more of dissection. And of course, you need to be very careful how you actually lift it out. Now the important thing is that you replicate this on a donor eye, on an artificial anterior chamber. And once you do that, you can actually get a good match. Usually about 0.2 micron is what we tend to oversize it. Up to 200 microns, if it's a very well-planned procedure, you can actually just put a contact lens, leave it in place. These corneas, you need to use it fresh, because if there is edema, sometimes there is over-cutting or an undercutting. We wait for almost about 10 minutes in all these procedures, because if you do it a lot more earlier, sometimes the adhesion is not good. Post-op, a lot of them actually do quite well. They have a lot of less scatter, and most of them actually are quite happy. This is just one other procedure for DALC, wherein we basically, this has already been cut with the femtosecond. And just to show you that it's possible to actually get a very nice demarcation. And I'm showing you on the right the screen, which is showing the mushroom cut. So you've cut this on the recipient and the donor, and then you kind of match this by about 0.2 millimeters more. And the rest of the dissection in terms of the LK is very, very similar. You go ahead with the big bubble injection and then do the posterior dissection and match the donor and basically suture it in at the end of the procedure. Femtosecond Intacs usually works well for all stages of keratoconus, both for central and for peripheral cones. And in this, I would just show you one where we actually did the centration and the with the CARES, which is a lot more a different procedure from the femtosecond Intacs, which we are doing for many years. Now, the important point about even for femtosecond Intacs is the centration and the docking. Of course, it needs to be a very, very soft dock, so we're taking a bit more of time. This is with the FS800. And once you have that centered, the cutting is a lot more quicker. You can find, in this we have made slightly larger tunnels because we got to put in the allogenic CARES. But what we find is in terms of effect, it is actually quite good. The cutting is very, very quick. You have 2 entries. Now this is the ICR incision, which is the printout that you get from Zeiss. And you can make out that you have 2 slightly larger size of the tunnels with 2 entry wounds to actually insert your CARES. Now with the femtosecond laser, which we still do, and it has definitely some present indications, you need to center it on the pupil. You need to then make the incision cut. Usually these ring segments are a lot more tighter. You of course need to open it, and once you do that, depending on the nomogram and the refraction, you open this up and then push in the intracorneal ring segments. This procedure, usually the first one is a lot more easier to insert because the cornea is a lot more softer. The second one tends to be a lot more stiffer. And once you do that, you can actually see that changing. Now, for Femto Smile, we've had long-term results matching the Femto LASIK. That is, of course, a learning curve. And it is definitely easier for corneal surgeons, I find, where the dissection tends to be a lot more better. In lenticular extraction, you can see the edge actually quite a lot more clearly in a lot of these procedures. And in terms of the visual results, the initial hesitation of recovery is actually a lot more come down. Now, when you're looking at achieving the perfect outcome with femtosecond, you need to have perfect preparation because you need to make sure that the surface is very clean. You need to have perfect docking and centration. You need to have perfect energy settings, and of course, you need to have perfect dissection. If all these 3-4 parameters are satisfied, you tend to get very, very good outcomes. I'd like to end with this, and I've finished in time. Thank you so much for your patient hearing.
Thank you, Dr. Anand, for sticking to the time and excellent talk. Next speaker will be Dr. KP Kudlu, and be speaking on my experience with the acryl phakic IOLs.
Thank you for the opportunity. I thank my brother Son calling me all the way from Udupi, Karnataka. So I will be talking about my experience and the safety and efficacy of acryl phakic IOLs. No financial interest for this particular talk. So I think I will not be talking much about the indications for phakic IOL. As we all know that in the case of very high myopia, thin corneas, even we can do it in stabilized central keratoconus, post-ARC and post-PK patient. These are the contraindication. Patient with a progressive refractive error, history of uveitis, history of glaucoma, and antechamber less than 2.8. And if the patient is already developing cataract, and in case of pregnancy, he should not be implanting the phakic IOL. But there are a lot of advantages with phakic posterior chamber lenses. That is because it is behind the iris, far from the endothelium. Very important, we implant close to the nodal point of the eye. Always vision will be much better than the promise, and less likely to cause any dry eye also, and does not alter the any shape of the cornea. These are the A list. One is subjective refraction, very important, keratometry, AC depth, pachymetry, axial length and white to white diameter. So refraction, all my patients where I am doing refractive surgery, I do the cycloplegic refraction. Those are using contact lens, soft lens, discontinue for 4 to 5 days, for RGP minimum of 1 week. So coming to the keratometry, whether posterior curvature is important in the phakic IOL calculation is not. So if you are using with autorefractometer keratometer, always you should do the calibration. Antechamber depth is one of the very important point to be noted here. Always the minimum has to be 2.8. It is from the endothelium to the antricapsule. If you are doing with the ultrasound, you should remember to deduct the Pachy value. So antechamber depth probably the only determinant which should prevent patient not getting a phakic IOL. Because if you have some problem with the ACD, then patient may land up with some problem. See, this comment to the ACD, which is the best method. With the A-scan, we compared with the A-scan and the IOL Master 700, which gives quite similar results with even comparison with the ASOCT. So white to white, probably the single most important measurement which has bearing the success of the procedure. Always I take 2 to 3 reading and I cross check with my other surgeon also. Why it is very important, if you make mistake in white to white, then oversizing gives a higher vault, lead to glaucoma, and undersizing gives to lower vault, which could lead to patient may have a cataract. So this is the different method. I think the calibrated digital calipers, if you compare with the OpScan, which gives a quite similar results of white to white. So normally patient has to be there in the supine position under the microscope with the speculum applied. Normally we measure white to white horizontally. So always what I do, I measure from clear cornea to clear cornea. That is my take home message. So always post-operatively you need to look for a IOP checkup, very, very important. So coming to one or two points about the wart, what exactly is the wart? This is the distance between the posterior surface of the phakic IOL and the anterior surface of the anterior capsule. Optimum should be half the corneal thickness to the 1.5 corneal thickness, that is between 250 to 750 micron. So these are the possible complications: high wall, low wall, there is increase in IOP, iris chafing and poor corneal healing. This is a video I am showing you. So I wanted me to show a video of phakic IOL. First, initially in front of the slit lamp, I mark the cornea. After marking the cornea, there are different methods to mark the cornea. I do have got a Callisto system, no financial interest. So we can do without marking also, where intraoperative marking only you will get. Once you mark, I think it's very easy, phakic lenses. Only thing is, when you're making incision, when you're injecting viscoelastic, always you have to be very, very careful. Don't fill the anterior chamber with the more viscoelastic. Sometimes later on post-op complication may increase, because after implanting the phakic lenses, if a lot of visco left behind the lens, then you may land up with some amount of high, the pressure may increase. So this is how you pick up the lens from the bottle, but the only thing is advantage, these lenses are hydrophilic acrylic lenses, so you can even touch with the McPherson, unlikely with the any of the other competitive brand. So you take the lens, then once you load, keep injecting with a smooth jerk. I am doing something called something wooden assisted, so that I am not going in that much. But these lenses are very comfortable lenses. The chances of flipping the lens inside the anterior chamber is much, much lesser. Once you mark, I think already we had marked, once you go inside, the rotation will be around 5 to 10 degrees, whether clockwise or anti-clockwise. So the stability of the lens is very, very good. I happened to do a live surgery yesterday itself in Ranchi, and also I am doing live surgery in Kanpur on the same lenses. These are the lenses actually we started initially. I helped the company for even designing these lenses, and I implanted more than 1,000 plus lenses so far. Absolutely there is no problem and there is no complication with these lenses, except for 8 patients in out of 1,000. So for the trailing haptic, I always use the main one, tuck underneath the iris and look for the round pupil. Once you are tucking done, make sure that you are aligned with the what is the marking. On the marking over, normally I clean with the Simcoe cannula. I always stay within the anterior chamber for a period of 5 minutes. Make sure that you remove most of the viscoelastic. These are the advantage: excellent osmosis, easy to load, less chance of flip and rotation, and online and offline mobile application for calculation available like this I am showing. So you will have all sort of advantage with these lenses. This is our experience. I take a half a minute. So now this is experience with the 120 eyes, normally followed for 1 day, 1 week, 1 month and 6 and 12 months. So these lenses advantage: water content 26%, optic diameter 6.5. It will come in all length of 12, 12.5, 13, 13.5. You can implant in the sulcus, dioptric range between 3 to 25 diopters. This is about the patient results. Most of the patients are fit in between -10 to -15 diopter, around 50% of the patient. If you see, I think post-operatively, almost near to 50% of the patient, very minimal residual refraction was remaining. These are the wow factor. I think more than like 90% of the patient had a wow effect of 6.6. And if you see the IOP stability also, not much increase in the intraocular pressure. So coming to the safety, I think patient achieving a very good post-operative uncorrected distal acuity. The endothelial cell loss was a much lesser. 8 patients had an initial IOP control, which was controlled by anti-glaucoma medication. None of the patients developed actually cataract. So this is my experience with the toric lenses. I think 100 eyes. The advantage is the power diopter -5 to -23 diopter with the 5 cylinder. So you can almost cover up, you take care about around 28 diopters of overall eye power. So if you see, these are the results. If you see here, 48% of the patients are actually fitting between the 1.5 to 2 cylinder. If you see post-operatively, 80% of the patient had a very, very minimal astigmatism left over, that is around 0.5. Only less than 5% had in 86% of patients had a rotation. All eyes had a more than 10 eyes per rotation. In conclusion, iClick phakic and iClick phakic toric lens are safe and effective for treating range of myopia with astigmatism. Short and easy learning curve for cataract surgeon. Quality of vision is always better than promised. Long-term follow-up studies are needed in order to evaluate the incidence of cataract and endothelial cell loss. So once again, I thank my friend Sonu for this wonderful opportunity. Thank you, one and all.
Nice presentation, Dr. Kudlu. Just I wanted to aid or rather you can say I just want to know from you, because you told white to white. White, there is no sharp line. So sometimes it is gray to gray. There are many people who take gray to gray, yes, because all depends on your own experience. Yes. What do you feel? You feel prefer gray to gray or black to black?
Sir,
secondly, two questions. Answer it one time. And secondly, acrylic lenses sometimes if you want to take it out again, suppose it is reverse or it is traumatized. If you want to take it, it is very difficult to take out from the same incision. Yes, so do you enlarge the incision?
Sir, actually I do have got video without extending the incision. These lenses, like the other lenses available in the market, you can take it out and reload and put it. But the shape is so good that the chances of flipping inside is almost next to zero. But we have, like just in the initial trial, they want to do this trial also after injecting to take out through the same wound. We tried for 3-4 patients. We could able to remove very easily. There is no problem. If it is flip also, you can remove through the same incision and you can put it back. And about the white to white, what you say that normally I measure where the white ends, that part. Gray about to start, that part to the gray about to start, I measure. What I do in my hospital, I do it. Then I tell my senior consultant or those are cornea surgeon, you go and do it. Then we both write their reading. Then along with that orb scan, with 3 comparison, if we do it, then we ourselves only, we know that what is our, how is the measurement errors also we had already come to know. With 3 modalities, 2 surgeon and 1 more equipment, that's how we do it. And I also order the lens myself only.
But usually what they prefer, they ask for the digital also and IOL master also.
Yes, sir.
And usually they calculate it with the IOL master.
Yes, sir. Concluded with the IOL master. They do like that only.
Yeah.
Yes.
Thank you, Dr. Kuddu. I would like to welcome Dr. Arun Kshetrapal for his talk, which is titled as Double Trouble. Meanwhile, I'll request Dr. Namrata to hand over the certificate to Dr. Kuddu.
First of all, I'd like to thank Sonu for inviting me over and organizing such a beautiful scientific feast. I'll be showing a video titled Double Trouble. This is a 36-year-old male who was planned for a toric EDOF. I have already done the markings. I thought it's a simple case, the marking done. I don't have a fancy marking systems with me. I do it manually on a slit lamp. So capsular access was a cakewalk. I had a perfect hydrodissection, a good wave going all through, and a good rotation of the nucleus. I am a fan of direct chop. I engage my phaco probe and chop it into 2 pieces. And the nucleus consistency is about 2+, 3+, and it's very easy to chop these nucleus. And the first segment goes out. The second segment, I engage it, chop it, remove it. So almost 1/3 of the nucleus is out. Now this is the last part of this hemisphere. And look what happens now. I am trying to engage it, but I am not able to engage. Could you notice that what happened? We'll again see this in a slow motion. So here I am trying to engage the nucleus. I fail to engage. It gets released. I put my pedal down. I put in some more power. And look what happened. The phaco probe went through the nucleus, hit the capsule, and there was a capsular rupture. And if you could appreciate, there was a beautiful pupillary snap sign. can see the pupil had expanded and now it's coming back. So I had landed up with a posterior capsular rupture near the equator. So I said, okay, never mind. I was a bit careless and I said, let me finish up with my phacoemulsification since there was not any vitreous. So I go ahead, I'm doing my phacoemulsification. In the process, if you can appreciate that, I'm losing few nuclear fragments into the vitreous, and I'm so careless that I'm not even bothered about that, and I keep on doing my phacoemulsification. And you may say that I was really lazy to come out and put some viscoelastic and then do it. So I come out and look what I did. I did another mistake. I just pulled out my phaco probe and now the vitreous comes into the AC, and you can see that the capsule has got stretched. So now I get some wisdom, and now I'm injecting a viscoelastic to push the vitreous back. And since I was planning a toric IOL and the haptics were going into the place where the rent was, so I abandoned the idea of implanting a toric, and I thought I'll go with a single piece IOL so that I can implant it such a way that the haptics don't go over to the rent part where there's a deficiency of the posterior capsule. So once I start my vitrectomy, and you can see that all the nuclear fragments which had gone inside the vitreous, they came back, and I was lucky enough to eat away those nuclear fragments with the help of my vitrectomy. I go ahead and do my cortical cleanup, and as if one rent was not enough on this particular day, if you can appreciate here, there's a second rent. This one, if you can appreciate, there's another rent. Again, I'm very careless. I just come out, instead of injecting the viscoelastic, I go again with my irrigation aspiration cannula, and there's a fluid misdirection and the rent increases. I thought, okay, it's okay, I'll convert this particular rent into a rhexis, and maybe I'll still go ahead with a single piece IOL. So I'm converting it into a rhexis. So posterior capsular rhexis done, and I thought I've done a good rhexis, but I forgot to take care of this particular point where it was still a tear and it was not a rhexis. So I am planning to insert a single piece IOL, and I thought that I'll keep the haptics in such a way so that I have a full support for the haptics, and I can still implant it in the bag. I enlarge the incision because I don't want any stress, and as I inject my IOL, the whole of the posterior capsule gave way. And I have a tear extending from one end to the other end. If you can appreciate, the whole of the posterior capsule is here and it has given way throughout. So what you do next? Okay, so your single piece IOL is inside. So I then change my plan and I implant this into the sulcus. And we all know that a hydrophobic lens in the sulcus is a time bomb. So I thought, okay, let me take a chance. So I do all vitrectomy, and then I do an optic capture. I can visualize that I have beautifully captured the optic on this side. You can see that the anterior capsule is over the IOL, but on this side I was not able to visualize, so I put in some phenocaine, I dilate the pupil, and then I do an optic capture on this side also. So now I have a beautiful optic capture with just the haptics lying in the sulcus. I do a check of any vitreous in the anterior chamber with the help of Kenacort. There's no vitreous. I close my case here, and this is how I came out of a double trouble. Thank you very much.
Thank you, Dr. Arun, for the excellent video showing all the minute details. Next speaker will be Dr. Samresh, discussing about traumatic cataract management. Thanks a lot. Once again, thanks Dr. Ratnesh. I would like to thank Dr. Sonu and Team Anand Eye Hospital and JOS for inviting me. I'll keep it brief to one case in the interest of time. So we'll discuss this case that landed in my clinic, a young 17-year-old who's had trauma about a month back with penetrating injury. When the patient came to us, it was a near total cataract and the AC had split. So this is how the patient looks. There is an entry wound which is self-sealed. Some iris has been shaved, and you can see that the anterior lens material is flocculated and it's lying in the anterior chamber, and the anterior capsule is split. And it's a young patient, and this is the UVM scan showing the anterior capsule split, but it looks like the posterior capsule and the zonular integrity is intact. And this is on both the axes showing the same picture. So we decided in a young patient, or for that matter in any patient, it's important to try and maintain the anatomy as much as possible and aim for a long-term outcome, particularly in eyes which have been traumatized. We created a nick and we started with the capsular excess. We tried to fashion it as much as we can, keeping in mind that there must be an area of split and then encompassing it. Now, since it's a young cataract, there is really not much of nuclear sclerosis in the patient's eye. So we ended up doing a bimanual IA. Even when we do an IA, it's very important to keep your parameters in check. And if you notice, we've kept our bottle heights. This is not a gravity-fed system, which is showing an IOP. But because if the moment you increase your bottle height, if you have a bottle-fed system, you're going to increase the pressure in the anterior capsule, and that's going to cause a split, or that's going to cause a posterior pressure on this. And always good to do a viscoelastic exchange when you're changing your instruments, because you don't want this anterior capsule split going posteriorly. Just to pause this, once we cleared off the anterior the capsular bag, the challenge for us at this point in time is to place an IOL in this patient's eye. Now we can put a sulcus lens, we can try and put a lens in this capsular bag, but we know for sure the moment we try and put a hydrophobic lens in the capsular bag and any of these edges goes posteriorly, you'll land up losing the bag, and the chances are you'll have to do a full 3-port pass-band vitrectomy and do a scleral fixation. So we decided that we're not going to do an in-the-bag implantation just like that. So here we notice it's an intact posterior capsule, and we initiated a posterior capsular excess. The idea is to do an optic capture just like Dr. Kshetrapal sir showed. But in the posterior capsular excess, it's important to get the sizing of your capsular excess right. And it's not easy because it doesn't behave like an anterior capsule. It's a little flimsy and it needs to be pulled upwards and pulled outwards so as to get the right sizing done. Also, the important catch here is to make sure that you don't disrupt the anterior vitreous face. Because if you disrupt the face when you're picking up the posterior capsule, you'll end up losing vitreous and doing a vitrectomy, and the primary purpose of creating a barrier effect may be lost. Again, if you notice, the anterior capsule is a little bit less on this side, so we decided to extend the anterior capsular excess. Once we extended the anterior capsular excess, our choice was a 3-piece lens, because worst case scenario, we could pop it up into the sulcus and leave it there. So here we are dialing the 3-piece lens into whatever capsular bag remnants are there, and then slipping the optic behind the posterior capsule. So the haptics are in the capsular bag, but the optic is going behind the posterior capsule, firstly on the inferior side and then on the superior side. Notice how we are just gently sliding it, trying to be mindful that we don't disturb the vitreous. Although it can be disturbed, so it's always a good idea to check for vitreous when you do surgery like this using triamcinolone, as was shown previously by Dr. Kshetrapal as well. Since there's no vitreous, we decided to give it a thorough wash and take out all the viscoelastic. Also because it was a larger incision, because we have put a 3-piece lens and we put it using a holder-folder technique, we had to be better suture the lens. If in the slightest doubt, particularly in younger collapsible eyes, it's best to suture off even the side ports, but this eye held well. And this was how the patient looks post-operatively. Just to show you how optic capture works. So this is just a model made by us just to understand, where we've got this is one of those things that you use for crochet when you tie up the cloth in it. And we've created an anterior and posterior capsular excess in this plastic bag. And we're just trying to see the stability. So the haptics are in the capsular bag, but the optic has been pushed behind both the plastic holes, just to see how stable a lens would be. And not even under circumstances like this, but even if you shake it vigorously, notice how the lens is completely locked in once you do a posterior optic capture or an anterior optic capture, and this lens is going to be stable, and the compartmentalization between the anterior and the posterior is going to be maintained, so chances are late post-op complications in such eyes will also be low. So to conclude, optic capture is a very good technique, doesn't require too much of skill once you get to a few, particularly if you land up in a situation like this.
Most importantly, in younger eyes, it avoids visual axis obscuration and inflammatory sequelae that would normally happen by placing the lens in the sulcus. Thank you.
Thank you, Samresh, for keeping it short and sweet, and your animations and models of videos are always wonderful. Thank you. Next is Dr. Vishal Agrawal, and he will talk about Farm Fresh X, management of subretinal cyst.
Thank you, Sonu sir, and thank you, Anand Hospital and JOS for having me here. Unfortunately, the only interesting thing vitreoretina has to offer is lots of cysts and eggs, and it happens that I have them in abundance. I mean, not cysts per se, but videos of cysts. And we should just. So I'll be showing. I'll be doing a voiceover. Two extreme presentations of the same disease, that is subretinal cysticercosis. And I presented around 8 or 9 before in front of this audience. And these are farm fresh because these are the recent produced. And this case presented around 2 months back, and the left eye was involved, and you can see the patient was diagnosed as posterior pole choroiditis and was treated with steroids for the same without any improvement. The vision was around hand movements. This is the left eye, and the patient was actually worsening since the last visit somewhere else, and we diagnosed it as a subretinal cyst, and the location was very precarious because it was very near the fovea, and as you can see the movement of the cyst, it was a live cyst, and with the light directly reflecting on it, it shows the movement. So the point here is that the location is very near to the fovea, it's actually submacular, so we have to take care while removing it to cause minimum collateral damage. The second problem is that it is a young patient, so the posterior hyaloid, the hyaloid is very sticky. It's not loose as in adults, and it has to be removed very carefully because it is densely adherent. So normal cutter section did not work in this case, so we used a forceps. This is an end gripping forceps. So after staining the vitreous with triamcinolone acetonide, we used the forceps, created a cleavage plane, and now you can see the fluid wave. So the hyaloid over the cyst was not just aspirated with suction, but it was gently teased out away from the macula. If a lot of suction is used and there is already edema over the fovea, it can lead to a full thickness macular hole. So after clearing the PVD, after clearing the vitreous, now we have to tackle the subretinal cyst, which is near the macula. As you can see, again you can see the movements because of the light. So away from the fovea, we made a small diathermy spot so that it does not bleed because it was near the arcade. Care was taken. It should not be it should not be large because after it scars, it can encroach the foveal center, thus compromising the visual acuity. And after that, as I move with the fluid needle, it goes away from the fluid needle, and I cannot go much inside because of the fear of enlargement of the cyst and bleed. So I just tug it with the fluid needle towards the retinotomy side, and finally I catch hold of it. And you don't need any active suction. With its amoeboid movement, it comes out passively, and the hole is also not enlarged. And you don't need to remove it in toto out of the eye as we were taught before, because they do not cause much inflammation. You can eat it up inside the vitreous cavity, and it's done very easily with the high aspiration cutter these days. And finally, this is like a surgical retinotomy, and we go under air, we aspirate the subretinal fluid through that retinotomy. We don't make any other retinotomy, and because it's not very small, so we mildly laser it around. We do a mild laser around the retinotomy and use a short-acting gas like SF6 as a tamponade. And the results are brilliant. We have a normal foveal contour, and the patient is 6/6 in this case. The second case is again of a subretinal cyst, and this time the location was not the posterior pole, but the far periphery, just near the pars plana. So this female presented in the right eye with dense vitritis, and when we did the vitrectomy and cleared a lot of vitreous, we saw a encircling band, whitish band, encircling the whole 180 degree of the nasal periphery. Extreme periphery near the aura, and this subretinal cyst was actually incarcerated inside the retina. So there was no point, there was no way of just pulling it out without pulling the retina also along with it. So we just created a small retinotomy first, so that the fluid ingresses into the subretinal space, loosens up the cyst, and then we created a second retinotomy to pull it out. As it was a very long structure and it is elastic and it is live, so it was coming
it was going back inside the subdental space. So we used a combination of forceps and the section from the cutter to a combination of these two instruments to tease it out gently so that it does not break and a portion of it does not remain into the subdental space. Because a small portion, if it remains in the subdental space, it will be very difficult to remove that. So finally we took it out in toto, and you can see the whole cyst, bean-shaped cyst. And again, we did not remove it out, out from the vitreous cavity. We just aspirated it inside the eye. And this case had two retinotomies. They were in the far periphery. They were infero-nasal in the location. So we lasered it. And in this case, we used oil as a tamponade. So to conclude, subretinal cysticercosis poses unique surgical challenges, can masquerade as uveitis, and early intervention can lead to excellent results. Thank you so much.
Thank you, Dr. Vishal. So we have one more speaker who is about to arrive, Dr. Om Prakash. Meanwhile, we can have question and answers to any speakers. And I'll request Dr. Vishal to just collect his certificate by Dr. Anil Kothari. Request Dr. Anand Parsarthi to come and collect, sir, please. By Dr. Ashok Singh. Dr. Arun Kshetrapal, Dr. Samresh. Dr. Nalini to give us. Do we have any questions? We have few speakers here.
So Samresh, I have a question for you. You did a very good capture in traumatic cataract, but not in all cases of traumatic cataract is capture possible. So which are the cases where you would not like to capture?
So, madam, if I'm not confident, I show this video because I could capture, otherwise I wouldn't be showing it. But normally, if I can complete a capsular access, I would have captured it. If I had lost the capsular access here, I would have done a vitrectomy and gone in for like a Yamane fixation or maybe a scleral fixation, suture scleral fixation in this, because there is no point in leaving a sulcus lens in a 18-year-old child because it's going to cause a problem later. So wherever I have doubt that I'm not going to cause a posterior capsular rhexis, or the rhexis is so bad, or the posterior capsule is compromised at a level where it cannot be recovered, I will not go ahead with the capture.
And what is your cutoff for anterior vitrectomy in children, in general?
I would prefer to not do an anterior vitrectomy.
So now you don't do for any age?
Like for pediatric cataracts,
Pediatric.
We try to do anterior posterior capsular rhexis and optic capture as a primary, even for a pediatric cataract surgery, rather than going in for a anterior capsular rhexis lens, and then we used to do a pars plana posterior capsular rhexis. But our primary hope is to do a posterior capsular rhexis and capture and avoid any vitrectomy.
No anterior vitrectomy?
No anterior vitrectomy.
Any other question?
Before making a small puncture and putting some viscoelastic under the
That's a great point, madam. We learned posterior capsular rhexis under Dr. Marie Jose Tassignon, and she uses a 30 gauge needle or a 36 gauge needle, very fine needle, to inject visco to create a blister. But it doesn't work in my hands because that needle is so flimsy and it's so fine that you need really good dexterity. Only she can do it, to the best of my knowledge. But the trick is to not put the cystotome vertical, but to keep it on a slant and just lift up the posterior capsule rather than pressing it down, and that's where you create a leak.
Thanks.
Prefer 3-piece or 1-piece? Posterior, capture.
So again, because half the capsular rhexis was missing anteriorly, worst case scenario, I would have slipped the lens anteriorly piece. So if I'm very sure that my capsular bag, anterior and posterior rims are intact, I could put in a single piece as well. But a 3-piece is an easier lens to capture also.
Thank you.
We'd like to have Dr. Namrata's opinion also regarding the anterior vitrectomy, up to what age you do.
So I think we do anterior vitrectomy, and that is very much after Dr. Vasavada's papers himself. I remember he did publish a paper where he said that optic capture causes more reactions in children, and so we all gave it up. In fact, almost everybody gave it up. And now there was a subsequent paper in the more recent publication where he says that optic capture works. But I think that's because the technique and the technology, I suppose that is the explanation, or Samaresh, you can tell us the explanation.
Also, madam, a maturity of the skill set, because I think again it involves a lot of faults coming up and going, and eventually over time the learning curve is a little steep for learning posterior capsulosis. But now, like we said, we're not able to achieve in all the patients. So, at the moment we see there's a vitreous disturbance, the plan is to go ahead with the vitrectomy.
So for us, for all pediatric cataracts, less than 4 years, we are still doing anterior vitrectomy. 2 millimeters behind and 2 millimeters all around, and of course anterior rexus, posterior rexus, and then a capture.
Rexus with a forceps.
Rexus with a forceps. You can do rexus with a forceps. Of course, you can do a vitrectorexus also, but I think the edges of vitrectorexus are never as, they don't have that much strength as your capsulorexus, which you've made it manually.
So if you're doing a vitrectorexis, you do an IOL implant and then go past an IOL.
So I have a question for Dr. Parthasarthi. So if we have to make a big bubble after doing femto, then we might as well make a big bubble right in the beginning. So can you just tell us the advantage of first doing a femto and then making a big bubble? Except for the fact that you would probably have a better configuration of the wound.
So I think the concept of the sutures is important for me. So what we find is when we're doing a femto-assisted DAC, the aim is not to get the big bubble. The aim is to get a deeper depth of the. What also we find in the keratoconus patients, what happens is sometimes once you do the femto cut, because it's coming into, you're doing a shaped keratoplasty, it's within the 6 millimeters zone. Sometimes you don't get the big bubble, you do a manual dissection. But I'm okay because I have access to an OCT. I'm okay with leaving about last layer 20-30 micron. That's okay. Now, the shaped keratoplasty helps you reduce the number of sutures. So it's usually about 8 sutures you can actually finish the whole surgery. What is probably more important is the depth of dissection with the femtosecond. I think that's important, that anything beyond 200, 250 microns of the time, I think I'm sure you also cannot actually do.
Thank you. So Vishal, you have all your Sistri circus dancing to the tunes of your flute, and all of them, seem to get attracted towards the flute that you use to aspirate them. What would be the incidence of subretinal Sistri circus? I mean, is it very common or?
No, sir. The
subretinal.
It's very rare.
Rare.
It's very rare. So one is a case report from PGI and one is from AIMS, and I could not find any. There are case series, but submacular Sistri circus are very rare. And the second question you asked me, that why I am showing all these cysts, because I think it goes everywhere. Everybody is operating. It's not a very difficult surgery. But many people are not documenting it enough. So I just document and present. That might be the difference.
Thank you. We'd like to welcome Dr. Rohit Om Prakash, and he's talking on polar bug.
Celebration conference. So I have been assigned to talk on the polar bug. Well, as all of us know, posterior polar cataract is a big bug, and the answer is good intraoperative planning and good sided stepwise treatment. Well, there's a 100% incidence of PCR if the anterior segment OCT shows conical morphology or moth-eaten morphology, and a 66% incidence of PCR if there is a double nodular elevation and a V-shaped configuration. This is all RP center thing which is helping us, and a 1.96% incidence of PCR if there are no hypo areas. Well, the site of incision is very important. If the PCR is there, it should not be in line, it should be at an axis to the axis of the PCR. A calibrated side port incision is obligatory and mandatory to have stable chamber setting and no fluctuation in the anterior chamber whatsoever. That is a very important factor. The rhexis which I plan is an oval rhexis wherein the large rhexis arm gives the advantage of no rise of intracapsular pressure. The safe end-to-end sculpting, easy division, easy subincisional cortex and smooth IOL implantation, whereas the smaller rim gives the advantage of easy IOL optic capture, nucleus bag retention. Well, this is a patient where there is an intact PC. It's a young individual, and what has to be done is the layer by layer delineation has to be tried as put forth by Vajpayee et al. So I'm trying to create different planes, different layer by layer. 4 layers have already been created. I'm trying to take out the inner core, which is giving me the advantage of 3 layers which is protecting the posterior capsule. Now the second layer is being taken out. I'll try to take out the 3rd layer as such. And now I'm using epinucleus as a shield, wherein I'm trying to dislodge the cortex from all sides, but I'm leaving the epinucleus as such, which is guarding the posterior capsule. So the posterior capsule has to be guarded till the end, and you will find the posterior capsule has not been exposed to the fluidics whatsoever till now. And you will find now at the end the posterior capsule has been exposed, but the posterior capsule is intact. Herein I am trying to use the escape route which Bob Osher really explains well. This gives early and easy removal of the epinucleus. This is another patient wherein there is a moth-eaten morphology in a 32-year-old male with a very distinct posterior capsule rupture. So in this patient, what is going to happen is I have done layer by layer delineation. I do not do inside-out hydrodelineation in a capsule which is not intact. Stable chamber settings as should always be done. Now I will use an epinuclear shield to protect the posterior capsule from the fluidics. So, till this stage, the posterior capsule has not been exposed. No doubt there's a rent in it. So what is going to happen is once it is dislodged, then only I'm going to take it out. Now I'm going to do, trying to, round off the capsular rhexis. Now what is being done is just to see whether the vitreous is there or not, which was not there, it was intact. Now I'm going to do the optic capture. So this optic capture has been done. This is another patient wherein there is a moth-eaten, you can see very well, you could see how the posterior capsule was, there was a rent. I'm going to use 20 IOP with 23 to 26 fluidics. So this would go to bottle height of around 27 millimeters. And this no hydrodissection or delineation was done. I could not chop it nor I could divide it. So what I'm going to do is I'm going to do debulking and centripetal manipulation of the nuclear and the epinuclear mass. You can see the IOP is 30. I'll reduce it as and how the time will pass to around 20-24. Stable chamber settings. Now the next step is the visco separation will be done. Once the visco separation will be done, it will ease out, it will separate it from the posterior capsule and keep the vitreous away. You can see how visco separation is being done. Now I am trying to manipulate the nuclear epinuclear mass so that I am able to, the IOP at this stage is 20 and the flow rate is not more than 23 to create a stable chamber settings. Now you will see how it has been duly taken out. The posterior capsule rupture, you can see stable chamber settings. Now I am going to do, dry aspiration, which was propagated by Gills and Welch way back in 1990s. So you can see now I'm using the side port to my advantage because I do not want to use the main port because that can create unstable chamber settings. Now once it is there, you can see now the vitreous, translanon staining. Vitreous was not there. IOL capture has been done. The slit lamp examination shows how well centered the IOL is. This is another V-shaped morphology which shows that there is a predisposition. I'm using femto 4.6 millimeter capsular axis size. Sextants have been created. 750 millimeter safety margin of the posterior capsule has been done. So what I'm going to do is I'm going to do sculpting at this stage, partial sculpting, partial valley, separational movements, not wide. And now I'm going to take the central nuclear core. The peripheral part is acting as a shield for the posterior capsule. So this helps in taking care of protecting the posterior capsule all the way. You're not exposing it. You're using low IOP. You're using low fluid settings. This is another patient wherein there's a nuclear sclerosis grade 3. So this is something where you will find this is another RP center. This thing you will find a central cortical disc. This shows that by all means the posterior capsule would be intact. And you can very well go ahead and you will find that it could be done. This is a double nodular elevation which was found in this patient, and you will find that there is some predisposition. Here what I'm trying to do is what Saurabh Patwardhan has shown, the sideways sculpting. I find this very relevant in patients who have nuclear sclerosis. This is cross chopping which has been done, and now no vertical chopping has to be done. So this is another patient where you have to believe that all is not over until it is over. Now while doing the IOL implantation till this stage everything was intact. So just a small depressing of the IOL and you will find that the posterior capsule has given way. So all said and done, we have to be very careful when it comes to posterior polar cataracts. Thank you very much for your kind attention. Dr. Namrata, I would like to, thank RP Center.
Thank you. No, we have to.
It has eased posterior polar cataract to such an extent, this anterior segment OCT, how you have defined.
Yes.
And that has made life so easy.
Thank you so much. Thank you for that wonderful presentation. I think it covered almost everything that has been described, as well as your own way of doing it, which is so elegant, like I always say. And definitely excellent pearls. Any questions on this? Because anybody would want to comment or say something or give comments on posterior polar? I think
I'd request Dr. Rohit Om Prakash to collect his certificate from Dr. Namrata Sharma. And thank you. I'd like to thank all the panelists and chairperson. It was a wonderful session and we could get in time. Despite getting late, yeah.
We just relay live from the operation theatre.
I welcome Dr. Devashish Bhattacharya to the house, and we are just about to start the live surgery session. Before that, we can have a 5 to 10 minutes break for the refreshments. We will reassemble after 10 minutes.
So, I'm thankful to Jaipur Ophthalmological Society and thankful to all the STs who have made it to Jaipur and have blessed us with their clinical, surgical and academic skills here. So first in row, we begin the live surgical session here, and we have none other than Dr. Haripriya, and she's traveled right from Chennai, head of Arvind Eye, a dynamic surgeon, and I think let's see the surgical skills. So we'll introduce the patient. Dr. Sonai Mukherjee would do the needful.
A very good evening, ladies and gentlemen. Myself, Dr. Shanai, and we are starting with a 62-year-old lady. Can I have the slide, please? Thank you. Can I have the next slide? So she is a 53-year-old lady for the left eye cataract surgery. She has a dense PSC with grade 2 nuclear sclerosis, with a vision of 636, with best corrected 612, normal fundus and a normal specular count, with a lens power of plus 21.5. Dr. Haripriya madam will be operating on Alcon Centurion vision system, and the IOL which will be implanted is Nanix Multicell. Thank you. Ma'am, over to you.
Sonu Goyal and the entire team of Anand Eye Hospital and GOS for having me here. It's always a pleasure. And I think all the OT staff have been very friendly. I'll be operating on this 53-year-old lady with a dense subcapsular cataract. I'll be doing a phacoemulsification procedure through a 2.2 millimeter incision. Center towards me. So when making the incision, I like to have my heel down and tip of the knife up. Am I audible?
Yes, you are audible. You are audible.
So that is the incision there, and the side port about 2 clock hours from the main incision. So this patient is a nuclear sclerosis grade 2, dense PSCC, but I'm still using Viscoat. Normally I only use Viscoat for the patients who have grade 3 or above or mature cataracts, Visco. And I do a soft shell technique. So Dr. Steve Ashnoff's soft shell technique, Visco. Where he recommends using a dispersive viscoelastic and a cohesive below that. I use HPMC below the capsulotomy needle, below the Viscoat. Drops on the cornea, please. Can I have a little center? Yeah. Okay. So I normally use a capsulotomy for the rexus. This gives me good control. If the rexus goes to the periphery or in intumescent lenses, I prefer to use the forceps. So 2.2, I think the epsilon micro forceps is the one I like to use. Get some of the visco out so the chamber is not overfilled, especially in a dense PSCC like this. So I'm first injecting, doing a hydro dissection. I'm doing a very minimal hydro dissection, more of a hydro delineation here. It does not look like a posterior polar, but however I'm being a little extra cautious. So the golden ring is seen. We see 2 rings here, and the inside ring is the endonucleus visco. Or a whisk. Yes, please. Did you have Phaco? So I'm using the Centurion machine with a 2.2 tip and sleeve, blunt chopper. I'm going to do a horizontal chop here. So this is a straight chopper with a blunt tip. So with the Centurion machine, there's a new add-on. The Centurion, as you know, already has the active fluidics. In addition, this is also the active sentry, where the sensor is in the handpiece, so it responds immediately. Epinucleus. Can you center the eye, please, sister? And some drops on the cornea. Yeah. So I'm first trying to remove some of the epinucleus here. In the horizontal chop, one can just place the chopper up to the periphery. So I identify the lens, go under the rexus, scratch to the periphery, support in the center, and then bring the chopper towards the center and separate. So this splits the nucleus. So we repeat this. So before I emulsify, I take it out of the periphery. If you see, I'm in foot position 1. So I don't have to use any power or vacuum here. So just take your chopper down, all the way down, and then bring the chopper here. This mechanically splits the nucleus. So the advantage of this Centurion system is that one can preset the IOP. So that it's there between the plates, and that will help to tell what will be kind of be closest to the physiological IOP. The IOP I've set here is 44, but one can even go a little lower if they want to. Can you have a center, sister? More towards me? More towards me? Yes, perfect. Thank you. So when emulsifying these fragments, again you would like to emulsify them at the iris plane. So break them into as small, of course it's a soft nucleus, but I like to break them into very small fragments and then emulsify these pieces. So once the endonucleus is out, again with the same phaco probe, the epinucleus can also be removed. I have done only a mild hydrodissection here, so this is not going to come out fully. Red glow, sister? Microscope red glow. Yeah, but I can repeat the hydro once more, IA, hydro and IA. So because the epinucleus is still there, I would still do a repeat hydrodissection. This way the epinuclear bowl will also get loose and it's easy to emulsify this. IA probe, Sinski hook. Yes, cortex. So irrigation, aspiration, I'm going with the cortex mode, but because it's epinucleus, can we go to the...
So there is a epinucleus mode also in this machine, isn't it, Haripriya? So if you are with the phaco probe, you can go with the epinucleus mode, and if you are, this is the, I think, irrigation aspiration handpiece that you're using.
I'm sorry, can you please repeat your question, ma'am?
So I'm saying there is a epinucleus mode in this machine, especially if you're if you're using a phaco probe, then you can use a epinucleus mode also.
Do you know what the question was? I'm not able to...
You're not able to hear?
There are some... can you please repeat the question?
So it's okay, the epinucleus is gone. So
I the cortex oppositionally as well with a straight IA tip. I just change the direction of the aspiration probe towards the cortex. Sarai? So now to remove this small bit of cortex, I just, use this fluid jet with a hydrocannula, and this will help to dislodge. I don't have to go and use the IA probe and go close to the PC. So here you see the PC gets cleared, all the LSCs are nicely washed off, visco and lens. Visco. I didn't get your question. Can you please repeat the question for me, ma'am?
Yeah, so I was saying there is a epinucleus mode also in the machine, which if you're dealing with the epinuclear cortex, then and you are using a phaco probe, you can use the epinucleus mode on it. So all your parameters will go down a little bit, and it'll get easier to aspirate.
Absolutely. No, I have just used the epinucleus mode for my regular phaco. But yeah, you can have it all set. You know, if you're using a harder lens, you can have higher vacuum set. So it depends upon the cataract. One can change the setting, so you don't have to do too much of alterations during the procedure. So I'll be implanting an Nanex lens here. The Nanex lens is the lens from Hoya, which is a monofocal aspheric lens. Can I have a bigger cannula?
It's a preloaded lens, no, madam? Preloaded lens.
So this comes with the multi-cert injector. And the multi-cert, they call it multi-cert because one can either use the plunger or can use the rotator. So both of this is possible. And this also goes in, it's very small, it can go in through a sub 2 millimeter incision all the way inside. Sinsky? So here I like to do the plunger, so I always have it wound assisted, but this does not need wound assistance because the cartridge goes inside the wound. This is a hydrophobic acrylic lens, so you can see the lens goes in. Light dekhiye ma. So you can see the lens actually sits in quite nicely, goes into the bag. INA probe.
Excellent surgery, madam. Dr. Kudlu here from the auditorium.
Thank you.
Madam, I could able to see whatever the leftover 1 or 2 cortical fiber just before the injecting IOL, you just did a small amount of hydro with the saline with the 26 whatever the cannula, and you could able to remove that whatever the small bit of cortical matter over the PC.
Someone understand the question? I'm sorry.
No, KP wants to know that you flushed the posterior capsule to remove the fibers that were sticking to the posterior capsule. So actually we also do it. It's a very nice thing, and the PCO rates come down quite a lot because there's some fibers which you can never actually get by polishing the with a eye cannula.
Right. Yeah. So yeah.
Just
flushed out using a 26 gauge cannula. But as we speak, I think we just missed that part, the way the IOL sits right inside the bag and the way it unfolded. I think there's just one important point to mention out here. Gone are those days when we were fearing a rapid unfolding of the IOL with the hydrophobic, in the hydrophobic market. None of the IOLs rapidly unfold anymore. But some of them do unfold a little slower than what we want them to. So this is one platform wherein the unfolding is just right. It's neither too fast nor too slow. It just allows us enough time to tuck in the trailing haptic into the bag, and then it opens up very, very nicely indeed. So and the centration is very good. The post-operative stability is excellent. The refractive predictability is excellent as well. The material clarity remains so for quite some time. I mean, we don't have a follow-up of approximately 10 years now with these IOLs, but I mean, whatever we have followed them up for, it is very good.
Anurag, the one more advantage with this lens, it go through 2 mm incision. So most of these hydrophobic lenses, we need to have 2.8 mm, but this is probably the thinnest of the tip the lens can go into the bag.
Yeah, so I think this patient just finished the surgery. I also like to position the IOLs horizontally. That way it also helps to reduce the dysphotopsia. The other thing is to polish the capsule as much as you can. Please remove the lens epithelial cells. Also to remove the viscoelastic from behind the IOL, because that also helps the IOL to adhere to the capsule much faster. That is also quite useful to do.
Yeah, there was a wonderful tip from Dr. Haripriya that actually we should align the lenses like this, because there's a paper from Bonnie Anderson which says that lenses which were aligned like this towards the 3 o'clock or 2 o'clock, they have less amount of dysphotopsia. So
The mic on or?
yeah.
Yep. I'm sorry, what was the question?
No. We were just taking your very good point that you align the lens
Right.
horizontally so that the negative dysphotopsias don't occur. This was a nice paper by Bonnie Henderson, which retrospectively studied that the patients who had their IOLs aligned in this way did not have this negative dysphotopsias.
Yes, I think there's a recent paper, I think about 2 months back in AJO, which also showed a significant reduction in dysphotopsia when the IOL was horizontal. So it has been proven to be beneficial. That's something which we can do easily as well.
Yeah. Thank you, ma'am, for a wonderful surgery. Thank you very much. We all enjoyed it thoroughly. Can we have a clap for Dr. Haripriya, ma'am?
Having discussed about the orientation of the haptics, where we are not at liberty to do that would be the toric implants. So, wherever we are forced not to place them horizontally, do you have any observation in that regard? If they are not placed horizontally, like in torics, how many?
No, Anurag, it's just that, the paper that I have read is that with negative they have studied a huge series, and the lenses which are placed between 9 and 3 or a little towards the upper side, a little diagonally, those lenses, the patients had much less complaint of negative dysphotopsia. That is, in torics you can't help, you have to place the lens as is required.
So the reason why I was asking that question to ma'am was since she does such a large volume of toric implants. So I was just trying to know from her whether she has observed that if the haptics are not placed horizontally, how many of them approximately do complain of ND? Is what I wanted to know from her, if she has anything to say in that regard.
Yeah, so actually the good news I think is that most patients, out of 100, maybe 2 or 3 complain of negative dysphotopsia. And toric, we place them vertically only in patients who have with the root or maybe oblique. So that is a much smaller number than most of our patients. So we don't do that many vertical implantations. So we have a much smaller denominator. So considering that, we don't see many patients who actually come. I think my mic is on. My mic is on, yeah. So we don't see that many patients. I haven't actually looked out for it, but it'll be something good to, look at more keenly and check if they are probably more symptomatic or not.
Just going out of this particular zone, should you have an ND which persists and the patient's not relieved of it, what's your preferred mode of dealing with it?
Normally, it's just reinforcement. I think most patients do well over the course of time. So we don't do any intervention as of now. Yeah. I think that way we're lucky. Our patients are not very demanding. They understand and they're patient. And after a couple of months, most of them feel fine. So I don't normally do anything for those patients. Just spend a little more time and talk to them. And once they know nothing to worry and it'll be fine with time, I think most of them are accepting. Do you do something in your practice?
I have had an experience in 2 patients wherein it actually remained even after 6 months of the primary surgery, and they were not at all happy, so I had to intervene. So I put in a 0 part, neutral part, multi-piece IOL in the sulcus, and then it vanished. So I do have experience only in 2 patients though, and both of those patients luckily were monofocal implants, so the expectations are not huge.
Okay.
Luckily, as you, I have also been saved of having this in any ATIL implant, so God knows how would I satisfy them should that happen in one of those implants. But no, it's not happened. But 2, I have implanted a 0-part multi-piece IOL in sulcus. Any other questions for Haripriya ma'am from the audience? Yeah.
So, why I have gradually drifted to these preloaded IOLs, do you actually feel that it's worth when it comes to respect for the wound size, wound incision, you know, the high volume that you do, and sterility reasons? So I think it saves a lot of time. So in my practice, I think it really worked wonderfully. So I think it's a message to the entire industry that I think the preloaded is the next gen to come.
No, I completely agree with you. I haven't done these lenses for long, so I just tried them recently, and I was very happy with the injector system. And the fact that it has both an option of both, you know, if someone likes to use both their hands and rotate, it works well. Plus, you don't put stress on the wound. You don't have to, you know, actually do a wound assisted. It goes in comfortably. All of that actually is very good. So I was very happy. I think this is the way to go. I think more and more we look at lenses which are preloaded. They are, of course, safer, easier, and, you know, if you have the right model, that is the way to go.
The last question, you have a paper, I mean, that is a lot of talked about paper. So one good message that you give to all ophthalmologists in Rajasthan, do you recommend intracameral to all routine patients, or it is just that select few? I mean, out of your very interesting paper that you have published, I think that's a landmark paper. So any kind of message that
if you ask me, I will say all patients. No doubt.
All patients, all patients.
Patients,
So I think welcome Dr. Devasi sir, Dr. Sonopal Desai. Thank you so much sir for all the way traveling to us, and thank you, really, we are grateful to you sir.
Thank
so
you,
I think
sir.
one good message that Dr. Devasi, Dr. Haripriya is trying to convey is that intracameral moxifloxacin preservative free is the way to go in routine phaco surgeries. I think that gives you a peaceful mind.
The incidence is very low.
Our endophthalmitis rate has come down by 3 times. 3 times.
Yes, sir. That's exactly what we showed as well. So 3.5 time reduction. So we have, like, today, it's about 1 per 10,000 surgeries. Which is
Absolutely.
one of the lowest you can have, thankfully. Of course, you still have some risk factors, other organisms and things, but you can break it down significantly.
I think one very key message that she's trying to convey is the use of intracameral antibiotics, and I think that is very, very important. So thank you so very much, and that was a wonderful surgery. I think the house needs a standing ovation for Dr. Haripriya. Thank you so much.
Thank you so much.
Thank you so much, ma'am.
Thank you. Thanks to the team.
Hello.
Thank you for having me here.
Can you hear us? Hello?
Yeah, we can hear.
There is some problem with the audio in the tempo only.
But if we can't hear them, then we don't have to wait.
No, we can hear you, Gaurav. We can.
We can hear you.
Audio to चाहिए ना? Hello?
Yeah, we can hear
Can
you.
you hear us?
Yes, yes, loud and clear.
मेरा माइक ऑन है? तो उधर से तो फीडबैक नहीं आ रहा ना, तो फिर हम उनसे बात कैसे करेंगे? नहीं, मेरी आवाज तो जा रही होगी, उधर से भी तो आएगी ना? Hello?
Hello, we can hear you, Gaurav.
Okay, so there's some, we are not getting audio from the hall. I don't know, can you hear us?
Yes, we can hear you.
Okay.
There's some glitch with the audio. So I think we can start.
There's a loose connection, is it? आप देख लो एक बार, यहाँ check करो. Speaker का.
Yeah, we can listen, Gaurav. You can continue with the surgery.
Okay. So, if you don't hear him, then please call us up and tell us that you can't hear us. So, I think you want to introduce the patient. Okay, so we have this nice lady. She's a diabetic, well controlled now. She went on to develop a cataract over the last 1 year, and she has NS grade 2 to 3.
current vision is 612. She has a small astigmatism which we are going to correct with the femto LRI. So for very small astigmatisms like between 0.5 to 1 diopter, sometimes I might choose to do an LRI, but most often I will try to shift to a toric lens even for the smallest of astigmatisms. And she has a healthy endothelium, she has a mild NPDR, so she has not been selected for a multifocal implant. And she has, you can see the K readings over there, and we are planning to do a femto-assisted surgery over here along with a BBNX multi-cert lens implant. So I will be happy to show you this is an upgraded catalyst with the latest software. And as you can see, it will have, once you've entered all your data, and then it has the option of feeding in the astigmatism. This is a new feature in the new software where you can put in the astigmatism and the steep axis, and then you can go back to the regular thing. And then I'm planning to do a 5mm rexis, which is centered to the scan capsule. I'm going to do a 6-quadrant crack. This is my preferred method of doing it. And if you want to see the details of this, you can actually see all the details here. For example, I'm doing only one segment repetition over here. And these are the energies with the 500 microns offset, as you can see over here. So that's all standard, and we don't normally change it unless there's a posterior polar cataract where you might want to have more offsets. Then going on to the LRI, which is basically the newer feature. We could always do the LRIs, but we never had inbuilt calculation capabilities. But now the catalyst, as they call it, as the Apple phone or the iPhone kind of user ease, and one of the best laser platforms in the market today. You can actually go and plan the thing from the Arcuate Centaurix as an inbuilt calculator now using the Donenfeld nomogram. And you can see that once that data was already fed, we just push calculate, and then it can be fed in here. So you can see that we are doing the LRI. I don't now like to do the incisions with the femto. I used to do it a lot in the past, but it tends to kind of slow me down a little bit, and what we really need is what we do over here. So this is the plan. We have an LRI, we have a rexis, and we have a 6-quadrant crack, and then we are all set with the... I hope everything seems to be in place now. Can you hear us still?
Yes, we can hear you. Can you hear us?
Now we can hear you also. Any questions so far? And we are setting up the pack. So for me, the femto-assisted procedures have become a choice of procedure for many complex situations like pseudo-exfoliation, very shallow, you see, with hard brown cataracts, posterior polar cataracts, patients with operated RK incisions, all these intumescent cataracts, all these indications are, for me, they're very, very important for performing a femto-assisted surgery. And it definitely makes it much safer and more predictable for the patient. So we are placing we've already set it up with all the, it's a liquid optics interface. So we are setting up, आप इनकी उंगली को देखिए, दोनों आंखें खोल के रखिए, इनकी उंगली की तरफ देखिए, दोनों आंखें खोल लीजिए, उंगली को देखें, दूसरी आंख खोल लीजिए, टॉर्च को देखिए, इनकी उंगली को देखते रहिए. एक मिनट, थोड़ा सा नीचे पैरों की तरफ देखो, थोड़ा सा. Okay, so the vacuum is activated, and now we will be moving this into position, and there it goes. So it's locked into place, and now I'm going to do the dock. Maybe you can see it over there. Can you see the docking? I don't know whether you can see it in the picture or on the main screen.
Yes, we can see. Yes, we can see, Gaurav.
Now it is docked on.
So once the dock is done, you have to be sure that there are no bubbles there, and then you can center it, and then you press capture so that the two interfaces are locked into each other, and then you do the Z-axis lock over there, and then you press on the fluid confirmed. So now it is the OCT, which is a very high resolution OCT. In fact, I love the OCT on the catalyst because it captures everything from the cornea to the iris, the whole thing, including the posterior capsule, and some patients which are quite opaque, you can still capture the posterior capsule very nicely. If you have a posterior polar cataract, it can pick it up. So once it identifies the limbus and the pupil, and you are satisfied with the picking up of the landmarks over there, then you can say, correct the control for the centration of the, at 180 degrees for the pack over there. Once that is done, then it will just rescan for a moment, and then you just click on approve, and once you have approved all the data, you had all the data over there, you can be satisfied with the position of the rexis there, and there it is, the offsets are correct over here. Once you're satisfied, you moved on. And then again, this is showing you the 6-quadrant crack which you're going to do. You can actually change the positions of the cracks now depending on your incision. For me, I'm planning to make a 135 incision, and you can see the posterior offsets and the anterior offsets. If you're happy with it, you can move on, or you could change it at that point. and this is the LRI, which is in good place, and you can see that it's an 80%, 85% depth LRI. So once you are happy, and it's an anterior penetrating LRI because the machine can also do a intrastromal LRI, which I don't use. So we're all set. I'm ready to fire the laser, and I will be pressing the pedal, and you'll be able to see. So if you notice here, you'll be able to see the rexis is already done, and it takes barely a second. That's why it's great for intumescent cataracts and other situations, just in case there are small movements. And now we are getting the nuclear 6 quadrant crack over there. So this becomes really invaluable in very hard brown cataracts and also some leathery cataracts, because you already have cracks. Even in posterior polar cataracts, I love to do this because your nucleus is already cracked in 6, so there are no forces of lateral separation. You are not doing anything to rotate the nucleus, and so we are done with this. It's over in like less than a minute. And
Gaurav, what's your offset, posterior offset for normal cataract and for a posterior polar cataract?
So I think we are all set now. We are going to move this. If there are any doubts or any questions about what the catalyst does, I'll be happy to answer them.
Can you hear us?
I hope you could hear me, and I don't know if the audio is still working two-way or one-way. So we are all set here and ready to transfer you back to the ICLOT. Any questions? Dr. Kudlu, I could hear Dr. Kudlu there.
I am here, Gaurav bhai. It's an excellent procedure.
Who all are on the dice?
Gaurav bhai, can you hear me? Kudlu here.
Gaurav, can you hear us?
Can you hear us?
We can hear you, but can you hear us?
He's not hearing us.
I'm sorry, I can't hear you.
Yeah.
So
okay.
I'm not sure. So maybe I'll be in touch with you from the other OT.
Yeah.
And, okay. So we are moving on to the other OT. Dr. Ramamurthy is probably ready with the ICL, and he will be operating. I'll go and see him there and maybe talk to you from there itself. And I can answer questions from there. Okay. Thank you. आपका बहुत अच्छा हो गया.
वहाँ की कॉल की आवाज आ रही है, आप यहाँ का कुछ आवाज नहीं है. They were asking you, can you hear us? Can you hear us? I was traveling like, sir, आप इधर बोलो, मेरा पास हो.
Dr. Kudlu, what's your posterior offset usually?
Yeah, I don't have the femto cataract machine.
400 for you, sir. And in posterior polar cataract, do you alter your post?
Yeah, I mean maybe 300. Keep another 100.
Hello.
Yes.
Hello.
Yeah.
Can you hear us?
Yes, we can hear.
Can we have the feed to the main OT?
We can hear you loud and clear.
We are done with the femto cataract. So we are starting with the third case, a toric ICL patient. Dr. D. Ramamurthy is going to operate this patient. He's a 29-year-old male, high myop, minus 13 spherical, minus 2 cylinder at 180 degree. His left eye was operated yesterday. A toric ICL was implanted in the left eye yesterday with a good retinoscopy and a good vault. And he is an unfit candidate for LASIK as well as any other refractive procedure. So we proceed with the patient. This is a Vistar Vision toric ICL. Sir, can you please start?
Yeah. Good evening, everybody. Am I heard?
Yes, we can hear you, sir. Can you hear us?
Can I?
Yeah, we can hear you, Ramurthy sir.
Hello.
We can hear you, sir. Ramurthy sir.
Can you hear us?
Yes.
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 In the hall, can you hear me? I'm Dr. Mayank. Can you hear me?
Yes, we can hear you.
Hello? Can you hear us in the hall?
Yeah, we can hear you very well.
Yes, Ram, we can hear you clearly. You can carry on with your surgery.
Can you see the direct feed from the OT? Hello?
Yes,
we
yes.
can. Yes, we can. It's clear.
It's very clear.
यहाँ पे एवी वाले को बोलना.
Anurag, we can hear you very well.
Yeah. How did your femto go? How did you felt it?
Can you hear us?
Yeah, we can hear you very well.
Okay. So,
Hello, can you hear me?
Yes.
can you hear Dr. Ramamurthy?
Yeah, we can hear Dr. Ramamurthy also. Ramamurthy sir, please continue.
Oh, okay. Okay. Uh, hello, can you hear me?
Yes, sir, we can hear you. Please continue.
Excellent, excellent. I'm just starting off with the phakic IOL, and the other eye of the patient was done just yesterday by Sonu with excellent results. And I'm going to be starting off with first loading of the IOL. Basically, what this HPMC? I'm using HPMC basically to load the cartridge, and I'm going to seat it temporarily. And the lens, because of a polymer material, is dispensed in BSS.
For the benefit of all those present here, you cannot really hold this lens with any instrument. You need to pick it up with the help of this special sponge, which comes with the ICL itself.
Yeah, because these lenses are very thin lenses. The Colomar lenses, something unique from the Star Surgical, proprietary material from Star Surgical. So with a special sponge provided by the company, first the cartridge will be filled with the viscoelastic followed by some amount of saline. Now Dr. Ramamurthy is actually placing the lens within the cartridge.
I was using only viscoelastic, and basically, as was being mentioned, I held it up with a sponge and fed into the cartridge. Then I'm going to go in with a front-loading forceps.
So
This
it's
is a special forceps that again comes with the lens.
crocodile forceps, we say, sir.
So it's a crocodile forceps designed specially for the Star ICL.
We draw it all the way to the front.
So as you see that Dr. Ramamurthy has beautifully displayed that you should not
Turn the left hand, because very important. If you turn while pulling with the crocodile forceps, the chances of lens rotation within the eye. So he was very keen to have that his hands are not moving either side, so that lens will not rotate within the eye. So now he had already plugged this special sponge into the injecting system.
I'm just going to be plugging in the lens through the front. And to make the incision, I'm going to be making a 3 millimeter incision.
3.2.
3.2.
After making sure that everything has gone well with the loading, we go ahead and start the patient's eye. As you can see over here, I usually use a digital overlay, but in this case we are having a marker over here. It's at 180 degrees. So that's where we are going to basically, can I have the side port? As you can see here, I have not dilated the pupil. Can I have a Johnson's baby?
So what is the reason for not dilating the pupil preoperatively?
I like the pupil to be, the lens to be covered. As we all experience in cataract surgery, once in a while we have had a lens touch. And if that happens in a pediatric, in a ICL case, obviously that would be a disaster.
Right.
I like not to dilate the pupil, have the lens, and have a better process. For example, here itself I'm placing a little stress, and if there is a sudden ingress of the side port needle, then maybe there is always a risk of touching the lens. So that is something I want to completely avoid. That's the reason that I do not dilate these pupils. And because these patients are young and they are highly myopic, the propensity for these people to dilate with intracameral xylocaine and adrenaline mix like phenocaine, what we have now, is extremely high. So, and as you can see here, basically the side port incisions are made at 0 and 90 degrees, 90 and 270 rather.
19.
Sorry, I find this a little, I'm forced to use a little more. I'm just making the eyeball a little firm with saline. Side port. These are 1 millimeter side ports, and usually, main incisions. And even now I'm not using the phenocaine, I like to complete all the incisions. And this is a 3 millimeter incision.
So making a uniplanar or a biplanar incision, sir?
Uniplanar. Uniplanar. And almost a rectangular. I mean, it's about 2 millimeters into the cornea. Now is the time I use phenocaine. जरा सा जलन होगा भाई, 1 minute बस. Because of the difference in pH, there's always a little tingling sensation that the patient feels. This phenocaine. Sometimes you see a dramatic dilatation, but this will happen. And now I'm going to be injecting Helon. That's again something different. I find that as you'll see, there is hardly any need to. And now we have the dilatation that we want. It's a cohesive viscoelastic I've injected.
So it is classically said that you should use a HPMC when you insert a ICL.
Yeah.
So you are using Helon.
Helon. Because, that was okay when we didn't have that classical, I'll just complete. Can I have this spatula? But you'll find that the evacuation of this is quite complete at the end of the surgery. Spatula, lens positioning spatula. So I'm just going to see the recap. I'll come to your question, Dr. Mann.
Yeah.
And as you can see, it should be the left leading haptic which has the hole. So very gently.
Very smooth insertion, sir.
Thank you.
And one point I would like to highlight in this, as Ramamurthy sir has done it, always inject the ICL into the AC. Never try to go that the leading haptic should go behind the iris. Always pack it with your lens manipulator, like he is doing.
As you can see here, this is the right leading edge, goes behind. Then this is the left leading edge, that's going behind.
Again, one point to be noticed, how beautifully he has catch hold of the foot plate and just nudging it behind the iris. Beautiful, sir.
Even the pupil is not that much dilated, but the manipulation is so smooth by Dr. Ramamurthy.
You can see the third one has gone, this is the fourth one. And I'm going to be, usually with the digital overlay things are much more clearer, but I hope you can see the marking on the cornea, the 0, 180 degrees.
We can see very well, sir.
I am orienting it with that.
So
as you can see, I did not dilate the pupil, I have not just used cohesive viscoelastic. And what I'm going to do now is to just hydrate the incision, saline. And as you'll see now, just by hydration, the entire viscoelastic will flow out as a bolus. Once the flow of the viscoelastic stops, that means that all the viscoelastic has come out. I do not even introduce the irrigation aspiration cannula into the anterior chamber.
So what about the What about the viscoelastic underneath the ICL?
That also comes out. It's that's the advantage of Elon.
Yeah, but in your case, there is not even a bit of helon was behind the lens, so you could able to with a saline only, like a bolus, it has come out. Excellent surgery, sir. You could able to demonstrate such a wonderful ICL surgery.
So there's hardly anything that went inside the eye, and it has been well documented the incidence of PC touch or cataract occurring during the surgery with phakic intraocular lenses is essentially during the period of evacuation of the viscoelastic. Now that was not necessary at all, and you can see the lens is well seated, on track. It's a toric lens. Can I have Vigomox, Moxiflox? The surgery is done actually.
Excellent.
Sir, I just saw that you aligned the marking before removing the helon.
Yeah.
So don't you feel that the lens position might change after once we remove the helon?
I'm making sure that it is still in position.
Okay.
I'm making sure. You are quite right. Sometimes, I mean, there's a little bit of manipulation that is needed. But very often that's quite unnecessary. And because it's a cohesive viscoelastic, you find that the lens also remains quite stable.
It's an excellent surgery demonstration.
Fantastic.
Floxing that's been injected.
Dr. Ramamurthy, I have a question for you.
Yeah.
So this lens was oriented horizontally. So had the orientation been vertical, would you change your the size of the ICL?
No, see, the ICL is never oriented vertically. It might be oriented at an angle. Could be at 10 degrees, 12 degrees, 15 degrees. Because, you know, we are basically sizing the lenses by the horizontal white to white.
Right.
So obviously you do not want it to be oriented in the vertical direction. So this becomes even more relevant because sometimes when we have just about 0.5, 0.75 diopters of with the rule astigmatism, as it happens in these younger patients, I don't go for a toric ICL, just go make a superior 3 millimeter incision, which takes care of about 0.5 millimeter diopter of astigmatism. Even though I inject it in the vertical direction, I rotate the lens and orient it in the horizontal because it's a horizontal white to white which is giving you the sizing of the lens.
Sir, Dr. Kudlu here, sir. Can you hear me?
Would you like to place this ICL in the vertical meridian?
Maybe you are talking about where there is tendency for the lens to rotate.
Yeah.
So you feel that the horizontal white to vertical white to white might be a little larger, so you position it that direction. That might be possible in a case of a non-toric ICL, but obviously in a toric ICL it's not possible. And at least in my case, I mean 80% of my cases are toric because you know you do want to deal with even small amounts of astigmatism unless it's a with the rule astigmatism of very small degree. So the point I want to make is, you know, it's almost 20 years since this ICL came into the market and 2 million lenses have been implanted. I myself have been using it for almost 19 years. And now with these EVO lenses, EVO plus lenses of larger optics, which range from almost from 5.2 to 6.1, I think, we are able to deal with a wide range of refractive error, including astigmatism. And the tendency for us to, in spite of all the excellent laser vision correction modalities that's available to us now, SMILE, femtocontura, PRK, etc., whenever there is a beyond -7 or 8, I tend to go towards the phakic intraocular lens. And the fact is, you know, even though immediately you might get excellent results, the tendency with LVC is, especially in high grades of refractive error, for it to regress a little bit. Over time, I've seen it over the years. But in this case, because what the patient gets on the first post-operative is what the patient stays with till he reaches a presbyopic age group, the precision and accuracy is much better. And I find these small modifications of not dilating the pupil, using a cohesive viscoelastic, at least in my hands, seem to have worked quite well.
Ram, what has been your experience with IPCL and IPCL torics?
Very good. Actually, you know, our approach to ICL and IPCL is something like our approach to the multinational phaco intraocular lenses and the Indian intraocular lenses. As you know, the Indian industries have also made rapid strides and they're coming up with good quality products. So we do offer both the choices to the patient. Obviously, the IPCL at a much lesser price. So for those patients for whom the price point is major constraint, then they go for IPCL or a toric IPCL. In our practical usage, it's almost 50%.
Ramurthy sir, I would just like you to run through the loading process of the ICL because it's so radically different from the other phakic IOLs that are available. So for the interest of the audience, because I think ICL receives somewhat of a reluctance from the patient side because it's expensive. It receives somewhat of a reluctance from the surgeon side because the loading is a little tricky. So how to use the crocodile forceps exactly, and what sort of mixture of BSS and HPMC you should be using, and the way it should be the cartridge which should be pulled rather than the IOL. So those things I would just like you to highlight again, because you did it in a jiffy, so some points might have been missed by the audience. So just
yeah, I think it's a very relevant point because what was being said is that if you get the loading right with an phakic into ICL, 50% of the surgery is done. Today, of course, it has become so commonplace. Actually, in my place, it's almost 3-4 years since I loaded an ICL. Basically, have to come there.
No, the important part for us to appreciate that Eye Foundation and Ram does a lot of ICLs, and he says that IPCLs are good. They have everything. I mean, they have what is that? Smile, and all the eximers. But still, I think Ram does. He said 50% of his cases are ICLs or IPCLs, and as surgeons, single practices, LASIK may be beyond ER access. So it's a very good take home that you can all practice this simple surgery for your patients.
I think Anurag was asking something about loading of these lenses. Am I audible?
Yes,
audible. Okay. I think, as I was trying, very valid points, Devashish, and I don't know whether you remember, the first life surgery in ICL I did was in Disha. That was almost 17, 18 years back. At that time, it was a sort of something that was just coming into the market. Of course, now it has been adopted widely. And as far as the loading itself is concerned, basically it comes with a cartridge. And you have to, I use only HPMC, though some people recommend using a combination of HPMC and the saline. And because at that point of time, you do not want to use cohesive viscoelastic, because pulling the lens forward as well as the injection of the lens sometimes becomes a little bit of a problem in that situation. And having filled up the cartridge with the HPMC, I basically, because it's a hydrophilic polymer material, it comes with a BSS. Earlier it used to be saline, nowadays it's in BSS. So as I showed, I just take it out from the bottle and then place it on one side of the cartridge and then adjust it in such a way that both the haptics, it is basically a plate haptic lens, and the front right haptic and the following haptic, that is the trailing haptic, the left haptic, has a small hole in it, and those are the marks you essentially look for. Place it in the right way, gently push it under the two flanges of the cartridge. Then you use the front-loading forceps and hold the tip. And basically, you are supposed to withdraw the cartridge and not pull with the front-loading forceps or the crocodile forceps. That way, you bring it to the tip of the cartridge. Then subsequently, you place it in the cartridge. And basically, you do this first so that you're sure that the lens is ready for injection before making the incisions on the patient's eye. And so that, if you have any problem with the lens, then you do not proceed with the surgery.
Sir, Dr. Kudlu here. See, in case of if you see if the vault is high vault, do you really, in case of a non-toric ICL, do you rotate within a week or just you wait for a time?
No, frankly, I have not done a single rotation for a high vault at all.
Yeah.
No, basically, it is said that 250 to 500 microns or 750 microns is ideal, but there have been cases of just 100 micron vault as well as 1000 micron vault, which we have followed up for a period of 3 to 4 years or even longer without anything happening. So as far as the anterior capsule is pristine, as far as the angles are not zipping up, the intraocular pressure is well under control, the angles are open, then you can just follow up these cases. Of course, if the angle is becoming extremely shallow, if you find that there is a tendency for, there's too much of pigment dispersal in the angles, then you might have to exchange the lens for a smaller lens. But I personally have not rotate the lens purely for this reason.
Sir, and the last question for you. Actually, you are talking about some of the Indian make lenses. Just want to tell you, I got a large experience with the acryl phakic lenses of around 700 lenses. The results are very, very good, and none of my patients really had any cataract development or glaucoma. Just I wanted to share my experience.
Yeah, I quite agree with you.
We are ready with Dr. Nura's
I'm actually using both the acryl as well as IPCL, and of course ICL being the primary go-to lens, which is the front runner.
Okay, Gaurav, you can.
Hello.
Thank you.
Can you hear me, Dr. Kudlu?
Yeah, we can hear you, Gaurav bhai. Please continue.
Okay, so we're all set, and my patient has been waiting anxiously for you guys.
I'm okay.
And we did a femto for her. If you saw that, I don't know whether I was audible during the femto, but we are all set.
You are audible during your femto also. Only we are not. Whatever we spoke, you could not able to hear.
But now we are all set, and I'm making. See, I've done a small LRI here to neutralize at about 0.75 of astigmatism, and also it's a single LRI. So the Catalyst now has an amazing software for doing LRIs for small astigmatism, and can correct. But that's my second preferred technique. So we are all set. I'm using. I'm going to make 22 gauge side ports. So this is one side port, and you can see that this is one. And I'll be making a second one. So these are calibrated side ports that I make with these money knives, which are my favorite knives. And these are set to my instruments. So all my instruments are also calibrated to 22 gauge. And for the side port, so there's no leakage of fluids. And Dr. Rohit Prakash is there. He'll be able to, give you more information about why I make calibrated side ports, because the chamber stability becomes much better. And now I'm going to inject some lignocaine here to tighten the eye, and patient will feel a little bit of pressure. But main port. So now I'm making a 2.2 incision. And this is also a very sharp money knife. You can see that. That's why I don't like to use the femto to make my incisions anymore. These incisions are so amazing. Disco.
So you're sitting temporarily, Gaurav?
No, I'm sitting at 12 o'clock here. Because,
and making a supratemporal.
Yeah, so this is a little bit of a supratemporal incision, and it's at about 160.
So Gaurav, you worked with both the machines, the one from Alcon and the one from Catalyst.
Yes, I use both, one in one OT and one in the other one. And I love both of them because both of them work extremely well, and they both have excellent chamber stability. So
but one thing is that the Lensex machine is can make incisions far better than Catalyst machine.
But frankly, I've used both. I've used Lensex for about 3 years, and then I've been using Catalyst for about 5-6 years now. And I would say that, for those who are comfortable with one or the other, it's just a matter of how you get used to it. So
no, I have not seen people using Catalyst making incisions. But I have not done a case on Alcon without incisions. I mean, almost always you are able to make the incisions.
Even with Catalyst, you can make them always. It's just a waste of time. And as you saw, the incisions are so beautiful. Why should I waste that extra 1 minute, trying to open those incisions and making the incisions? That's the only reason. And I think that finally, actually, there's no superiority of the femto incisions.
No. I wouldn't agree with you, Gaurav, on that. Because I feel the femto incisions, and if you do on IOCT, you would see that wound side DMDs are far less with those ones, the subtle ones which you miss out otherwise, are far less with the femto wounds.
Yeah, Amrita, I can't agree more with you.
So that's something which I'll test out now, since we do have
you have both, so yeah, I mean, you are the best to test that out.
So that was a fluid wave. I've managed to rotate the nucleus. And we are all set now. I'm using a high flow sleeve with the 2.2 incision. So that allows me to operate with a bottle height of just about 40. And I do even my hard cataracts on the Signature Pro with 40 centimeters bottle height. And my tip is exposed a little too much. So I'm going to expose it a little less.
So there goes. So is it centered for you?
Yes.
It is. Cornea? Okay. So since it's a young patient, she's just about 50 years old. So I doubt we are going to have much of showing you the separation, but I will try to see if I can just separate the incisions without using any phaco parts. So I'm not using any phaco part, I'm only using vacuum and opening up the incisions. I can actually do that with many of my cataracts which are pre-chopped by the femtosecond laser. So you can see here that I'm only inducing vacuum. And yes, it's a very soft cataract, so it's like nothing that much I'm showing you actually. But actually these are the patients which are more challenging than the ones which are medium hard, which I feel are the easiest to actually operate, because it's the soft cataracts and the very hard cataracts which actually have these issues. So here goes.
In fact, pre-chops in these cases would help a lot more, because you don't cheese wire because it's already
Exactly.
split.
So, it makes a difference even in the soft, and I like it because see, you can have them separated out very easily, and you're not left with a sculpted pole which you have to later flip. So the cracks are nice and good over there, and separation is fairly easy. Only thing is that it should not be so soft that you can't get a hold onto it. So there I've managed to separate the last one, and there I've aspirated it. So we have not used any phaco parts so far because it's a soft cataract. And yes, in many cases with the femtosecond, you can actually get away with almost zero phaco parts. So quadrant removal. Yeah. Cornea, please. I hope the microscope illumination is enough for you to see over there.
Yeah, very clear, Gaurav bhai. Just please continue.
Thank you. So I think getting the quadrants out, and then we will be, the Catalyst, the Signature Pro has excellent chamber stability even with very low bottle heights, and we are able to do a good job with that. And I'll be today using a preloaded Vivinex lens, and today we had long session on the new lens which they are going to launch from Hoya, which is a trifocal amazing lens which is coming up very soon to everybody, and it seems to be very promising in the new design. It's called Geometrix, and Vivinex Geometrix is the name of the lens. So today I'll be using a monofocal Vivinex lens which has frosted haptics and excellent chamber stability, and it's become one of my favorite lenses because of two reasons: the quality of the lens and also of the injector system. So the material is glistening free and has amazing capabilities of remaining inert. It's one of the best hydrophobic lenses that I use today. And that's because of which it comes in the toric platform also now, and the toric has become available in the multi-cert as well. So the good thing is that the frosted haptics, they make sure that your lens stability, the rotational stability of these lenses is excellent. And with the new injector system, it's become like probably one of the best lenses to use in the toric platform with preloaded and with the multi-cert system. And I do a hydro implantation, so I prefer the preloaded system, which is the multi-cert, because you can use it like a shooter. Now these are 22 gauge polished, customized cannulas that I use, and these are basically going to ensure a non-leaky wound. I don't have any aqueous leaks from the incision, so my chamber remains very stable. Can you wet the cornea, please? So I prefer bimanual, and we always have this debate about whether coaxial is better or bimanual, but for me, right from the time I started doing phaco somewhere in the late 90s, I have been using bimanual, and at that time they never even used to make bimanuals. I used to improvise and make my own, bimanuals from subtenons cannula and cortex extractors and all that. But now we have excellent bimanuals, and these are high flow bimanuals which are customized for me by Epsilon. I have no financial interest, and they make it specially for me where both the handpieces are polished, are sandblasted, very fine sandblasting,
because this helps me in doing very good polishing with the hydro polishing that I like to do. I don't know whether I'll get a chance to show you that, but if you'll just watch now, rather than go and try to look at this, I'm going to just set up a fluid wave, and this will cause a hydro dissection of the cortex which is stuck to the PC over there. So I'm just running fluid and keeping the vacuum on, and this is causing good, cleavage of all the cortex which is stuck to the PC over there, and also to the equatorial bag. So I'm not doing anything with my aspiration port, but only with my infusion port. So I've loosened up everything, and now it'll all come out in a jiffy. I just hope I don't catch the PC. I don't want the PC to come out.
Gaurav,
Yes.
talking about the bimanual with the coaxial, my take-home message is I think whoever the surgeon is comfortable with whatever the technique. Lot of senior surgeons still use a Simco also for their
I completely agree, and it's fine. Whatever you are comfortable with is good.
It's perfectly, So whatever you are comfortable with.
Whatever you are comfortable, I think they can still stick on to the. Their
Whatever
technique.
is predictable in your hands is right.
Yeah.
It's not going to affect the outcome of the surgery.
Yeah.
So whatever you are comfortable.
But the fantastic polishing, Gaurav bhai, you
So I've
have
just
done
finished
everything.
that, and now I'm going to
to
inject the
finish.
lens. Thank you so much, Dr. Kudlu.
Gaurav, is your cornea going a bit steamy?
Yeah, the cornea is a little hazy because, it's been, a patient was actually lying for a good 15-20 minutes with the eye, with the speculum. So,
Yeah, so now if you insert a viscoelastic or something, it will come back to its normal.
Yeah. So one thing is that, Gaurav sir, I would like to add that if you just infuse the fluid from the main port, that gives an excellent polishing. All these sticky material
I agree.
onto the posterior capsule get flushed away.
Yes, absolutely.
You don't have to polish it with a vacuum. You
Right.
just flush it with the
I completely agree.
You have to insert it from the main port.
You're right. So that sets up a high flow system because if you put it from the main port, it does not. And so we are using this preloaded lens, and in fact, I'll be showing you the injector system. We've, injected, sister has already loaded it for me. It's a beautiful injector system. And this is the Vivinex lens which we are going to use here. And I'll just zoom out a little bit, and you can see that the lens ports, it is almost like 100% sure shot way of folding. It never goes wrong, and I always find that, you can just close your eyes and push the plunger and it will just fold up on its own. It's unlike many of the other preloaded systems where you'll have surprises with the haptic opening one way or the other. So let's get ready with it, please.
And the tip size, I think it is compatible
It's
with 1.8.
1.8, yes, you're
Yeah.
absolutely right. So in fact, people who use an earthly machine which has a 1.8 incision, they can also use it well. And with a 2.2 which I use, I can get a very easy injection, and especially it's very useful because if you have a PC disruption or something, and you don't want to do a wound assisted injection, you can deliver the lens straight into the bag without enlarging your incision. So I find the injection of this lens very, very predictable.
So what instrument are you using from the side port, Gaurav?
That's my infusion. That's my infusion. I'm
Bimanual.
doing
Is it any special kind of infusion?
Yeah, it's a infusion is my bimanual, which is 22 gauge with sandblasted tip, which I was using for my previous situation also. And my infusion is on.
So this injector system has both things. It can shoot as well as there is a rotator which advances the IR.
Yes, so it's a very predictable injection.
Yeah.
As you can see, it is going nicely and smoothly straight into the bag. Patient is exerting a lot, so
how beautifully everybody can appreciate that the infusion cannula has been put almost halfway over to the lens so that it doesn't tumbles. And the
Yeah, it helps
fluid
in,
is obstructing the lens to come up. It will stay down into the posterior chamber only.
And as Dr. Haripriya was showing, I also like to position my lens horizontally or a little bit in the supranasal infratemporal position where the negative dysphotopsia is the least. But frankly, with this lens, I have not really had patients complaining of negative dysphotopsia much. And now, yes. So now with the infusion on, especially if I'm doing toric, see my lens is well in place, my wounds are all sealed, my infusion is on, it's stabilizing the globe. And I'm now going to seal my side ports first. I'm using this cannula which helps me in sealing the side ports there. And then I will seal the main ports.
So which cannula is this, sir?
This is Herschel's cannula, I think.
This is, I think, Herschel's top
Yes.
cannula. Yeah. Made in Jaipur. Made in Jaipur.
So my main port is now sealed. And now I might seal the side port And there is no viscoelastic to remove, frankly. So the good thing is that I don't have to go behind the lens and all over the place trying to wash the viscoelastic, because I don't use viscoelastic at all. And I can just close my incisions and...
What about intracameral moxiflox? Do you use, Gaurav?
Last 5-6 years I used intracameral moxie in every patient. I learned it from Dr. Haripriya, and their study was the one which, made me decide to go in, and there's been no looking back. We are very happy to use it in all our patients. And so I'll just close the wound and I'll be showing you my way of confirming that all my incisions are well sealed. So we are almost done. The cornea has become a little hazy because of the time that it was left open, and we are sorry about that because your visibility may not be great. So my incisions are mostly sealed. I'll be putting a drop of trypan blue to check. So one drop here, and that shows that it is sealed over here. So you would see some aqueous escaping, and especially in pediatric cataracts, I use this a lot because it helps you in ensuring the integrity of the wound, and you can quickly see any aqueous. So you can see a small, small thing over here that the aqueous is escaping, but this is a micro leak which will settle down once the pressure neutralizes. So this one does not require me to do anything. We'll just wash the... do you have intracameral moxie? Okay, so we are all set, and wash off the extra dye, and any questions, I'll be LRI open karna hai. You have something to open the LRI?
So excellent surgery, Gaurav sir.
Thank
now
you.
We will be shifting to the next patient. Dr. Anurag Mishra will be operating. Sunaya?
Hello?
Yes,
hello.
You can start.
Yeah, thank you. Yeah, we are starting with the next case, Dr. Anurag Mishra. This is a patient, a 68-year-old male for left eye cataract surgery, grade 2 to 3 nucleus sclerosis, with mild fovea thinning in the left eye, with a CFT of 115 and with a good speculum count. And with a toric, can we have the toric sheet, please? Next slide. So you can see this is the toric sheet. The cylindrical power in the eye plane is 1.5 with a spherical equivalent power plus 24.5. And we move on to Dr. Anurag Mishra to start the surgery, please. Thank you.
Thank you so much for presenting the case summary so beautifully. Am I audible at the venue?
Yeah, audible, Anurag. Please continue.
Thank you so much, sir. Good evening, ladies and gentlemen. Yet another time, greetings and regards from the land of Lord Jagannath. You just heard the profile. The patient is going to receive a 24.5 T3, the corneal toricity staging at somewhere around 1.12. So since this is a left eye, I always approach it from a 20 degrees axis or angle for the primary incision. This is my favorite keratome coming in from the house of Orolab. Both of these, in fact, come from the house of Orolab. This is a straight back cut from the shoulder, as you can see, so it makes the incision very, very squarish in shape indeed. So I prefer not to anchor the conjunctiva at all with anything. I go in with the side port and the incision, primary incision together, and then construct the other side port. So before any solution goes into the all three sections, all three ports have been made. Then I inject a small quantity of preservative-free lignocaine into the eye, so that the patient's comfortable right throughout the procedure. Next, we go in with the HPMC and fill up the eye with the viscoelastic substance so that it creates a space for us for the subsequent maneuvers. And we then proceed towards the capsulorhexis.
Anurag, those are amazing. I know the quality of the plates is amazing. I'm only concerned about your side ports. I'll allow you to complete the rexes, then I'll ask.
No, sir, you can carry on.
Okay. So, when you use these side port blades, you are not sure of what size incisions you are plating. And that leaves a bit of uncertainty about, you may sometimes get very small ones or you may get slightly bigger. And plus the configuration of the wound is such that, it's, different size on the outside and on the inside, right? So I've often used this and found that I was uncomfortable about sometimes the wound would be leaky, sometimes there may be an iris prolapse, small one. So
So I like to know what size side ports I'm making. That's why I use that kind of a plate, which is like a MBR, which is fixed gauge. And here you cannot have a fixed gauge because it's like a 15 degrees, which how much you put in will decide how much size of incision you get. So I'm wondering, is there a special reason that you like this?
The MBRs have never actually caught my attention because they're too large for me. They say that at the shoulder, the widest diameter, it's around 1 millimeter, this height. So that's what's written on the packet. So I do not go till the shoulder, so I fall just short of it. So that makes it approximately 0.9. But you're right. I think we are working on assumptions here. We do not have it gauged or metered. सीधा देखिएगा अंकल लाइट पे सीधा देखिए. Thank you. बहुत अच्छा देखा हैं. But I think I agree with you. It should be gauged, it should be metered. If we are measuring everything else in ophthalmology, there's no reason why we should not be measuring the side put as well. Somehow the MVR's angulation, I have not been इसको नहीं चाहिए. सीधा चौपर दीजिए और एक ऊपर दीजिए.
Actually, they come in all kinds of angulations now, and in fact, the one that I was using, while I'm sure many others are making it too, it's not very long, so the bent part is very small. So even if you go in, it won't go beyond like about 3 or 4 mm. So you are not likely to hit the capsular bag also, so you're not likely to damage your rexus. It can't go in beyond like about 3 millimeters. So it'll just make your incision and maybe go about a millimeter or so inside, and then it won't go further.
Yeah, it makes sense actually. I would certainly go back and try that. Order for a few with the different angulations and see whether it works for me. At the outset, when I started using the MBRs for the side port, I was not very happy just because of the fact that they used to be of larger dimension than I actually required for the second instrument to go in. My side ports are usually always on the smaller side because I don't use bimanual IA. They're usually on the smaller side. So but this is a very nice thought, sir. There's no reason why we should not meter them. So I'm using an IOP of 20. If the video camera can just focus on the screen a little bit, I always prefer to keep my fluidics extremely low on the machine. We don't have a video overlay to show that, but if the video camera if somebody can ask the video camera guy to focus on the screen for a bit. So we are through with the primary chop. We have fired one of the heminuclei. We are going into the secondary chop of the other heminucleus. Is it properly centered out there in the screen?
Yes, very much centered.
Is it centered there in the hall?
So the chopping is complete. Now we go to the pod removal. Pod removal mode, the IOP stays at 20. Again, and the flow rate is also very minimal. It stays at 23 to 25. That's the flow rate I normally use because I never need more than that. The vacuum stays at somewhere around 450. I'm not somebody who believes in setting very high vacuum because actually we don't need that. Most of the time, we don't need that. So a vacuum that works with the lower fluidics well and gels well with the lower fluidics is something that works for me very well. So as we speak, we are about to finish off the third pie of one of the heminuclei. What would be the CD? What's the CD up to now? 4.4 is the CDE when we are through with one half of the nucleus. We do tend to keep a check on that nowadays because with the advent of so much of new gen machines, why not try and bring down everything? Why not try and bring down the amount of fluid we use for the procedure? Why not bring down the amount of energy that we use for the procedure? Everything has to be metered. Everything has to be optimal for the outcome to be optimal as well. So there's no reason why we should be bombarding the eye with fluid. There's no reason why we should be jeopardizing the tissue's integrity with so much of energy. If all of that can be managed with mediocre settings in the machine and yet not compromising with the comfort factor that the surgeon has. The highlight of this procedure, again, just like Gaurav sir mentioned a while back, is going to be another preloaded IOL coming in from Hoya Surgical Optics. It is built on the Vivinex platform, and we are so happy to see the torics come in on the Vivinex platform. I think Hoya has done a wonderful job in keeping the surgeon's comfort in topmost priority. The preloaded platform has been spectacular.
The multi-cert has been another addition, icing on the cake. However, the IOL that we will be using today is not on the multi-cert platform. It is going to be on the iCert platform. So that is a screw type injector that we would be using. Cortex, yeah. So it will be a screw type injection. So I would have to take the help of my assistant to screw it in. So this is the cortex mode. I was getting to hear the discussion on bimanual vis-a-vis coaxial, and I always prefer the coaxial over the bimanual. That's my preference. The bimanual IA Kannada is always there on standby. It's even here in my instrument set, but that's not my primary go-to handpiece. I preserve that for specific few cases, like the polars, or if there's an eventuality on the table, I use that. Otherwise, if there's a small bit of subinstitutional cortex at the end of the procedure, I tend to take it out with the bimanual, but usually it is the coaxial that I go to for removing cortex in a routine case. So here the vacuum has actually gone up to 600. If you could just see that, 600 is the vacuum and it is in panel mode, but yet the IOP stays at 22. So I think in the initial part of today's live surgery session, we were discussing BSS Kannada, hydro Kannada, please. So we were discussing about hydro polishing. So we'll just demonstrate that for a bit. You can see a few cortical fibers still adhered to the PC. We will just flush it out with the use of this BSS, and it comes out really nice and easy. No need to polish them with any handpiece, any machine, any vacuum. Just flush out some of the BSS and then सीधा देखिएगा अंकल जी, लाइट पे देखिएगा सीधा, बहुत अच्छा. So this is the IOL that we are going to be implanting today. It is, I think, enough of exhibition of the preparation of this assembly. Beautiful holder that holds it, and there's a nice hole here which receives viscoelastic through, so we'll just push in some amount of viscoelastic. You can see this viscoelastic filling up the cartridge. Then you remove the lock that holds the whole assembly in place. Just remove it. Advance this holder. The arrow mark is given. It clicks, and then you just disassemble the whole assembly. And then you screw it in. Look at the plunger. It's a bi-fit plunger which nicely holds the optic-haptic junction together. And look at the blob of the IOL as it advances. So for injecting the iCert, I would just 2.8 blade hai aapke paas sister. So I would just increase the incision a little bit, which I never do with a multi-cert platform. This iCert platform, I actually find it a little easier if I irrigation can la dijiyega. If I just increase it, am I audible?
Yes, you are very much audible. No, you are audible and we are watching.
Fantastic surgery.
I'm sorry, sir. I thought there was absolute silence from the other side, so I thought I would better check out.
No.
Cannula that goes in, and with the 2.8 millimeter blade, I would just extend it a little bit for easy access of the cartridge inside, and then I would take the assembly from the switch off the irrigation just for a while the yes, now it goes in, and I request my assistant to screw it in. As she does that, look at that, nice and easy. It goes in straight into the bag. One of the striking features of this particular IOL is that you would never find the salami sign. The optic and the haptic are never glued to each other. Dialer dijiyega, sister, Sinsky. They're never glued together. The haptic never glues onto the optic surface. Once that happens, it's actually very annoying because you lose around 30 to 40 seconds for the IOL to completely unfold itself. So you lose time over there, and when you have a reasonably long list in the OT, that becomes very annoying. That's number one. And number two is, then it requires an effort. You have to go in with another instrument, you have to dislodge them from one another, they stay glued. So it's just kind of disturbing to the surgeon as well. So I have never seen that happen with the Vivinex. Uncle, seedha dekhega please, light pe. एकदम सीधा देखिए, इसको थोड़ा आप छोड़िए.
Excellent, Anurag sir. You have exhibited.
So you can see that the IL marks are properly aligned with the axis that we had marked initially, and there's a good coverage of the anterior capsular margin all around the optic. So I mean, that's peace of mind for the surgeon, and we know that this patient is going to do very well in the post-operative period. Just before vacating this chair, I would, if
Thank you, Anurag sir, for exhibiting a very excellent surgery. And now we are switching to the feed of Dr. Anaga Harur. Sunai, can you just report the case?
Thank you so much, Dr. Anurag sir. We are moving on to the next case. Dr. Anaga is the operating surgeon. It is again a Womanic toric.
My duty is if I don't thank the audience for watching. Thank you so much for watching.
Thank you, Anurag. Thank you very much.
So we would like to continue with the last FECO case. So this is a 65-year-old lady with left eye cataract. Right eye is already operated with a grade 2 to 3 nuclear sclerosis with a dense PSC. Normal retina with a good endothelial count. And IOL power is plus 23. Can we have the toric sheet? The next slide, please. So the axis of alignment is 178 degree, and the patient has a cylindrical power in the IOL plane of 3 diopters, and the model is T5 model. So we start with the surgery, ma'am. Over to you.
So, Namrata,
Daddy, upar karo, aunty.
we generally load the lenses with Hilon.
Daddy,
So
upar karo.
what Anurag was saying that
thoda niche
the
karna.
haptics don't
Daddy,
touch
upar
each
like-
other, and that is
Daddy,
avoided,
upar
and
kariye thoda.
it
हाँ,
opens
बस
up
बस
very
बस
gently, and you can
बस
just
बस
wash out
टेबल थोड़ा
the
ऊपर
viscoelastics within
टेबल का फुट स्विच है
without
क्या
having to worry that
मेरे पैर
there's
के नीचे
viscoelastic on the haptic edge or in the bag. And so all in all, and in fact we prepare aliquots. You can load almost 10, 15 of these lenses with Hilon. So it's not costly either. So, and, of course, hydro implantation. We do hydro implantation.
But when you put it in the cartridge, but when you put it, you put viscoelastic into the
Hilon into the cartridge, yes.
यही है ना कम लग रहा है illumination थोड़ा
What we really do is we dilute the HPMC with BSS, and then we use that in the cartridge. So it comes out very easily while just doing a irrigation aspiration.
That's interesting.
Yeah.
26 में लगा के दें माजी लाइट की तरफ देखते
Almost
रहो
flows out with the irrigation.
Yes, my quick question to Madam Anaga.
Yeah, good evening everyone.
Good evening.
बड़ा needle holder है ना Yeah, hello everyone, good evening.
Good evening.
Is Dr. Anaga audible?
Needle holder, बड़ा needle holder.
Anaga, you need to center the eye.
Are we audible in the hall?
Yes, very much audible. Can you hear us, Mank?
Yeah. We can hear you, sir.
Okay, so the eye needs to be centered.
So, Dr. Anaga is operating a cataract which is grade 3, and she will be implanting a VV Next toric IOL at 178 degree, a T5 model. Ma'am, what will be your technique to deal with these kind of cases? You'll do a direct chop or a stop and chop, or?
Usually my go-to technique is stop and chop. One tooth देना. So this is almost grade 2, grade 3 with cortical cataract. Auntie, सामने देखते रहना है. Marking has already been done. You can see the 3 marks that are done here, 0, 1, 88, 90.
Ma'am, can you center it a little
Anaga,
bit?
you need to center the eye.
Yeah,
Please center.
yeah. Is it okay na?
Slightly more away from
Aji,
you.
क्या रखना है?
Yeah.
Is it okay?
Better, but still.
देखते रहना है सामने. Oculine ready रखना. Making 2 side ports. Oculine देना. Putting in a little oculine. थोड़ा visco देना.
वो छोटा कैन्युला का दिया था, yeah. So putting in a little visco. Need to be careful to go inside. Air bubble नहीं चाहिए, ठीक है. Yeah, entry दे देना. Since की है dialer. So actually, I would have preferred a little 20-degree incision. Here the incision is at 180 itself, but it's more convenient to have a 20 or a 30-degree incision. Here it will be a little uncomfortable. So this is a triplanar kind of incision.
So you're making a triplanar incision.
Yeah. This is a 2.8. Okay. Let's see now. So for a better red glow, I'm putting it on the SCI mode. Putting it in a little visco. Yeah. Increasing the magnification now. SCI mode. ये मैंने जो बनाया वो है, मैंने बनाया वो. लाइट की तरफ देखते रहना.
Madam, center a little bit, please.
It's not center.
Little,
Okay?
bus, now it is okay.
Yeah.
It is perfect.
Yeah. थोड़ा सा सलाइन डालना, थोड़ा डालना सलाइन. माझी दो लाइट दिख रहा है, उधर देखते रहना. Don't put too much सलाइन, कूलिंग हो रहा है. देखते रहिए सामने. So doing a capsular axis. Trying to keep the capsulotomy flat.
So everybody can appreciate that Dr. Anuga is very meticulously doing it. The capsular axis, she is holding the capsule from a little away from the cut margin, and that gives her a beautiful and excellent control. And see how a 5 millimeter central axis has been made.
Similar to femtoraxis, eh?
Yeah. I was just asking Anurag also that, do you have a femto? He said yes. मैंने कहा ले क्यों रखा है?
I'm removing the capsulotomy flap so that it doesn't then interfere. Otherwise, sometimes it can just get dislodged. And here what I do is just reduce the pressure of the speculum so as to reduce the pressure on the anterior chamber also. So now illumination appears to be a little low. Illumination full hai? Is it full? Just check. Can you please, I'm trying to do it through the foot switch, it's not happening. Zyada saline mat dalna, so cooling ho raha hai. Yeah. Can somebody,
now it is full.
No, somehow there's a little less, doesn't matter. As long as we can see. So first depress the posterior lip so as to remove a little bit of the visco so that we don't suddenly increase the pressure in the anterior chamber. Just doing a little bit of hydro. It's a little harder nucleus, not a very NS1 or NS2. You can see a little bit of shallowing, tapping in the center. Yeah, visco. दो सेंस के देना. Yeah. Just rotate it to ensure that, yeah, फेक को ready रखना. Yeah, so you can see that it is now easily moving, mobile. So now, sorry? Huh? Yeah, let it be. I know. Huh? What? Right. Correct. Yeah, so I'm just adjusting the sleeve so that it's 90 degrees to the tip. Okay. माझी थोड़ा पानी आएगा, प्रेशर आएगा आंख पे. Do you have a small chopper, please? One of them is the chopper. Just give me the small chopper. Yeah. No, this is the dialer only. We have some.
In the meantime, I would like to take this opportunity to thank all the support staff of Anand Eye Hospital, especially Dr. Rupen Jain, Dr. Sonay Mukherjee, Dr. Gopal Krishnan, Suman,
Chopper and chopper. हाँ ठीक है.
Pooja,
Okay.
and all the support staff
थोड़ा पानी
who
आएगा
has
फिर
beautifully and seamlessly organized this live surgery show here at Anand Eye Hospital. I'd like to thank all of them and all the participating surgeons, Dr. Ramamurthy, Dr. Gaurav Luthra, Dr. Anurag, Dr. Anaga Arur, for showing us beautifully the cataracts.
superficial cortex.
So you're going in
Dr.
for
Anega
stop
will
and
be
chop.
showing us a stop and chop. He's beautifully making a nice central crater.
No, no, 1 minute, the foot switch. Yeah, chop pen.
So as you can appreciate, 2 chops has been done and pie has been separated.
I hope it is focused well there. Try and remove the air bubble so that visibility improves. बड़ा चॉपर है क्या? देखो, little hard. नहीं, ठीक है.
As you can see, the central hard nucleus is still attached, but she has made all these peripheral chops. And once you remove one pie, this will all come out.
किस पे? स्कल्प पे? हाँ? हाँ, एक मिनट.
So Anaga, you've got the hardest cataract in the whole
Yeah.
series today.
So I'll try and
You
solve
asked
the-
for it?
Yeah, yeah. No, no, no. What is it on scalp? I can't hear the auditory feedback. Is it on scalp? Yeah, yeah. So I purposely made it on scalp so that we can scalp the central part a little bit. What is the power kept on? Oh, it should be fine. Okay. Stop है? Yeah. Okay. Okay.
See how beautifully the central core has been separated.
Foot switch is not working on.
So in such cases, this happens at times when you flower petal the peripheral parts, the central hard endonucleus, which is virtually unchoppable or difficult choppable. That's exactly the way to go when you have a hard cataract. And Namrata ma'am, just to add on to what you said moments back, I think just like the wand chooses its wizard, the cataract also chooses its surgeon. So she got the hardest because she is the hardest amongst us, toughest amongst us as the surgeon. So it had to come to her.
Dr. Anurag, you are being very kind with your words. Give me a Sinsky openly now. Yeah. There. Somehow I'm filing the illumination a little low, but ठीक है.
It's 100%.
Yeah, yeah, I know. It's okay. हाँ जी, सामने देखते रहिए. Yeah. Don't put too much saline, no? That's right. थोड़ा saline डालो. हाँ.
So the one thing that I have always appreciated about the Signature Pro's dynamics part is that it allows you to choose different modes, pre-occlusion and post-occlusion. So you can choose the pulse mode if you don't want to waste too much of energy before the occlusion happens, and after the occlusion happens, you can go to the continuous mode or burst mode, whichever is your favorable mode. Not many machines allow that, but the SIG Pro does allow that. And I think we are using a 20 gauge tip here. So the 20 gauge tip is what Anaga is using in this case. They also have the access to a 19 gauge tip, I believe. Yeah. So that's a little wider bore. So for very hard cataracts, that actually comes in very handy because the surface area is more, and you have an increased bore area for the nuclear fragments to go in without clogging it. Nice. So you have the tip. The sleeve size also varies according to the tip, I believe. It's a 2.6 with a 20, with 2.8 with a 19, and a 2.2 with a 21 gauge. All of them being available in curved and straight tip arrangements. And the standard bevel is 30 degrees.
It's a straight tip or it's a Kelman bent tip? It's a straight tip.
Can we go on to the epinucleus mode? Saline on cornea, please. So because it's the last of the fragments, I'm going on to the epinucleus mode.
So just decreasing the parameters for the last piece.
Because I can see there is hardly any cortex,
Hmm.
and we don't want any kind of PC coming into the tip.
The one advantage with this sort of cases is that the epinucleus also is pretty thick. So once you eat away the nucleus, it just tumbles out. It sometimes flips over, and the convex side of the bowel pops up out of the back. So it becomes easier for the needle to negotiate with it and suck it in.
Yeah, so we are done with the phaco part.
So beautifully done. You'll be doing a coaxial or a bimanual one?
No, bimanual.
Yeah, more
I'm a
comfortable.
big fan of bimanual because I think that gives us a very good control and access to all parts of the cortex. So this is the 20 gauge side ports that we have made. Light में देखना है आंटी, माजी light में देखें. So always before putting in the IA, I prefer to put in a little bit of irrigation. See that there are no air bubbles, so that, yeah. Then focus the line product. Can you make it on polish mode, please? Why is the foot switch not changing? Yeah, yeah. Yeah, saline on color. Because it's a very flimsy cortex. Yeah, saline dana. Yeah. Yeah, now make it on, wait. Foot switch से हो नहीं रहा है. 1 minute, huh? No. Yeah. Saline डाला. Polish. Yeah. Change. Right side में ही रखा है ना? Change in the. Yeah, yeah. Done. Take the lens, no? Yeah. Cortex पे रखो. Yeah. Saline दो. Yeah. Polish पे रखो. Yeah. Keep the lens ready so that you can, yeah. So this is the last of the IA part. Give me some whisper.
So once again, just like the previous surgery, the highlighting feature of this procedure is also going to be a Vivinex toric, but this time it will be on a multi-cert platform.
Cert platform.
Yeah.
So just show you the lens. This is the lens. You put in some visco first. You put in already? Okay. Everything is done. Okay.
So something they've done for you, Anaga, you don't have to do everything.
Yeah, fine. I was about to show that. Okay. Give. Give. Sinski, dialer.
So the internal design of this cartridge is also very interesting to study at. You would never find the advancing haptic unfolding in the...
So it has that advancer plunger also. You can adjust the amount of tip that enters the anterior chamber. Until light mein dekhiye, it goes in very easily.
So beautiful. And the
Extremely
biped plunger.
Smooth, extremely smooth. Dusra sense ke na? Yeah. So this is a toric lens and it is at 0-180 only. So I'll have to just rotate it so that it comes to the 0-180. I'm rotating it just 20 degrees short of it. And then we'll remove the viscoelastic from underneath the lens and then align it perfectly at 0-180. So give me the eye please. So the lens is well centered in the capsular bag. So it's not just the injector system, but it's also the optical clarity of the lens. It's 0-180 only, so don't need to. Visco kariye? Yeah. So you can see that the lens is perfectly centered. All we need to do, and it has a very good tackiness. Because of the modification of the surface, it adheres well to the posterior capsule, the lens. So the chances of rotation post-op is very less. Salinum.
And the textured haptics
And
also play.
They have some coating on the posterior surface of the IOL as well, which releases some nascent oxygen. They say that way.
Yeah.
It's not a coating actually, they treat it with active oxygen.
So it's the ozone and the UV treatment, which makes it adhere well, and that is why there is hardly any post-op rotation.
One of the other less talked about aspects is the fact that the toric IOL in this platform has got the asphericity on the anterior surface and the toricity in the posterior surface. So the posterior surface is not flat. It maintains its convexity to fit into the curvature of the posterior capsule. The contact of the posterior capsule with the optic is also maximal. That also enhances the fibronectin binding and the tackiness of the material. So that also contributes towards the materials or the IOL stability post-operative.
You can see here now
And
that
it has a frosted haptics as well. So the rotation is minimal.
Yeah, so that's what we were discussing, the textured haptic. Beautifully centered, wonderful surgery, Anaga. I think we should all clap for him for finishing off so beautifully.
Yeah, fantastic surgery, Anaga.
Yeah, now we will be shifting to the refractive surgeries. Dr. Sonu is there ready. So I would like the feet to be changed to the lacy coating now. Can we have the feet from the lacy coating now?
Ready?
Hi, Mayank.
Yes, we can hear you.
Hello.
We can hear you.
Hello.
Sonu?
But we can't see you.
Can't see you, Sonu. Will you shift it to Visumax 800?
Am I visible now?
No, you're not.
Yes,
now.
now.
Visible.
Okay. So I think welcome Dr. Namrata Sharma, Dr. Devashish Bhattacharya, Dr. Arun and KP Kudlu is here. So I think all great refractive surgeons on the platform. So welcome to the world of Visumax 800. And this is what Zeiss boasts of their new femtosecond platform. And they claim it as one of the fastest femtosecond laser in the world. And this is basically a 2 kilohertz or 2000 megahertz machine. And the total treatment time taken for creating a lenticule is maybe 8 to 9 seconds. And it creates flap within maybe 5 to 6 seconds. So this is the two arms, and a brief description that I'm trying to show you is the screen here. So these are the two camera systems here, and these are the sensors here, which basically prevent these arms to prevent hitting onto the face of the patient here. So these are the sensors built in. This is the joystick control of the bed here. And then you have, I'll show you the wonderful microscope, a lot of features that the Zeiss has put in. And this is basically the laser system here. And this is the cone system which comes down and where you attach the cone, the suction cone here. So this 22-year-old girl has a refractive error of 4.5 with half a cylinder at 180. Her Paki is 530 microns. And what we are trying to do is we are trying to create a cap of 120 microns, leaving a minimal thickness of 30 microns. And can you just get it close here? So this is on the fly that the screen, both the eyes can work together, the left and the right. You get a good pictorial diagram here, and the residual thickness in the right eye is 302, and with the other eye, it's close to 305 here, 309 here. So the incisions that we are aiming is at 100 degree with an angle of 38, and the width that I'm taking is 2.5. So gradually I'm drifting to minimal size, and minimum you can take it here is 2. So presently I'm using 2.5 here.
So no, 2.5 is also lesser incision. This is ultimate. I think you can shift to 1 mm also soon.
So yes, I think with the experience and whatever the safety protocols is, slippers, Gaurav slippers.
Definitely, it's a revolutionary machine, Sonu. Probably you are the early adapter of in the world market.
So I have with me two doyens of ophthalmology here, refractive surgery, Dr. Gaurav Luthra and Dr. Ramamurthy. I think they're trying to give me goosebumps here. So, so as we start here, so the treatment that we have planned is saved. So this is a switch here which says the operating microscope, and this swirls down, and so this is how the patient is in.
So as opposed to the previous machine which had the whole system coming onto the patient's eye, this has only a single arm which comes, and
so
the
this
machine
arm
is located on the side now, I think.
Chin up.
It's a fantastic machine, madam. The results are so good, except for only one thing. Price. Other than that, everything is better.
So, usual tendency is put 2 drops of paracaine, don't let the cornea dry, chin up, wash the conjunctival flora, and can we have the microscope feed here? Chin up, chin up, chin up, chin up. I think microscope feed abhi nahi chalu hua, is it?
Yes, we can't see the microscope.
Now we
we can see now.
Yeah. You rotate, sahi hai? Okay. Chin up. Select.
This machine is the iris tracker, no, Sonu bhai?
So actually they have to link this machine with a software called Forum that we, will link this to ILMaster 700, and then the two machines start talking in. So as of now, the software still is yet to be given, and they'll have a workstation, which will be the refractive planning station. So very shortly, to all the 3-4 establishments that have been done worldwide in India, they'll be giving, that is what Zeiss has promised us.
Which is connected to ILMaster 700.
Yeah, ILMaster 700. Like, like mahina nahi hai. So the most important thing in smile surgery, when I shifted from 500 to 800, was that those 28 seconds were the most adrenaline pouring moments for us. And actually, the surgery wasn't, so much taxing as the 28 seconds of the laser treatment was. So I think the studies also show that the maximum vacuum loss would usually occur within the last 15 seconds of the surgery. Syringe, fast. Cornea dry ho raha hai, chin up. Are you okay, Hiral? So this beautiful girl wants to be a star. She wants to do films. You want to model? So you're getting the best of the stuff here. Yeah. So now we have clicked in the laser microscope. So this goes up, and this is the laser system which scrolls down. And if you see here, this is the OS and the OD treatment planning system here. So we press the left eye here, And so the parameters that you see have to be, is it visible?
Yeah, visible. Visible.
Parameters, we can't read them, but the screen is very much.
Screen is visible. Myopic astigmatism.
I think now it should be.
Hiral Porwal.
So it is 4.5 with 0.25 cylinder, 180 intended refraction remains the same. So I have not done any corrections. The cap data is 7.5, lenticule is 6.6 here. The thickness that we are aiming is 120 for the cap. The transition zone is 0.1 and the thickness minimum is 30 at the edge.
What is the lenticle thickness, Sonu?
109. 109 is the lenticle thickness.
Yeah.
And the incision is at 100 degree and I'm aiming at an angle of 38 with 2.5. So the residual is 309 here. Confirm. So now with the software 1.2, see actually if you see here, the spot distance has gone to 3 for the cap and 1.5 for the side cuts. So I think this makes the separation very, very smooth. Chin up करेंगे. Very good. So now you confirm here, and so you see the joystick here.
Yeah.
So this is the joystick. And you see on the side mirror, the side screen, and this is how the joystick, just watch carefully here. So this is the laser component which comes down. Show here. इधर. अब उधर से साइड से दिखाओ आप कहाँ मैं ये अटैच कर रहा हूँ. Just go to that side. So this is the place where the suction cone is connected here, and then.
So no, same cone what we use for Visumax 500?
Yeah. This is the same. And just see the magnetic click with which this gets illuminated, right? Can you see this?
Yeah.
So can you exchange the feed? Can you shift the feed now? Picture in picture to change. Yes, correct.
Yes, we can see that.
Yeah. So the two important features which I want to highlight with this Visumax is the centration and the cyclotorsion alignment. So three things: the speed. बेटा chin up करोगे? Chin up करोगे. Very good. अब आपको green light दिखेगा. Now. So can you see the green blinking light?
Yeah, could you able to see
and
very
we have
well.
been talking of angle alpha here. So the visual axis, and with the on the topographer, you can have the XY planning and which can be fed here. So any kind of deviation from the center can be fed in here, and you can actually take care of angle kappa here. So just watch carefully. Even in fully dilated pupils, I can take care. So this is the joystick which I am moving. I am trying, beta green light dekhna. I am trying to center. Beta green light, green dekhna hai. Hilla nahi hai, green light dekhna hai. So this is the green beta, green light, hilla nahi beta. So you can have your watches for the countdown. Beta hilla nahi. नहीं आप हिल रहे हो लाइट में ग्रीन देखो हिरल ये तो सीधे ग्रीन लाइट बता या वंडरफुल हिरल हिलना नहीं है हिलना नहीं हिरल आप हिल रहे हो बेटा मेरोसिल देना बेटा हिरल आर यू ओके सो डोंट मूव बेटा चिन अप करोगे जस्ट रिलैक्स सलाइन देंगे कैन आई हैव अ ड्राई मेरोसिल
Sono,
yeah.
I think we have to, this was the question I wanted to ask. I think I've been training a lot of people for Visumax for last 10 years for Zeiss.
Yes.
But you, normally at the Visumax 500, I used to keep the cornea semi-moist. But you left a lot of fluid over this. Probably she's a contact lens user. You wanted to make it more towards the moisture side, no?
Yeah, so actually the drift of the AC is what is causing the cornea to dry. So I don't want those spots here.
Yeah.
Chin up करेगा बेटा बस हिलना नहीं बेटा हिलना नहीं या रिलैक्स चिन अप करेंगे वंडरफुल बेटा हिलना नहीं आपको हिलना नहीं हिरल बहुत अच्छा देख रहे हैं. Just don't move, हिरल. Very nice. Very nice, बेटा. Very nice, हिरल. हिरल हिलना नहीं, हिलना नहीं. हिरल हिलना नहीं, बेटा. So just watch the time, बेटा बिल्कुल नहीं हिलना है. You are blocked now. And that's it.
Yeah, fantastic, Sonu. What you wanted to demonstrate in this case, you demonstrated. In spite of
actually,
having,
what is being taken care is the centration, right?
yeah, and even fluid is there surrounding. There is no chance of suction loss at all in this particular machine. That's what you wanted to show. Because Visumax 500, as you said, that 28 seconds, our heart is also beating. This much of fluid, chances of, I think, suction loss is quite high. But here, your fluid is there around, no chance of suction
KP,
loss.
just watch this. This is a screen here. You press the detach, and that is when the cone gets detached, and you can just throw it off. So actually, you need a trained assistant, a good doctor here on by your sides who can, help him all these procedures. So now, again, this system goes off, and the operating microscope moves down. If you see, watch. Can we have the microscope feed down? Chin up, better chin up karenge, chin up karenge. Yeah. So I think the rest of the surgery is what everybody of us has been doing saline.
You mark the cornea, Sonu.
So actually, I just wanted to show the marking, but actually what is important is the markings have to be little inside the limbus. Beta light में देखना है. केवल chin up करेंगे. बेटा आप थोड़ा सा को move कर रहे हो ना. Move करने से पता है क्या होगा? नुकसान हो जाएगा. Light में देखना बेटा. I'll show you a light in the center. Just wait. Hiral, wait, beta. Can you see the light now? Can you see the light now? So I think that's the procedure where you can, slightly dislodge these bubbles, and the patient becomes a little. So this is 2.5 here, and the rest of the surgery is what everybody of us has been doing. I just wanted to show the smoothness of this, the software and the 1.2 software and the spot spacing. So. I think to me the magnitude of suction has also seems to be quite reduced. Now you can see this, the different the signs that have been explained. I mean, you can see the edge here, right? So I'm underneath. So I just first go underneath this. You want, I can magnify also.
The magnification is a little less. If you can increase the magnification, it will be, yes. No, that's okay, that's fine.
Earlier one was better. Yeah, this one.
This is fine.
This is also fine. Okay, perfect.
Beta light में देखना, light में देखना हिलना नहीं आपको. So actually you can see now I am underneath the cap, and now I am underneath the lenticule, right? So beta saline देंगे, cornea dry. Light में हिरल, light में बेटा, light में. अब important है आपको move नहीं करना. हिरल chin up करेगा. But just look in the light बेटा. Don't move हिरल. Hiral, if you move.
So Dr. Sonu is dissecting the now anterior layer or the.
हिलना नहीं हिरल, हिलना नहीं बेटा.
The sort of a windshield wiper movement is dissecting.
So I use this instrument, move left and right. I am underneath the cap. बेटा हिलना नहीं आपको, हिलना नहीं बेटा. Chin up करेगा, चेहरा टेढ़ा कर रहे हो आप. Don't move बेटा. Look in the light. Look in the light बेटा. Look in the light. Don't move. Now I am underneath the lenticule. बेटा हिलना नहीं, हिलना नहीं बेटा. हिलना नहीं बेटा.
But I could able to see very smooth dissection, especially with the Visumax 800.
हिलना नहीं है.
So no.
Yeah.
Effortless you are doing.
So exactly that is the point that I want to emphasize. बेटा light में देखना है, light में देखना है. And I think we have Gaurav here, and I think he has taught the world the wonderful technique of what is he calls at the hydro
Injecting
expression.
the fluid, hydro.
I think that is a wonderful technique which he has, given to us, because actually you don't need to manipulate inside the chamber. So I have dissected. बेटा light में देखना है आपको, light में देखना है, हिलना नहीं बेटा. So you can see this girl has something which is called the the green iris. So you can see
No,
the
no,
lenticle.
it is, yeah, much easier to see. That's what we were discussing.
Yeah.
Had it been a brown eye,
Yeah.
we would have not been able to see any
That
dissection.
is what I want to actually emphasize, that you can, actually see.
Yeah, because
sort
it's
of
light
magnify.
iris, you can still make
Beta
out
Hillani,
the
Hillani.
cap dissection, the lenticle
So
dissection.
you can see
Perfect
this.
case, Sonu.
You can see the lenticle here, bit of forceps. So they can have a tag here, and then it can be just, and you have everything intact here. Beta hilla nahi, cannula beta, saline. Hilla nahi beta. So this is the complete lenticle that you have.
Excellent, excellent.
That's a
Excellent,
wonderful
Sonu.
display
Fantastic
of surgical
surgery.
skills, huh?
So this goes to Rohit
I'm
Shetty
saying
in
it's
his
a
lab.
wonderful display of surgical skill.
You send it to Bangalore,
Yeah.
Grow Lab.
This is shipped to Bangalore.
Yeah. Have you store? Cryopreserve it?
Yeah, he has set up a cryo machine with us.
Yeah.
So I think that's the end of the surgery. And so, three key features. I think suction loss, what I say, 15 to 28 seconds is the maximum time where 50% of the the suction losses usually occur. Then the cyclotorsion is being taken care here. You have on the joystick, since this patient didn't have actually the cylinder, we couldn't demonstrate. But what is important is with the movement of the joystick itself, you can actually rotate. So can we demonstrate that also?
So Sonu, we have to tell companies not to come with newer and newer versions. First make a version.
So congratulations, beta.
Which has adhesions, then make one without adhesions.
So Hiral, can you just sit?
And then charge heavily
Sit.
for it.
And just see your experience. Close your right eye. And just see. Just see in the monitor. Can you see your face in front? Right eye close karoge aap haath se? Can you see your face? So was it painless? Did you feel pressure in your eyes? So I think we would always prefer to do 100% of the cases on the smile, but actually I think more than
Sonu, sorry, Kudlu here. First of all, congratulations. This is the first time in live surgery under Visumax 800 in India. I want to tell people over here, congratulations.
So actually, I think Zais was sharing me. I think Shri Ganesh has done a live surgery on 800. So maybe, I mean,
Live, whereas I am part of every size meeting. I think this is the first time you are doing in India.
So actually that is not important. What is important is to get the best technology and showcase the best technology. So I think three key features which has really worked for me is the time 8 seconds. So 220 eyes that we have done, not even a single patient. It's just the time you start talking to the patient and the procedure is over. So I think that is one very important factor where you actually, you're conscious of the suction loss. I think that is being taken care. The second is I can take care of dilated patients as well. And the centration is very important because actually it's centered right on the visual axis. So the angle kappa is being taken care. And they say with the Atlas, you can, on the XY, you can actually calculate out how much is the, the XY deviation of the visual axis. And this goes directly into the system and automatically it will take care of the centration of the treatment. So I think that is one important which takes care of all those aberrations which are being induced. And the third is on the fly with this, the joystick that you have those Myers. So these Myers can be tilted onto the desired axis. So once you have dogged, once you apply the suction, then you can rotate the joystick and you can actually align the desired axis. So if you have a pre-marked cornea where you have a small element of cyclotorsion, usually 3 to 4 degrees, and actually it works great for high cylinders. So we've treated up till 4 cylinders, a small study that we are getting for 220 eyes, actually the HOA have considerably reduced. So the refractive error has been taken care, the SIL has been taken care, and there has been, the study says the HOA has also gone down. So I think all in all this translates into an excellent visual quality day one. And I think less suction time would be good for ocular surface also. So I think Namrata ma'am would agree that when your suction is less, your dryness and all those parameters are less. So I think it actually tends to give you a more healthier the ocular surface and the better healing. So all in all, this system has really worked well with us, and I think this will be a game changer in the femtosecond lenticle platform. So yes, actually we were looking at hyperopia, and we were trying to fix those patients. We tried to book those patients, but they say by if anybody can comment from the Zeiss team here, I think we have Priya and a lot of the senior faculty and sitting here. Can you address Rajan here? So can Rajan give us?
Can't hear you.
Can't hear you.
So Rajan is trying to say that there is no deadline what the factory has given to them, but every time it could be 2 to 3 months for the last 1 year we have been listening to this. So anytime a lot of studies which I talked to Dr. Rupal, I think they've already been done, and I think it's just to and it just needs a software upgrade.
You're from Zeiss. Yeah.
So Dr. Sonu, this is Dr. Nalini here.
Hi ma'am, hi.
So that's an excellent piece of surgery there, and we would just like to know what makes it so fast. The 500 system and the 800 system,
So
the
I think
difference between the two.
Yeah.
And so 500 runs at a speed of 500 hertz, right?
Yeah.
But 800 seems to be running at 2000 hertz.
Yeah.
So that makes it really fast, and therefore it reduces the suction time. Could we hear a little more about that from you?
Yes, one or two words about Priya. Just she wanted to give you told her to give her. Yeah, talk.
Just to answer that, we foresee in next 9 to 10 months. So we'll be launching the software.
Sorry, come back again, Priya.
9 to 10
9
months.
to 10 months, sir.
Okay.
For the hyperopia software.
So yeah, Dr. Ramamurthy says it's the gestation period, I believe. 9 months.
So I think, Sonu, we come to the end of the...
End of the surgery for keynote speaker by none other than Dr. Debash.
Thank you so much.
Wonderful surgery, Sodan.
Thank you.
Congratulations.
Thank you. Thank you.
Thank you. It was a wonderful live surgery session. Next, I would like to invite Dr. Debasis Bhattacharya ji, who is a great clinician, teacher, and person. And he'll be giving a keynote lecture on affordable quality eye care, the way forward. Welcome, sir.
Good evening, everybody. It's always a pleasure to be in Jaipur amongst friends, and especially Dr. Sonu Goel and Anand Hospital. Of course, this is the first time that I've come to Sonu's program. So essentially, I changed the topic a little bit because we are more cataract oriented at this point of time. So that's what we do in Disha. We try to provide good quality surgery in high volumes, and obviously it comes at a very affordable rate. And this financial year, let me share with all of you that we have done 100,000, 1 lakh paid cataract surgeries. So, maybe a pent-up demand of COVID or something, but the ticket size of the average cost of these surgery would be 20,000. If you take the total revenue divided by 1 lakh, so the cost of one surgery comes to 20,000 rupees. So this has been, we are also celebrating the 25 years, and this has been our growth of cataract surgery. You can see the dip in the 2020 where we came down to 55,000 cataract surgeries and then went to 81, 82,000. And this year we did 100,000, another 13 days to go. So that was good going. And essentially this was a respect to the aspirations of the common people who wanted quality cataract surgeries. Now when we do good cataract surgeries for the community and they pay and participate in it, I think you can well follow if you compare the GDP of the West Bengal, which is the blue line, and our cataract average ticket size, it kind of flows in one flow right from 97 to this date. And essentially it has a much bigger impact in the sense that, I mean, if today or this year, the vision at operation, which we are very sensitive about, it is one thing that we always monitor. The vision that the patients had prior to cataract surgery, the average was 72% last year, which has grown up to 79%. So again, that 7% change also makes a big offering to the community. Now, if we get patients early with less visual loss, so they would not only come for cataract, they would come with glaucomas, diabetic retinopathies, AMDs, vascular retinopathies, everything. So essentially the diseases which we would like to attend early would come to us, and that would have a sincere impact in the community comprehensive care. So these are the operation theaters that we operate on. We have 28 of them, and across 18 centers where our family of 102 doctors now operate these 100,000 cataract surgeries. And it's a system flow, like the assistant and the floor staff does their job. So is in the dirty corridor the lady waiting. So they usually, this is a center, this is our main center where we do 25,000 surgeries a year. So every month we do about 2,500. Every day about 100 surgeries. So this, the instruments don't wait. They come to the cleaning area immediately because, you know, otherwise all this visco and cortex and everything sticks, and you clean the instruments, pack it up immediately. The hand pieces, we use 6 or 7 depending upon the surgeon. Some surgeons are fast enough, so they operate 7 or 8 cases an hour. So we scrub once in an hour, and in between we use double gloves, and that's how we prevent cross infection and gown. And so also is it with the assistant. In the next video, I'll tell you how we go about doing these things. And in the peripheral centers, we are also in the districts. So there, all these, the tick marks in the autoclave line, the packaging line, and everything are seen through. And of course, I would not recommend this for single practice which is not a surgery center, because unless you are doing high volume, unless you are doing 2000 cataract surgeries in a theater, I mean particle counts and air sterilization is not as important. But here 50 patients are coming in and out of the theater in a period of say 4, 5 hours, 6 hours. There we really need air sterilization. And actually it's more about the particles, because microbes are all over. I mean, if 3 people are there in the operation theater, it's full of microbes. But microbes can't move in the lab, even if there is an air column. What moves are the particles. So the microbes sit on the particle, and that gives the mobility, and it can sit on the table, on the keratome, and that gives the access to the eye. This is how we change in between surgeries. So the first thing that the assistant does is remove the tip and sleeve, and we put 6 or 7 sheets depending upon who the surgeon is, like whether they are operating 7 an hour, 6 an hour, kind of stuff. And then he removes his gloves, and then he goes on to change his gloves, and the surgeons also doing the same. The patients being taken off the table, the next patients come in, and the surgeon also has degloved and is using his next pair. And now in between this 1 hour change time, the assistant actually prepares an alicot, because as I'll show you later, we use Heal-On alicots to load the lens, then a viscoat coating for the endothelium, and HPMC, maybe Xylocard, intracameral, and Vigamox. All this is preloaded, and these 5 injections are pre-prepared for the 7 cases. So those are the injections you can see, and so we are ready for the round off. This is a change. So this entire time takes about 1.2 minutes. Now another thing, most of us have these conventional phaco machines, and in eye face or the chamber stability with a hard cataract, where you want the chamber to be stable and the pupil to be not to collapse and shrink. So we use this continuous irrigation mode. I don't know how many of you use this, because when we are doing with a conventional phaco machine, not active fluidic machine, in the non-committal time, generally we are in foot position 2, not in foot position 1. And what we do is we actually keep on aspirating the visco, and this actually disturbs the milieu, because in a conventional phaco machine, the wounds would leak a bit, and you can't have the active fluidic closed chamber, tight chamber thing. So what we practice is we keep the continuous irrigation mode, and we go right from 0 to 3 or 2 as required, and whenever we are not doing anything, suppose rotating the nucleus or say dividing the nucleus in, you'll see the procedures, we are in foot position 0. So, and then again this continuous irrigation helps, because the youngsters, or the learners, they suddenly withdraw the probe if there is a PC rent, and the chamber collapses. But if it is a continuous irrigation, even if they do that, and often, sometimes, even the experience we've seen, the commonest time that we have a PCR is probably when we are taking up the probe, where the sleeve is half in, and the opening of the sleeve is in the incision, corneal incision, and then suddenly that thing happens. But if we are doing it in continuous irrigation, probably that doesn't happen. So just to take you through in the next 1 or 2 minutes, 1.5 minutes, this surgery. This is continuous irrigation on. So please see that here is 3 and now it's 0. So while coming back, it's 0, absolutely. And here. So now in rotation time again, it's 0. So that's how the viscoelastic that has been given and loaded in the anterior chamber is just there, and there's no turbulence of the fragments because they won't try to fly here and there because we have preserved the viscoelastic all through the procedure. So this is a good thing we would like to share with you. You can do it. I mean, because generally it's very easy. It's just that when you're doing something, go to 2 or 3. You're not doing anything, just go to 0. Just lift off your foot out of the paddle. So that's what is here. And you can really work with high parameters, maybe 500, 600 vacuum, 40, 50 flow rates with a conventional machine with this viscotamponade. So you saw those air bubbles which were still there. So this is how the whole thing works. And the another little thing that we wanted to share, that now we're going 2.2, and sometimes we're also using this balance tip, but with an infinity machine or a conventional machine to support, with 2.2, the irrigation falls short. So you can have a third port. We can just punch it with a small, trabeculectomy punch, and this gives additional fluidics into the entire system, which helps. And as I was talking to you about our lens introduction technique, we do hydroimplantation and we load the lens with Hilon. See the Hilon and actually see how easily, as Dr. Ramamurthy was also demonstrating in the ICL case, how easily it comes out. And I can tell you it isn't costly because, Hilon is at what, 1200-1500 rupees, and for each loading you would only spend 100 rupees. So, in a bulk situation where you're doing 15 surgeries a day, opening a Hilon for lens loading, it costs only 100 rupees for a patient. And actually what it does is, of course, Arun shared a very nice thing with me. What it does is, if you are loading it with HPMC, in the haptics, it's very difficult to clear that part. And that is in the bag. And the bag, almost in the next 2-3 days, fuses. And then that is a closed compartment. And that is why the patient, may not be that comfortable, thoda upar dard ho raha, irritation and that kind of stuff. But if that visco is gone, what Arun shared with me, I'm sharing with you, is that he dilutes the HPMC and with BSS and loads the lens with that. So yeah, fair chance that could also clear off easily and give you. Another thing which Haripriya did is something which we do routinely, that we go behind the lens and just flush the posterior capsule of the fibers, and this gives us very low PCO rates and also cleans the bag of any viscoelastic that we have left behind. We need to keep a clean bag post-op, and that would help both in the post-operative comfort and also in getting less PCOs. So these are a few things of high volume surgery that we wanted to share with you. Thank you for your attention. Thank you very much.
Can we all stand up for sir, please, for a standing ovation? This was truly a very inspiring talk, and what Sir has done in Calcutta, I think, is something that we all should be proud of, and something that is worth emulating by everybody. That sort of a model, like Disha sir, is very difficult to have and very difficult to sustain. And I believe now you're coming up with a super specialty hospital also. So many congratulations for that, sir. Multi-speciality.
Thank you, sir. I would like to request Dr. Namrata and Dr. Arun to give the certificate to Dr. Debasish. And thank you, sir, for blessing us with such a wonderful lecture. Soon we'll follow the inauguration ceremony, so I would like to all to wait for a few minutes.
जिसकी ऑडियो चेक कराना इस यहाँ से खोल लो
Good evening, ladies and gentlemen. I request all of you to please be seated. Our chief guests have arrived. Kindly please take your seats.
बोल स्पीक मेरे मोबाइल से ले ले भाई क्योंकि तुम्हारे पास भी वन प्लस है टीना के बारे में बोलना है टीना टीना Ladies and gentlemen, we have our honorable chief guest. Can we have a round of applause, please? Mr. Mahesh Joshi ji.
अच्छा बस प्ले करना नेक्स्ट करना बैक करने से वीडियो आ जाएगा नेक्स्ट करने से वो आ जाएगा A very good evening, ladies and gentlemen. We are waiting for our guest of honor. So we start with the proceedings. Namaste, Adab, Khambagari, from this land of sand dunes, forts, palaces, kings and queens. And in this hall today we have kings and queens all over India. Our invited guest faculty, they are the topmost surgeons, and we are experiencing this ophthalmic fiesta for the next 2 days. Honorable Chief Guest, respected Director Sir, all the invited guest faculty, myself, Dr. Shanai Mukherjee, and it is my pleasure to welcome you all to Festival du Film Dunes, where we are celebrating the 23rd Founders Day of Anand Eye Hospital under the Aegis of Jaipur Ophthalmological Society. Also with the launch of Visumax Smile Pro. We have also introduced the AI power of virtual assistant Tina in our hospital, which is the first AI virtual assistant in Rajasthan. I wholeheartedly welcome all the delegates across the country, east, west, north, south. We have all of them amongst us. And to start with the proceedings, I would like to project a vision of a man, a single man who, with a single chair practice, who started his dream 23 years ago, and today he is now set up the leading hospital of Rajasthan. A small video clip of Anand Eye Hospital and Dr. Sonu Goyal, this man's vision towards further and scientific and further innovations in ophthalmology. A very small video clip, Anand Eye Hamari Shaan. Thank you so much for your patience.
Now I request our director, sir, Dr. Sonu Goel and Dr. Rajkumar Sharma, sir, to kindly welcome and escort our chief guest, Mr. Mahesh Joshi ji, Honorable Cabinet Minister, PhD, Government of Rajasthan. Something we all would like to know about him. He is Honorable Cabinet Minister, PhD, Government of Rajasthan. Jaipur born. He is a PhD holder in Social Sciences from Rajasthan University. PG Diploma in Journalism. Member of Parliament in the 15th Lok Sabha constituency, 2009 to 2013. Member Parliamentary Consultative Committee in External Affairs, 2009. Transport and Tourism and Culture. And many more representations under his banner. A big round of applause for him, please. Now I would request Dr. Mukesh Sharma, sir. I'm sorry. Now I request Dr. R.K. Sharma, sir, to kindly hand over a bouquet to our honorable chief guest, Mr. Mahesh Joshi ji. Dr. Sonu Goel, sir, to please present a safa or a turban to our chief guest. Professor Dr. Indu Goel, please come up on the stage and honor Mr. Mahesh Joshi ji with a shawl. Now we move forward to the lightning ceremony. I request our chief guest, Dr. Sonu Goel, Dr. Indu Goel, Dr. Mayank Agarwal, Dr. Mukesh Sharma, Dr. R.K. Sharma, to kindly come up on the stage and please light the diya. Thank you, everyone. I request Professor Dr. Indu Goel to please come up on the dais and to speak a few words.
Good evening, everybody. This is a moment of great pleasure to have all the dignitaries on the dais and so many ophthalmologists, such a good surgery, I am so proud to have you all. Thank you so much for coming. Thank you so much.
Thank you so much, ma'am. I would now request Dr. Rajkumar Sharma, sir, to please come up on this dais and speak a few words.
Good evening, everybody. Welcome to this show. And at the same time, I welcome Dr. Sudhir Bhandari, sir. Welcome, sir. So, continuing with the same, I welcome you all. Shri Mahesh Joshi ji, our Honorable Minister Sahab, who has been very kind to us and has spared his valuable time. Dr. Sudhir Bhandari sir. And at the same time, I would like to congratulate Dr. Sonu Goyal and his team for organizing such a wonderful film festival and a very apt name, Festival du Film Dunes. I had to search for the French into the French dictionary. What does this exactly mean? So it says it is an ophthalmic film festival in the sand dunes. Is that right, sir? So I welcome you again and hope you will enjoyed the show today and will enjoy tomorrow also. Thank you.
Thank you, Dr. Rajkumar, sir. Now, I would request Dr. Mukesh Sharma, sir, President JOS, and Dr. Mayank Agarwal to please honor our chief guest of honor, Dr. Sudhir Bhandari, sir. Dr. Mayank Agarwal, can you please give a bouquet? Dr. Sudhir Bhandari, as you all know, Vice Chancellor, RUHS. He has an academic excellence and extraordinary social service. He is a triple gold medalist with professional excellence in social work with humanitarian services, advisor and member board of management in JNU Institute of Medical Sciences, honorary physician to the Governor of Rajasthan, head of COVID-19 containment program of SMS Medical College and attached hospitals. We are very proud to have him here and one of the finest physicians amongst us. I request Dr. Mukesh Sharma sir to please come up on the stage and speak a few words.
Respected Dr. Mahesh Joshi ji, Honorable Minister, Professor Sudhir Bhandari ji, Vice Chancellor RUHS, other dignitaries on the dais, distinguished faculty from wide and far corner of the country, and all the delegates. It gives me immense pleasure to welcome you all today here on behalf of Jaipur Ophthalmological Society and also from Anand Hospital on this very unique, I should say, conference. It's a film festival wherein we are enjoying surgical live videos of various distinguished faculty from our own Jaipur, Rajasthan, and also from the country. This is primarily a baby of Anand Eye Hospital and Dr. Sonu Goyal, who has really worked hard for this conference and success of this conference. I must congratulate him. So it is because of his own stature so that he can invite and involve such a wide galaxy of faculty from all over the country. So I think he deserves a great lot of applause from all of us. With these words, I once again welcome you all on this very conference and this film festival, and I hope that tomorrow also we shall enjoy a very good, wonderful scientific fiesta. Thank you.
Thank you, Dr. Mukesh Sharma, sir. Now I request our director, Dr. Sonu Goyal, to please come up on stage.
So without wasting and without taking much of time, I'd like to welcome Shri Mahesh Joshi Sahab. साहब का मिल मिलना ही बहुत दुर्लभ है और एक सिंगल मीटिंग में ही सेट कि जब जितने समय जहाँ पर जैसे एंड ही वाज वेटिंग फॉर अस टू इनवाइट, तो 7:45 से घर पर बैठे हुए एंड वेट करें. थैंक यू सो मच सर, वी आर रियली ऑनर्ड टू हैव यू हियर एंड आई थिंक राजस्थान हैज़ स्पेशल रिगार्ड्स फॉर यू. जितना एफिशिएंट और आपका कर्तव्य निष्ठा से आपने कार्य करा है अपने कार्य क्षेत्र में सर, ये सराहनीय है और जयपुर के लिए आपने बहुत योगदान किया है. हम बहुत आपके लिए बहुत आभारी. शुक्रवार. Respected Dr. Sudhir Bhandari sir, and I think he needs a great round of applause. All these COVID years, I think Rajasthan, Jaipur and SMS was the best in managing COVID all throughout the state. And it was a single man show and it is his face, Dr. Sudhir Bhandari. Without fail, he was there morning 7 to late night 12, meeting ministers, meeting and taking one-to-one all, and he took right from the front. And I think it is him who could do this in India. So congratulations, sir, for making us that COVID-free. So RUHS University is blessed to have him as their Vice Chancellor, and we are really blessed. Any problem that we have, he has a solution immediately. Thank you, Dr. Mukesh Sharma, for being with us as President JOS. Your support has always been constant. Dr. Mayank Agarwal has been a very, very helpful man, and without fail, always he has been there as Secretary JOS. Dr. Rajkumar Sharma has always been like an elder brother, and what a personality he is, always ready to take on his back. My wife, Dr. Indu, has always supported me, and I think the back part of the leg surgery was always being taken care by her today. Dr. Ratnesh Sharma as the scientific chair, I think I am thankful to LVP to, groom such nice consultants, and amazing. He's a great asset to Anand. I would fail to thank my esteemed faculty. I mean, I don't have words for Dr. Debashish Bhattacharya, who traveled all the way from Calcutta on a single phone call. Such a busy man, and to travel here. Dr. Namrata Sharma, Professor, RP Center, Secretary IOS, on a single phone call to be with us for 2 days. Dr. Ramamurthy, sir, traveling all the way from Coimbatore, when his parents and in-laws are just recovering from illnesses. Thank you so very much, sir. Dr. Gaurav Luthra, Dehradun, Dr. Anand Parthasarthi, Dr. Anaga Harur, Dr. Amit Porwal, sir, and the chief of Arvind. I don't have words for Dr. Haripriya, such a nice surgeon, sparing the valuable time for us, and many more, Dr. Saurabh Luthra, Dr. Anurag Mishra, and I'm really thankful to you guys. And then our state faculty from Ajmer, Dr. L.K. Nepalia, sir, Dr. Arun Kshetrapal, then Dr. Ghulam Ali from Jodhpur, and then we have Saurabh Bhargav from Bikaner. I think Dr. Anil Kothari from Udaipur. I think thank you so much. And our own faculty from Jaipur, the entire Jaipur Ophthalmic Society who has been with us, Professor Dr. Malhotra sir, Dr. R.B. Goel sir, and Professor and Head of SMS, Dr. Pankaj Sharma sir. So I think all in all, I am really indebted to the entire faculty who has been with us and who has spared your valuable time. You have contributed to the academics, for which this whole show was. And my bent has always been to showcase the latest and the best amongst our colleagues in the state. And that's what we have. And thank you so very much for making all the show up till now really successful. I'm really indebted from, and this comes from the core of my heart. Thank you so much.
Thank you so much, Dr. Sonogal, sir. Now I would request Mr. Mahesh Joshi ji to please come up on the stage and please speak a few words for us.
डॉक्टर साहब, आपके लिए क्या संबोधन करूं भंडारी जी के लिए। मैं भी कह रहा था भंडारी जी को कि आप जयपुर के ही नहीं, राजस्थान के सारे डॉक्टर्स के भीष्म पितामह हैं। एक ऐसा निर्विवाद व्यक्तित्व, मैं नहीं जानता आपका क्या अनुभव है, लेकिन मैंने कभी डॉक्टर भंडारी जी को गुस्से में नहीं देखा। एक बार मैं इन पर नाराज भी हुआ कोरोना काल में, और इतना नाराज था कि कॉन्फ्रेंस में चला गया। मैंने कहा आप बाहर आइए, लेकिन फिर मुझे ध्यान आया कॉन्फ्रेंस चल रही है। मैंने कहा नहीं, आप स्पीच खत्म करके आइए। लेकिन डॉक्टर साहब के चेहरे पे शिकन नहीं, जिस पोलाइटनेस से समस्याओं का समाधान किया, वो दिन मुझे आज भी याद है डॉक्टर साहब। और अभी विधानसभा में डॉक्टर साहब पे किसी ने कुछ छींटाकशी करने की कोशिश की, एक एमएलए ने, अभी बजट सत्र के दौरान। कल मुख्यमंत्री जी ने उस एमएलए को बहुत डांट लगाई, ये मेरे सामने की बात। तो डॉक्टर साहब, आपके लिए, आपकी सेवाओं के लिए शब्द भी कम है। जो आपने राजस्थान में स्वास्थ्य सेवाओं को ऊंचाइयां दी हैं, ये गवर्नमेंट का तो काम है। पूरे राजस्थान में जो कुछ हो रहा, उसके पीछे प्रेरणा पुरुष मुख्यमंत्री अशोक गहलोत जी हैं। लेकिन वर्किंग हैंड भी चाहिए, जो काम कर सके, जो काम को साकार कर सके, और ये सोच के करे कि भाई ये काम मेरे काम आएगा या नहीं आएगा। एक शेर याद आता है मेरे को कि तामीरों की खातिर कब देखे हैं हमने ख्वाब, तामीरे दुनिया देखेगी, हम देखेंगे ख्वाब। कि जो जिस चीज को हम बना रहे हैं, तामीर कर रहे हो, हमारे काम आए कि नहीं आए, वो अगली जनरेशन के, दूसरों के काम आनी चाहिए। आज एसएमएस में आप नहीं हैं, आप वीसी हैं, लेकिन एसएमएस की एक एक ईंट आपको याद करती है। तो मैं बहुत खुश हूं कि आज आपने यहाँ डॉक्टर भंडारी जी से मुझे मिलने का मौका दिया। आज जिनके कारण मैं यहाँ आ पाया, डॉक्टर सोनू गोयल जी मेरे पारिवारिक सदस्य हैं, डॉक्टर आर.के. शर्मा जी परिवार के सदस्य हैं, मुकेश शर्मा जी परिवार के सदस्य हैं। इसलिए जब सोनू जी परिवार के सदस्य हैं तो इंदु गोयल जी स्वाभाविक रूप से हैं। डॉक्टर रत्नेश शर्मा जी, डॉक्टर मयंक अग्रवाल जी, डॉक्टर नम्रता जी, डॉक्टर देवाशीष जी, डॉक्टर हरिप्रिया जी, और दूर दूर से आए सभी डॉक्टर साहिबान, प्रतिष्ठित गणमान्य अतिथिगण, भाइयों और बहनों। एक ऐसा विषय जो जुड़ा तो सबसे है, मेरे से भी जुड़ा है, मेरे जैसे दूसरे लोगों से, एक एक आदमी से जुड़ा हुआ है, लेकिन उसके बारे में ज्ञान कम है हमको। ज्ञान आपको ज्यादा है। हम सब आंखों से देखते हैं, लेकिन आंखें क्या है ये ज्ञान आपको है। ये इतनी बड़ी सेवा है कि हालांकि अब जमाना बदल रहा है। हम जिन लोगों में कोई जन्म से कोई विकार है, कोई कमी है, उसको हम कमी नहीं बताते हुए उसको विशेष दर्जा दे रहे हैं, दिव्यांग कह रहे हैं। लेकिन आंखों का क्या महत्व है, ये जिसकी आंख रही हो और फिर उसकी आंख चली गई हो, वो महसूस कर सकता है। कि मेरे एक दोस्त हैं ऐसे, मेरे साथ पढ़ते थे, बहुत वर्षों तक उनको पूरा जैसे सबको नजर आता था, और अचानक धीरे से कुछ ही दिनों में उनकी दृष्टि चली गई, और बीमारी ऐसी बीमारी जिसका कोई इलाज भी नहीं। वो महत्व समझ सकते हैं कि आंखों का क्या महत्व है, नजर का क्या महत्व है। और आप लोगों को नजर लोगों की सुधारते हैं, लोगों की आंखों की रक्षा करते हैं, लोगों को इस काबिल रखते हैं कि वो लंबे समय तक, क्योंकि आज जिस तरीके से प्रदूषण है, जिस तरीके से दूसरा माहौल है, आंखों के लिए भी वो सब खतरा है। स्वास्थ्य के लिए खतरा है, और आंखें स्वास्थ्य से अलग नहीं हो सकती। वो आंखों के लिए ज्यादा बड़ा खतरा है, क्योंकि सबसे ज्यादा नाजुक चीज अगर प्रदूषण की कांटेक्ट में कोई चीज आती है तो हमारी आंखें हैं। आप उनको दुरुस्त रखते हैं, ठीक रखते हैं। और मुझे बहुत खुशी है कि आप आज यहाँ पे लाइव सर्जरी भी इस कॉन्फ्रेंस में आप करेंगे, आप लेजर भी करेंगे, और फिल्म फेस्टिवल भी होगा। ये हम सब के लिए गौरव की बात है, जयपुर वालों के लिए, कि ये कॉन्फ्रेंस जयपुर में आप कर रहे हैं। जयपुर ऑफ्थल्मोलॉजी सोसाइटी और आनंद आई हॉस्पिटल की तरफ से मुझे यहाँ आप सबका अभिनंदन करते हुए, स्वागत करते हुए बेहद खुशी है। और मैं उम्मीद करके चलता हूँ कि यूं राजस्थान में डॉक्टर साहब हम बहुत कर रहे हैं, लेकिन अभी हमें आई के मामले में और भी ज्यादा, ऑफ्थल्मोलॉजी के मामले में और ज्यादा कोई करने की जरूरत है। ऐसा कोई बड़ा सेंटर जो लोगों की सेवा करे, जैसे साउथ में कई सेंटर हैं और कई जगह पे सेंटर हैं, हमारे यहाँ भी एक ऐसे सेंटर की जरूरत है। और मुझे विश्वास है कि डॉक्टर साहब आप पहल करेंगे तो वो सेंटर भी बनेगा। सारे डॉक्टर साहिबान आई वाले यहाँ बैठे हैं, ये सब पहल करेंगे। हम सबके लिए बहुत खुशी की बात है कि ऐसा कोई सेंटर बने जो हम ये कह सकें, हमारे डॉक्टर्स पे हमको गर्व है, राजस्थान के आई वालों पे भी गर्व है और दूसरे डॉक्टर्स पे भी गर्व है। अभी मुझे SMS एलुमनाई के प्रोग्राम में जाने का मौका मिला। मैंने कहा कि हमारे जयपुर की SMS की जो शान पूरे देश में फैली है और राजस्थान की स्वास्थ्य जो स्किल है डॉक्टर्स की, वो पूरे देश की स्किल को सबसे ज्यादा मान्यता दिलाने में अगर किसी एक मेडिकल कॉलेज का योगदान है तो SMS मेडिकल कॉलेज है। दुनिया भर में SMS मेडिकल कॉलेज के लोग अपनी प्रतिभा से लोगों की सेवा कर रहे हैं, चाहे अमेरिका हो, इंग्लैंड हो, फ्रांस हो, जापान हो, कोई देश हो, कोई ऐसी जगह नहीं है जहां SMS मेडिकल कॉलेज का कोई न कोई यहाँ से पास आउट डॉक्टर सेवा नहीं कर रहा हो। तो हमें इस बात का गर्व है। बाहर से आए जो डॉक्टर साहिबान हैं, आप लोग भले आई के हैं, लेकिन स्वास्थ्य सेवाएं सब एक दूसरे से जुड़ी हुई हैं। मुझे गर्व है कि जयपुर में SMS मेडिकल हॉस्पिटल है, मेडिकल कॉलेज है। स्थिति यह है, किसी लावारिस को भी अगर आप SMS हॉस्पिटल के बाहर कोई छोड़ जाएगा और अगर वो ठीक होने की स्थिति में, तो आप मान के चलिए वो ठीक होकर ही निकलेगा वहां से। इस बात का हम दावा करते हैं। स्वास्थ्य सेवाओं में जो निरोगी राजस्थान का सपना मुख्यमंत्री जी ने देखा, जो चिरंजीवी स्वास्थ्य बीमा योजना मुख्यमंत्री जी ने लागू की, जिस तरीके से पिछला उनका कार्यकाल था, पहले उन्होंने मुफ्त दवाएं शुरू की, फिर मुफ्त जांच शुरू की। इस बार उन्होंने उससे आगे बढ़ते हुए निरोगी राजस्थान का सपना देखा और फिर मुख्यमंत्री चिरंजीवी स्वास्थ्य बीमा योजना लागू की। 5 लाख रुपए का बीमा हर परिवार को, फिर लगा कि 5 लाख कम है, 10 लाख रुपए का बीमा हर परिवार को। और बीमा उस रजिस्ट्रेशन शुल्क क्या है, 850 रुपए। उनको लगा ये भी कम है, लोगों के घर बार बिक जाते हैं बीमारी का इलाज कराने में। उसको इस 1 अप्रैल से 10 लाख को बढ़ा के 25 लाख रुपए का बीमा देने जा रहे हैं। और जो नहीं देने की स्थिति में 850 रुपए, उसका रजिस्ट्रेशन शुल्क भी हम लोग देने को तैयार है। साथ में 10 लाख रुपए का एक्सीडेंटल क्लेम। हमारे कार्यकर्ता की एक रैली में डेथ हो गई थी डॉक्टर साहब, उसमें उसको 5 लाख रुपए का तुरंत हमने एक्सीडेंटल क्लेम दिलाया। दूसरा घायल हो गया था, उसका इलाज कराया। बेहतरीन तरीके से, अविश्वसनीय तरीके से सेवाएं राजस्थान में मेडिकल साइड में हो रही हैं। हम लोग बहुत गर्व के साथ ये कह सकते हैं, कोरोना काल में भी हम लोगों ने सेवा की, बहुत शानदार तरीके से सेवा की। हमारे पास संसाधन कम थे और हमारे पास क्या, कोरोना के मामले में तो दुनिया में कोई नहीं जानता था कि कैसा वायरस है, क्या इसका इलाज होगा। फिर भी हम लोगों ने राजस्थान में इतनी बेहतरीन सेवाएं की, हम लोग किसी को इलाज से वंचित नहीं रहने देंगे। मुख्यमंत्री जी ने घोषणा की, न तो इलाज से वंचित रहने देंगे, न किसी को भूखा सोने देंगे, क्योंकि लॉकडाउन हो गया, कर्फ्यू लग गए, बहुत सारी परिस्थितियां थी। हम सब लोग राजस्थान में मुख्यमंत्री अशोक गहलोत जी के नेतृत्व में उन सेवाओं को लोगों को मुहैया करा सके, लोगों को हम स्वास्थ्य सेवाएं दे सके, कोरोना से बचा सके। तो इसी तरीके से मैं उम्मीद करके चलता हूं, आज की जो सेमिनार जो आज शुरू हो रही है, इस सेमिनार के आज शुरू है कि आज पूरी है? शुरू है ना। आज 2 बजे से आपने शुरू, 2 बजे से की। आपके जो सब्जेक्ट जो सेशंस होंगे, उनमें आप निश्चित रूप से उनसे हम लोगों का भी ज्ञान बढ़ेगा। विभिन्न जर्नल्स में आपके कंक्लूजन होंगे या जो पेपर्स होंगे वो पब्लिश होंगे, पूरी दुनिया को लाभ मिलेगा। और हमें इस बात से खुशी होगी कि ये ज्ञान जयपुर के माध्यम से सारे दुनिया में फैलेगा। मैं आप सब लोगों का अभिनंदन करता हूं, स्वागत करता हूं। और जो भी जो सब्जेक्ट है, ऑप्थेल्मोलॉजी है, उसके बारे में अगर किसी प्रकार की कोई अतिरिक्त सेवा, क्योंकि मैं मंत्री भी हूं, अपने क्षेत्र से विधायक भी हूं, तो हम लोग कोई सेवा कर सके, कोई जो मंच पर डॉक्टर साहिबान जयपुर के बैठे हैं वो कोई सेवा बताएंगे तो वो करने में हमें खुशी होगी। आप सबका बहुत बहुत अभिनंदन, धन्यवाद, जय हिंद।
Thank you so much, sir. Now I request Dr. Sudhir Bhandari, sir, to please come up on the stage and speak a few golden words from his mouth.
Honorable Shri Mahesh Joshi Sahab, Dr. Sonu Goyal, all the esteemed people sitting on the dais and off the dais. I extend my profuse thanks and gratitude to Dr. Sonu Goyal and team for having invited me. I'm really humbled and touched by the fine words, sir, you used. And I'm really extremely delighted and happy to be here with a galaxy. When Dr. Sonu Goyal shared the names of the galaxy of the people from field of ophthalmology are going to be here, it was very delightful to know about it. As we move from a disease-specific care model towards comprehensive eye care, there is a need for a more holistic and integrated approach involving health system. It should encompass not only the treatment but also preventive, promotion, and rehabilitation of incurable blindness. Photorefractive keratotomy, that's LASIK, and the SMILE are the most clinically effective and safe techniques for refractive surgery. All three kinds of laser versions correction while varying in technique have roughly a similar high achievement rate. Which method is best for you to rely upon various components like the refractive error, habits, and profession, for example, sports and lifestyle. Refractive lenticule extraction marks a paradigm shift in the field of refractive surgery. For conventional flap-based corneal ablative procedure to flapless extraction of femtosecond laser-created intrasomal lenticules. A SMILE proved an effective and safe refractive corneal procedure and provided a predictable and stable correction of myopia and myopic astigmatism. A SMILE technique demonstrated a very good outcome in terms of keratometric, cylindrical, spherical, and measurements. These kind of tele-festival and film festivals are going to make a tremendous impact. Brain registers what eye sees, and I think Dr. Sonu Goyal and his team deserve a lot of compliments for such kind of film festivals, which is going to make a permanent imprint in the minds of budding people from field of ophthalmology. Recent reforms of medical education highlights the growing concern about the capability of the current educational model to equip the medical school students and the postgraduates with essential skill for future career development. In the field of ophthalmology, although many attempts have been made to address the problem of decreasing teaching time and increasing load of course content, a growing body of literature indicate the need to reform the current ophthalmology teaching strategies, and I compliment you that the type of teaching strategy which you have adopted for film festival or kind of film show, it needs to be complemented. All those delegates who have come from outside the state, sir, I would like to share with you, there's a little different health model in the state of Rajasthan. It is a state where basic care is totally free and it goes up to the tertiary care. If you go to the medical college institutions, if you go to the district hospital, every possible medical treatment up to 10 lakh to begin with, and now from up to 25 lakhs is free. Those people who have come from outside the state, although not to your specialty, but I must share with you, in our institutions, the bypass is free, knee replacement is free, hip replacement is free, the stenting is free, every possible surgical procedure is free, and this applies to the procedures in the field of ophthalmology. Sir, you talked about the institute. You will be very happy to know, sir, that we have one of the biggest medical college hospitals in the country, that is SMS Medical College, with 5,000 bedded facility, with daily OPD of 17,000 people and annual OPD of 68 lakh. Recently, Government of Rajasthan had announced the Institute of Ophthalmic Sciences akin to the Shankar Netralaya in Rajasthan government domain, and it is going to be one of the finest institutions. We are very privileged to have people of all people who are sitting from Jaipur. We are very proud to have very high standard excellence in the professional services in field of ophthalmology in Jaipur. Dr. Sonu Goyal is a live example of amalgamation of professional excellence and humility. I compliment him for doing a wonderful job. Each and every one of my colleagues sitting here from Jaipur and the state of Rajasthan has absolutely state-of-art acumen, and they have brought the ophthalmic sciences to a very high pedestal. We welcome you to the city of joy, that is a touristic city with a strong culture and heritage. I'm sure with the professional updates, I was just going through the scientific contents. Probably it's so enlightening. What a state-of-art, latest cutting-edge technology which you are going to see and observe. Probably you should also have the flair of great city of Jaipur with the great history, the wonderful tourist attraction which city offers. So I once again welcome all of the delegates from outside. I extend profuse thanks to the people sitting here, and it's been a wonderful endeavor and a very innovative way of showing the cutting-edge technology in the field of ophthalmology. I wish all the best to the organizers and welcome once again to all the delegates. Thank you very much. Thank you.
Thank you so much, Dr. Sudhir Bhandari, sir. Now we start with the award ceremony. As we are doing a film festival, so you need awards, and we start with the first award. Can we have the slide, please? The first award goes to the founder chairman of Disha Eye Hospitals, a distinguished practitioner and innovator in the field of ophthalmology, a pioneer in SICS and phaco in the state of West Bengal, an ophthalmologist who emerged from a small town in the mid-1990s, Barafpur. Very quickly, he emerged as a skilled cataract surgeon to deliver high volume of sight-restoring surgeries. He stands out as a textbook example of group practice and sustained growth, all due to his vision and entrepreneurship. He has so many prestigious awards, national and international, under his name. Proud to have him amongst us, Dr. Debashish Bhattacharya. The Dunes Leadership Award. Thank you so much, sir. Moving on to the next award. Chairman of the Eye Foundation Group of Hospitals, Coimbatore, Tirupur and Ooty. Phaco-refractive surgeon with a member of several professional organizations, ex-president AIOS, chairman scientific committee AIOS, with many awards and accolades, a skilled phaco-refractive surgeon with a calm and composed nature. Honored to present him the Dunes Achievement Award, Dr. D. Ramamurthy, sir. Thank you, Ramamurthy, sir. Now coming to the Dabang lady. Professor Cornea Refractive Surgery at AIIMS, New Delhi. Honorary Secretary AIOS with more than 380 publications in international peer-reviewed journals. Authored 119 book chapters, 11 books, and she has 2 patents. Brand ambassador for the Tear Film and Ocular Surface Society. We all female ophthalmologists are inspired by her and her achievements. She is the lady, वो lady जो एक में एक अकेले ही फिल्म को hit कर देगी. On a lighter note, the Sushmita Sen of our ophthalmic industry, the Iron Lady of the world, Dr. Namrata Sharma. Thank you, ma'am. Now moving on to the next award, the lady with the Midas touch. Head of Cataract and IOL Services at Arvind Eye Hospital, Madurai for over a decade. She currently heads the Cataract Clinic She's a lady with flawless hands and she does bulk phaco surgeries. Her calm and cool nature, the lady with the golden touch, the phaco quickie, Dr. G. Haripriya Arvind, for the Dunes Achievement Award. Moving on to the next award. Medical Director, Drishti Eye Hospitals, Dehradun. Founder member, World College of Refractive Surgery. He has under his belt more than 200 live surgery demonstrations. A cool and a chilled out surgeon I have seen today in the live surgery. One of the finest surgical hands in femtocataract. Chairman Academic and past President IRSI, Dr. Gaurav Luthra, for the Dunes Achievement Award. Moving on to the next award, Medical Director, Anil Eye Hospital, ex-member, Scientific Committee, Maharashtra Ophthalmological Society, a versatile lady and a phaco surgeon with flawless hands. Today I have seen her in the live OT and she's very sweet. Dr. Anaga Herur for the Dunes Achievement Award. Moving on to the next award, a well-renowned phaco-refractive surgeon based in Cuttack, and he's been serving there for more than 20 years. Director Radharaman Hospital, Cuttack, proud to have a dynamic young phaco surgeon amongst us. He's really fast and quick. I have seen him today in the live OT. Dr. Anurag Mishra for the Dunes Achievement Award. One of the most renowned ophthalmologists based in Center for Vision and Eye Surgery, Chennai, with many accolades and honors under his belt in the academic and the scientific field, Dr. Anand Parthasarthi for the Dunes Achievement Award. We move on to the next award. Head of Dr. Om Prakash Eye Institute, Amritsar, Punjab, an experienced phaco surgeon with many years of hard work, toil and brilliance, Dr. Rohit Om Prakash. Do we have him? Okay, thank you. We move on to the next award. Director, Luthra Vision Care, President, Bilaspur Division, Ophthalmic Society, first to introduce Zepto and trifocals in Chhattisgarh. We present Dr. Saurabh Luthra with the Dunes Achievement Award. Thank you so much, sir. And we have a young achiever, Dr. Amit Porwal, a teacher, trainer, a young achiever in glaucoma and cataract surgery for more than 19 years, Head of Glaucoma Services, Shoitram Netralay, Central Zone Executive Member, Indore, and the GSI Committee. Dr. Amit Porwal for the Dunes Achievement Award. Thank you so much. Last but not the least, we are fortunate enough to have support from our trade partners. Mr. Vipin Bharadwaj, MD, Hoya Surgicals, Sharad, Sunil and Prateek, can you please come up and collect your memento, please, from the stage? Team Zeiss, Priya, Nitesh, Rajan, Vinay, can you please come up on stage? Anybody from Zeiss? Team Star, Sunil Mishra, Sumit, anybody from Star? Team Raymond, Ashish Kharbendra, can you please come up on stage and collect your mementos? Johnson & Johnson, anybody from J&J? Okay, so we proceed for the fellowship dinner. I would invite Dr. Mayank Agarwal to please come up and give a vote of thanks. Johnson & Johnson, Nishan. Team Biotech, anybody from Biotech? Can you please collect your award? Okay, thank you so much. I'll sir to please give the vote of thanks. And for now, after that, we proceed for the fellowship dinner. Sir, please.
Thank you, Sonaya. I am really delighted to have such dignitaries on the dais. Mahesh Joshi Saab, Dr. Mahesh Joshi Saab, our Honorable Prime Minister, Sudhir Bhandari Sir, Dr. Sonu Goyal, our President, Dr. Mukesh Sharma, Dr. Rajkumar Sharma, Madam Indu Goyal, and the distinguished faculty and galaxy of stars from across the India. The presentation ceremony is being concluded here, and I invite all of you to have the fellowship and dinner with us. Thank you very much for sparing time and coming and sharing knowledge to us. Thank you very much.